Am I audible and visible to all of you? Are you guys there with me? There should not be any problem. A very good morning. Let's start the day with some blessings from Lord Ganesha because of the great festival today in this COVID pandemic that we are trying to celebrate at home. Okay, Ganesh Chaturthi, right? Now let's look upon just the camera. A very good morning. All there with me? Any hassles, any problem, any crashing today? Okay. When will endocrine start? Endocrine will start when neurology will finish. Simple funda. Okay. So we were somewhere yesterday at the discussion of the introduction of the spinal cord. Let me just quickly revise with you guys. Okay. What we were trying to catch in this topic, spinal cord. Spinal cord is a transmitter like thing which takes up to the brain a signal which is sensory and takes down from the brain a signal that is coming down as motor. A sensory happens to be the ascending track and the motor happens to be the descending track to control the body. And we know this fact that there is a track which is running up in the spinal cord, right? That was known as the spinothalamic tract, which is crossing the midline in the anterior half of the spinal cord, not at the same level, one segment above. So let me draw this again. This is the thoracic 3 segment, thoracic 4 segment and the thoracic 5 segment. What we had tried to understand yesterday, that the spinothalamic tract of the thoracic 5 segment, right, is going to move up and cross the midline in the thoracic 4 segment. And then finally it will reach the thalamus. Okay. So this one happens to be the spinothalamic tract of the thoracic 5 segment on one side. Similarly, there is a spinothalamic tract of thoracic 5 from the other side, which is coming on with the pain, touch and temperature signal. And then it is going and crossing the midline in T4 and then moving up like this. So this wala is a spinothalamic tract of 3-5 from the other side, right? Spinothalamic tract of T3, right, which comes in, crosses the midline in the thoracic 2 segment, which I am not showing in the diagram. Okay. Similarly, there is a spinothalamic tract of T3 from the other side, which is going to go up a segment and then cross the midline. Okay. Similarly, we had got a posterior or the dorsal column. The posterior dorsal column did not cross anywhere in the spinal cord. Where did it cross? It crossed in medulla. Okay. So we have got a posterior column of the thoracic 5 segment now. Okay. Which is going up like this and going up like this. We all know this, it's not crossing anywhere in the spinal cord, it is crossing 1 or 2 segment above the spinal cord. Similarly, there is a posterior column of the T4 segment, okay, and there is a posterior column of the T3 segment also. Although it might look too congested for you, but it's alright if you can just write T3 and T5, that's fine. Okay, I'll just put this one. T5, T4 and T3 run parallel to one another and they do not cross anywhere in the spinal cord. They cross the midline above in the brainstem, and the part of the brainstem is the medulla where it crosses, right? Good. Now we had tried to know this also yesterday somewhere in the corticospinal or the descending tract, that there is a gate always sitting and waiting to receive the impulse, that is the anterior horn cell. Okay, so as a green dot I can make in this diagram, there is an anterior horn cell, yes, of the T3 segment. There is an anterior horn cell of the T4 segment. Similarly, there is an anterior horn cell of the T5 segment, which is basically connecting, if you remember, with the opposite cortex through a tract corticospinal. Okay, so very important thing to understand in this diagram. Apart from this, we can make a smaller one below to understand the anatomy of the corticospinal again. We have discussed this yesterday. The corticospinal tract, right, starts in the brain, comes down in the spinal cord, okay, and stops at a gate anterior horn cell, comes down in the spinal cord from the opposite brain. So I'm just trying to draw it separately for a clear understanding. If this is T3 and this is T4 and this is T5, every segment has got its own gate, the anterior horn cell, okay, for every segment. And what is this anterior horn cell connected with? It is connected with the brain through which tract? The corticospinal tract. So if I can see the corticospinal tract like this, the corticospinal tract like this, and the corticospinal tract like this. Why I'm trying to deflect it in the midline at this point? Because if you remember, medulla, the lower part, we discussed it yesterday, the corticospinal tract crosses the midline. Okay, so it is originating in this part of the brain, but it is supplying the opposite cortex because the crossover of the fibers happen in the lower part of medulla. So this one is a corticospinal tract of the T3 segment. This one is a corticospinal tract of the T4 segment, and this one is a corticospinal tract of the T5 segment. Okay. Why I'm drawing this diagram? Because I want to explain you guys this. Look at this now. If I create a hemisection, okay, if I create a hemisection in the thoracic 3 segment, please tell me, in the thoracic 3 segment, what am I losing? Am I losing the anterior horn cell or the corticospinal tract of T3? Answer my question. If there is a section in thoracic 3 segment, hemisection like this, what are we losing for T3? Are we losing the anterior horn cell of T3 by such a section, or are we losing the corticospinal tract by this kind of a section? Please tell me. Yes, not the both, not the both, not the both. First of all, let me clear this concept, it's a kind of a three-dimensional thing. For example, I can draw this as a cylindrical thing also. Okay, so just imagine spinal cord as a cylindrical thing, not both, please, my dear friend. Okay, at this point, I've got the anterior horn cell, and this anterior horn cell is connected to what? The corticospinal tract, which is originating from the opposite brain. Okay, it's a three-dimensional kind of a thing. So just imagine this, the corticospinal tract is coming, stopping at a gate anterior horn cell to become a nerve for a muscle. Now just imagine this as a three-dimensional figure, and if I cut the spinal cord, maybe complete even, what am I cutting in it? Look at the diagram, this diagram. If imagine this as a three-dimensional thing and it's coming down like this, and it is stopping at a gate anterior horn cell to become a nerve for a muscle. So if I cut it like this in that particular plane, okay, then what are we cutting in it? What are we cutting in it? We are cutting what? Anterior horn cell or corticospinal? See, the corticospinal is above the section, so it's unaffected. Remember this. But the anterior horn cell, the green dot, will be at the level of the section. So what are we cutting at this point? My dear friend, we are not cutting the corticospinal. It's cutting the anterior horn cell, not the corticospinal again. Got my point? I'll repeat this again. This is very important and a very basic concept. That if you imagine the spinal cord in a plane horizontal, right? And corticospinal is coming from above and stopping over here. If I cut it at this point, anterior horn cell is lost. The corticospinal being above it is spared. So do we have any problem with the corticospinal tract? No, we have a problem with the anterior horn cell only. So I'll just let me put this like this: T3, T4 and T5 again. Okay, correct. So let me put this here. Let me make this wala as a hemisection. Okay, let me make this as a hemisection. So there has to be anterior horn cell of T4 and T5. Okay, the corticospinal tract of T4 and the corticospinal tract of T5. Right? Nothing new, same thing again in a different way. So now please tell me, if I cut the semi-section in T3 half, I cut the anterior horn cell of T3, that's agreed, you have agreed with that. But for T4 and T5, what do we cut? Please answer me. I'm asking you a question. That the corticospinal tract below the level of lesion, is it affected, or anterior horn cell below the level of the lesion is affected? It's a very simple question, very clear in the diagram. So if I see the corticospinal tract of T4 segment, the corticospinal tract of the T5 segment, and I cut it half in T3, correct? So what are we cutting for T4 and T5? Yes, very good. You're clear in the concept now. We are not cutting the anterior horn cell, right? We are cutting the corticospinal. Good. Now Mugambo again khush hua. But tell the Mugambo now that if anterior horn cell is affected, what kind of weakness do you get? Answer me please. If anterior horn cell is affected in any disease, I've answered you yesterday, you know this. If anterior horn cell is affected in any of the disorder, what kind of weakness do we get? UMN or LMN weakness? Answer me please. I'm waiting for your answers. Yes, good, very good. Mugambo बहुत खुश हुआ. LMN. LMN. Got it? Simple. But now answer me, if corticospinal is affected, that is happening in this case below the level of the lesion, then what kind of weakness do you get? We were clear in our diagram yesterday also that the corticospinal tract, if at all affected any time, yes, will result in what kind of a weakness? LMN or UMN? LMN or UMN weakness? Answer me. UMN weakness. Very good. Mugambo बहुत ज़्यादा खुश हुआ. Right. Now Mugambo will be more happy if you tell me, will this weakness, that is UMN, happen on the same side of the lesion in the spinal cord, or will it happen on the opposite side? Will this UMN weakness be ipsilateral to the lesion or contralateral to the lesion? Tell Mugambo please, will this UMN weakness be contralateral to the level of lesion, or on the same side of the lesion, ipsilateral? Answer me. If it is a UMN weakness below the level of the lesion, will it be on the same side, ipsilateral to the lesion, or will it be contralateral to the lesion? If you are telling me contralateral, then my dear friend, we are not on the same side. Be on my side, ipsilateral. Why? 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 Okay. Why? The reason is, why is it ipsilateral to the side of the lesion? I hope you remember the drama yesterday. Any lesion involving the corticospinal above the level of medulla, yes, the weakness was seen on the contralateral side. Any lesion below the level of medulla, the weakness will be seen on the same side. Yes, my dear friend, I'll repeat. Any lesion involving the corticospinal tract above the level of medulla, the weakness is perceived on the contralateral side. Any lesion below the level of medulla, the weakness is perceived on the same side. So technically, anatomically, this kind of a lesion is below medulla. So the weakness will not be contralateral, it will always be ipsilateral. I'll repeat again. Any lesion involving corticospinal above medulla, the weakness is seen on the contralateral side. Any lesion involving corticospinal tract below the level of medulla, the weakness is seen on the same side. Right? Chalo. Let me put this into the previous diagram, everything together. Should be very clear in our concepts in this very topic. I've got a hemisection in the spinal cord. What would happen in T3? What would happen in T5? See, intentionally nothing about T4 I'll tell. Intentionally I'll not tell. It will just invite a lot of confusion. Okay? Right. T3 spinothalamic, T5 spinothalamic. It's very clear. T3 section happens. The spinothalamic is affected on the same side, ipsilateral. T5, the spinothalamic is affected on the opposite side, contralateral. Posterior column. Posterior column. Yes, is affected in both the segments on the same side. Right? Very important. The pattern of weakness that you come across. At the level of the lesion, remember this, weakness is seen on the same side, LMN, ipsilateral. While below the level of the lesion, the weakness is seen UMN, again on the same side, what? Ipsilateral. Correct. So this is the first page. We are on the same side, we are on the same page. We are on the same side for the weakness, but the spinothalamic, we are not on the same side. At the level of the lesion, spinothalamic involvement is ipsilateral. Below the level of the lesion, it is contralateral. Got my point? Name the disease. Name the disease. I have just put a name which is hemisection of the spinal cord. Yes. Name the disease. Mr. Brown. Brown-Séquard syndrome. Yes. Hemisection of the spinal cord, Brown-Séquard syndrome. Correct? 10 marks question for your theory exam in the final prof. I remember this question. Okay. And we used to write Brown-Séquard syndrome was a syndrome discovered by Dr. Brown and Séquard together. It caused hemisection of the spinal cord and spinothalamic posterior column and corticospinal and anterior horn cell, depending on the level of lesion, was affected. But my dear friend, you'll not get these kind of questions in your MCQ purpose. You'll always get it differently. Okay. Let me just put it in a simpler format. If I get a hemisection of the spinal cord, right? Yeah, in first year also, I remember physio students, first prof physiology, they were reading the Brown-Séquard. Oh my God. They're just into the MBBS. They want to become doctors so fast. Okay. Spinothalamic at the level of the lesion. In the Brown-Séquard, spinothalamic at the level of the lesion is affected on the same side, ipsilateral. Posterior column at the level of the lesion is affected on the same side, ipsilateral. Weakness is going to be LMN on the same side, ipsilateral. Correct? But a thing which is slightly different now, below the level of the lesion, the posterior column and the pattern of weakness. Posterior column will be affected on the same side, ipsilateral. The pattern of weakness will be UMN on the same side, ipsilateral. while the spinothalamic is the only thing which is standing below the level of the lesion on the opposite side, contralateral. Right? Mr. Brown, Brown-Séquard syndrome. Brown-Séquard syndrome. Hemisection of the spinal cord. You know why this topic has come in the first year course now. Yeah, some student is writing in our exam in first prof, we got it in physiology. Yeah. Why did it come in first year? Because this is not Brown-Séquard, it is Suryavansham. Yeah, Suryavansham is a movie which keeps on coming before and after IPL on Setmax. And this topic, if they start teaching you in first year, by almost final year or PG entrance, you will understand. So every year you have to read this topic. So this is the Suryavansham of all the topics that you get in neurology at least. But in exam, it might become a Zehar wali kheer for you. Okay. So it doesn't become a Zehar wali kheer for you. For this, we'll like to solve 2-3 questions. Okay. Right, I'll solve this one first, then I'll take you back. So Suryavansham part 1, the Daya Thakur is there with the bus. You start topic in the first year and by PG entrance in dams you will understand Brown-Séquard. Good. Question number 3. All of the following are components of Brown-Séquard syndrome except. The following are components of Brown-Séquard syndrome except. Okay, it's an easy question, nothing difficult in this. Ipsilateral extensor plantar. If you remember, the plantar extensor was a part of the UMN finding. And the UMN finding happened below the level of the lesion on the same side, ipsilateral. Ipsilateral pyramidal tract. Yeah, the UMN become UMN because the pyramidal or the corticospinal was affected below the level of the lesion on the same side, ipsilateral. Contralateral spinothalamic. Yes, below the level of the lesion. But in any format of Brown-Séquard, do you ever find contralateral posterior column? Now, Baba, you always find ipsilateral posterior column involvement. So it is not a Zehar wali kheer, don't worry, you will survive Suryavansham. Now let me put into a bigger format, All of the following, which of the following is the best set of symptoms for a Brown-Séquard syndrome at the L4 level? Okay, first of all, make it very clear. Is it a symmetrical injury or asymmetrical injury? It is asymmetrical because one side is affected, the other side is safe. So it's a asymmetrical injury. Correct. Right. With ipsilateral loss of pain and temperature. Yes, at the level of the lesion. But contralateral loss of motor function? No. Contralaterally, it's always ipsilateral. Correct. Asymmetrical injury with ipsilateral loss of motor function below the level of the lesion and contralateral loss of pain and temperature. So which is a better answer? C or D? It's a very clear question. C or D? D. Okay. So you can get a question which is a simple one-liner which I discussed earlier, or maybe this one. Just have to read it once with a clear mind. If you have understood this topic, there's no problem in it at all. Okay. Let me take you back into this now. A ventrolateral cordotomy is performed to produce relief of pain in the right leg. Okay, the question reads like this. A ventrolateral cordotomy is performed to bring the relief of pain in the right leg. Now, for the diagram purpose, I can make this wala as a right leg of the patient. Okay, I'm looking from to him at the anterior side, from the anterior end, and now the right leg will get the pain through a particular nerve, correct? the signal of pain will enter the spinal cord dorsally, okay, cross the spinal cord anteriorly, and then go up to the brain in the format of a spinothalamic tract, right? Now, they say you are cutting a spinal cord. Read it carefully. Cordotomy in the lateral part of it, right? We were very clear on the concept yesterday. There is a lateral spinothalamic which is taking up the signal of pain and temperature. Yes, if you remember, temperature was medial and the pain signal was going up laterally slightly, right? Now, which spinothalamic should I cut? Left spinothalamic, that means which is on the left side of the patient, or the right spinothalamic, which is on the right side of the patient. Which spinothalamic should I cut? Which is on the left side of the spinal cord, or should I cut it on the right side of the spinal cord? It's very clear in the diagram. Yes, Mugambo Khush hua again. Left lateral spinothalamic. If I cut this, loss of pain will happen below the level of lesion on the opposite contralateral side. I believe some people will fight with me. Sir, right lateral if I cut, because when it is entering, it is moving up a segment and then. See, it's very difficult to tell in which segment is it L3, L4, L5, in which segment is the pain impulse starting. So what we do, for example, if you remember, the nerve supply of the lower limb is sacral and lumbar. Okay, it will enter. In any case, it will go up through thoracic like this. So imagine this is sacral, foot, leg is lumbar, and thoracic is abdomen and thorax above. So what do I do? In the thoracic spinal cord, I'll cut it. So if I cut it there, lumbar and sacral, all sensation will be lost on the opposite side below the level of lesion. Okay, so this should be very, very clear to you guys. And look at the examiner, he's given me a good thing also, lateral cordotomy, like I'm cutting the lateral spinal thalamic only. Okay, right. Now let's try to find an answer for this one also. A patient is admitted to a hospital after his physician observed the following symptom. Abrupt paralysis of the lower limb, right? Sphincter paralysis, related autonomic problems as well as segmental loss of pain and temperature. Without loss of proprioception of either legs and arm. So what is involved in the patient if I want to see? One is paralysis is occurring. That means the corticospinal tract is gone. The second thing which they mention is loss of pain and temperature. That means the spinothalamic is gone. But without loss of proprioception, that means posterior column is intact. Okay, so now what do you do? Where is the lesion like? Yeah, if you remember, I'll just make it a bigger one. If this is a section of the spinal cord, right, the spinothalamic is actually crossing the midline in the anterior half like this. Spinothalamic tract. From the other side as well, right. Now the posterior column that you know is going up like this on the posterior aspect. Now basic anatomy again, I'm 100% sure in anatomy sir has taught you this concept. The blood supply of the spinal cord. Yes, the anterior two-third of the spinal cord, gets the blood supply from an artery which is the anterior spinal artery, while the posterior one-third of the spinal cord is supplied by an artery, posterior spinal artery. So if you have an occlusion of the anterior spinal artery, as you can easily calculate now, look at this. If you cut the anterior spinal artery, the blood supply to the anterior two-third, the spinothalamic is gone, but the posterior column is 100% safe. Correct? Now, what is the motor weakness due to? If you remember, anterior horn cell, that was a name given to it. Corticospinal tract has to come down near it, stop at the gate and come out. So the corticospinal and the anterior horn cell are also sitting in the anterior two-third. Because of that, the motor weakness occurs. So it's a very easy question. Occlusion of the anterior spinal artery, right? not the posterior, because posterior column in this question is safe. There is without loss of proprioception. Okay, right. Till now what we were trying to discuss was more of anatomy and physiology. Now we'll sit into the hardcore neurology. Okay, what did we learn out of this kind of a drama? Remember this. Whenever you have a lesion in the spinal cord, correct? Whenever you have a lesion in the spinal cord, which can be a complete or hemisection, anything, at the level of the lesion you get element weakness. Below the level of the lesion you get UMN weakness. But above the level of the lesion all is well normal. This is a very important concept. Okay. So what do you find now? At the level of the lesion, okay, you get element weakness. But below the level of the lesion, you always get a UMN weakness. And above the level of the lesion, all is well normal. Okay, so remember this old concept. Above the level of the lesion, all is well normal. At the level of the lesion, it's element weakness. Below the level of the lesion, it is a UMN weakness. Okay. Now remember this. All this drama is put together into one term, which is known to me as myelopathy. Pathy is a term, is a disorder. Disorders have been always given a nice name, pathy. And myelopathy is a term applied for a disorder in the spinal cord. Okay, so spinal cord lesions behave like this. At the level of the lesion you get element, below the level of the lesion you get UMN, and above the level of the lesion all is well normal. But somewhere we find, sometimes we get it, that below the level of the lesion, instead of UMN, I find the element weakness. Okay, below the level of the lesion, instead of UMN, I start finding element weakness. Okay, so what is this drama known as? Can someone of you tell me? In orthopedics, it's been covered very well. Below the level of the lesion, instead of UMN, you find an element weakness seen. Please tell me, what is this known as? Yes, don't go into shock with the spinal cord. It's known as spinal shock. Yes, it's a very famous topic. Yes. So remember this, spinal shock. How do you define spinal shock? Few concepts, neurology concepts on this. Spinal shock is defined to me as a transient element weakness below the level of lesion. Below the level of lesion, instead of the UMN finding, you find element, and that's not permanent. It's found to be transient in the patient, because most of the patients, recover. It can be found that the transient word has been written for a duration of 1 to 6 weeks. Although transient for 1 to 6 weeks, but remember this concept, most of the patients recover in 48 to 72 hours. So it can be from 1 to 4 weeks, but the recovery sometimes has been found to be very, very early also, within 48 to 72 hours. Okay. Below the level of the lesion, instead of UMN, it is known as element. It can last till 1 to 6 weeks, agreed, but most of them recover very fast in 2 to 3 days time. Let us quickly revise what were the findings in element weakness that we found. Correct. Element weakness. Tell me what the reflexes. If you remember the element weakness, in the patient you find areflexia coming in. Areflexia. One thing. If you remember the tone of the muscle, yes, has also decreased in the patient. We have discussed this concept yesterday. Flaccidity, yes. Also in these patients, the tone on the bladder muscle will decrease. Bladder muscles are under constant control of the brain and the spinal cord. But when the tone on the bladder muscles also decrease, what will happen next? The urine will stay in the bladder for a very long time. Urinary retention, yes. But my question for you guys will be, in a patient which you find to be a case of spinal shock, will wasting happen or not? Will wasting happen or not? Yes or no? Transient element weakness below the level of the lesion, most of the cases recovering very, very fast in 48 to 72 hours. No. Yes. For the very clear reason, because it's not permanent, it's transient. We were clear on the concept yesterday as well, that whenever you find a element weakness, you get wasting because the nerve doesn't release trophic factors towards the muscle. But 2 to 3 days time, it's very short. The muscle has got internal nutrition, it can survive so well. So wasting won't be seen. Yeah. So it's very clear to you guys. Good. Again khush hua that in spinal shock everything will look like an element except for one thing missing in the patient, that is wasting. Now, as a old question which keeps on coming, this, the first reflex to recover back from areflexia in these patients is, I'm very sure in orthopedics you've been taught about this. The first reflex to recover back in cases of spinal shock is, this has been an old controversy also, but make it very, very clear. As per all the neurosurgery orthopedics books, yes, the bulbocavernous reflex is known as a superficial reflex. Yes. After this, you can put an arrow, because many questions I've seen, they don't mention the bulbocavernous as an option at all. That is your flexor withdrawal reflex. Flexor withdrawal reflex. Now look at the name, flexor. Whenever the word flexor withdrawal comes into your mind, you think about the plantar. And the word withdrawal means the patient is taking away the limb. Okay, flexor withdrawal. Now how does it really look like? We just play a video related to this. Okay, sorry for the plantar. Sorry, I lost the video somewhere on the transit. Maybe I'll play it later on, don't worry. It's very simple. Like, you tell the patient to lie down flat on the bed, and you tell the patient to just lie down flat, like we were trying to check the plantar yesterday. And when you're trying to do the plantar in the patient, suddenly the patient takes away the whole limb. Okay, that becomes a flexor withdrawal. Okay, so the flexor withdrawal is something which is happening to come in the patient after the bulbocavernous has come for the patient. Okay, not prior to this. Right. Yes, the spinal shock occurs in spinal injury only, not in cases of stroke patients. Urinary retention happen was something which is seen when the bladder muscle tone decreases. So it is due to decrease in the tone of urinary bladder muscles. So urinary bladder muscles, the tone decreases on them also, because of that the urinary retention occurs. Okay. Now let me take you into a basic clinical neuroanatomy on this topic. Why does LMN occur instead of UMN? Now, what I could understand from my books was this, if at all, for example, this is the spinal cord running down, and you have an injury to the spinal cord from outside or inside, whatever. In such an injury, whatever the blood supply to the spinal cord is coming from above, it's been cut off. So look at this. If an injury to spinal cord occurs, there is obviously a disruption of the vascular supply of the spinal cord. Once this kind of a drama happens, below this lesion, below the lesion, there is going to be anoxia or an anoxic injury. But soon we know God is always great for us. Collaterals will develop and the blood supply will come in. So whenever there is an anoxic injury, the limb becomes very flaccid in the sense that there is no signal from the spinal cord going on to any of the limb. And because of this, there is a element which is there, but it's not permanent, it's transient. Because sooner or later, collaterals will develop and the blood supply will come back. So maybe below the level of lesion, we can find sometime an anoxic injury, okay, which is occurring in the spinal cord. So this can also occur whenever there is a lesion inside the spinal cord or a lesion comes from outside, either way. Okay. So this is one possible explanation, what I could read in the books, but they always write, when there are so many explanations anywhere, they always write, the mechanism is unclear. Okay. There are many hypotheses for it. Now follow this. I'll try to make a normal person. Okay. A normal person with something which you find is having a sensory input on the skin surface through a dermatome and a motor output from the brain through a particular corticospinal tract and a muscle group. But how are the dermatomes being arranged in a patient on the skin surface? Just I'm trying to make a rough diagram. The head and neck is cervical dermatome, if you remember. The thorax and abdomen is the thoracic. The upper limb is again cervical. Okay. The thorax and abdomen is thoracic. The leg and thigh is lumbar. Foot region is sacral. So a rough diagram, not a very correct one. The head and neck is cervical. The upper limb is cervical. The thorax and abdomen is thoracic. The leg and thigh is lumbar, and the foot region is sacral. Let me amplify this diagram. Okay. If I want to see it as per the body landmarks, the dermatomes are like this. The inguinal ligament is the T12 dermatome. The umbilical region is a T10 dermatome. The subcostal margin is the T6 dermatome. And the nipple region somewhere goes to the T4 dermatome. Even above it, if I want to see the clavicle meeting the sacral head, the sternal head, it goes to C4 and C5 region. So maybe a sternoclavicular junction, you can be C4, C5, the nipple is T4, the subcostal margin is T6, the umbilicus is T10 and the inguinal ligament is T12. Okay. Now, why this diagram is important? Okay, I'll tell you this. Something will rewind what we read yesterday. Okay. If a person, I'll just take it away from this, you can write it separately. If a person comes to you with a disorder, a neurological deficit, referred to me as hemiparesis. One side of the body is weak. Okay, the patient has come to me with a disease in which one side of the body is weak, the upper limb and the lower limb, hemiparesis. Okay, where can be the lesion be? Most likely, we have discussed this yesterday. The lesion has to sit in a tract controlling the body from the brain, the corticospinal. Correct. But where? Let's look into the cortex. Please tell me. If the lesion is in the cortex involving the corticospinal tract resulting in hemiparesis, which artery is involved? Is it ACA or is it MCA? Which artery is involved if the lesion is in the cortex to cause hemiparesis? It is MCA artery. Okay, right. If the lesion is at the level of internal capsule, which we define as a term dense hemiparesis, yes. Which artery? Again the same artery, middle cerebral artery. Fine. But I have a patient whose neurological deficit is hemiparesis, but the patient is having a very high blood pressure and the patient is having drowsiness also, and on a CT scan I find what? Intracerebral bleed, ICH. Please tell me. If a patient of ICH comes to me, where is the most likely site? I'm not asking you the artery this time. I'm asking you the site of the lesion. Tell me. The site of the lesion in a patient with intracerebral bleed who comes to you with hemiparesis. Yes, that's the putamen, basal ganglia bleed, right? So this is something very easy to understand. Like you come across a patient with hemiparesis and you got all these things together, what can be the possible localization done? Okay, but remember this, a patient has come to you with monoparesis. That means in the patient, not all four limbs, not one side, only just one limb is weak, either the upper limb or the lower limb. It can be lower limb also. Yes, possibly in these patients we are harboring a disease which is known as neuropathy, nerve disease. For example, you suffer with foot drop, that is a peroneal nerve injury, so it's a neuropathy. So monoparesis basically means a neuropathy disorder. Okay, but on the other spectrum, remember this, if a person comes to you with paraparesis, that means in the patient both the lower limbs are weak equally or unequally, then what can be the possible disorder? In paraparesis, the possible disorder which you read somewhere in stroke yesterday was ACA infarcts on both the sides. One. Second, don't forget, is myelopathy, very important. So whenever you come across a patient with paraparesis, think about a disease in the spinal cord sitting, myelopathy. Okay. See, anterior cerebral artery, I don't know, people are getting confused into this, that ACA infarcts don't cause hemiparesis. Yeah, unpaired ACA, which we discussed yesterday, can cause paraparesis, but they are very rare. I'm not telling you rare things, I'm telling you common things. Myelopathy. Okay. Now, in a patient who's got both lower limb weak or paraparesis or myelopathy, I should examine the patient in order to know the level of the lesion. Correct? For this, I'll do one thing. I'll take a sharp pointed pin and poke my patient from below upwards. Wherever the patient starts feeling the needle or the pin, that becomes the level of the lesion. So look at the diagram, please. I poke the patient from below upwards with a needle or a sharp pin, and patient tells me, doctor, below umbilicus I cannot feel anything, but above umbilicus everything is intact. If a person tells me this kind of history, where is the level of the lesion? It is at the level of umbilicus or T10. It's very simple. So to localize the level of the lesion in reference to a sensory input, we can easily find it. But I'll tell you the basic problem. The abdomen of the patient is not like this. It's not a six pack, it's a family pack. There's possibly a lot of fat on the abdomen. So you poke him with a pin or maybe you stab him with a knife. He's not going to feel it at all. Okay. So what we do one thing. We tell our patient to lie supine in the bed and tell the patient to get up from a supine to a sitting posture. If such a maneuver is being performed, then what we see, the upper abdominal muscles are contracting and they're pulling the umbilicus toward itself. The lower abdominal muscles are also contracting and they're pulling the umbilicus toward itself. So there's a kind of a tug of war between the two. If both of them are equal in power, obviously the umbilicus will remain central. But if at all the lower abdominal muscles are weak, then what we see, the umbilicus will move upward. Correct? Why are the lower abdominal muscles weak? Because the level of the lesion is where? Below the segment T10, right? This has been known in bedside clinics as a very old sign known as a term Beaver's sign. Now what is you do in the Beaver's sign? We tell the patient to get up from a supine to a sitting posture, and if at all in the patient the umbilicus starts moving upwards, then in that case the lesion is at or below the T10 segment of the spinal cord. I can also take it as at, okay, or it can be below also the T10 segment of the spinal cord if umbilicus moves upward when the patient is brought up from a supine to a sitting posture. Okay, Beaver's sign, a very old sign. A very easy question came in the exam, long back on this topic. That Beaver's sign is actually tested on which muscles? The question came, it is tested on which group of muscle? Is it tested on the upper limb, cervical? Is it tested on the lower limb? Is it tested on the thoracic muscles, or is it tested on the abdominal muscles? Tell me, is it tested on the thoracic muscles, this sign, or is it tested on the abdominal muscles? Please tell me. Which muscle group? Abdominal muscle. Yes, good. Because every student I've seen, they carry this message home that it is a thoracic kind of innervation, so these are thoracic muscles. No, these are abdominal muscle having a thoracic innervation with it. Okay. Beaver's sign. Name sign are very important nowadays. Okay. One more sign which you all should know about is a pronator drift sign. Pronator drift sign. This has been asked actually. Okay, I'll show an image related to this one. In a pronator drift, I'll tell you the problem. You come across a patient with hemiparesis in the hospital. I'll just tell you a clinical view on this. If a patient of hemiparesis comes in the hospital, you think of stroke. CV as a possible etiology for that. And the artery involved is the middle cerebral artery. We know this concept, right? Now, if a patient of hemiparesis comes to you in the early phase, the problem is the early stage. That means they're having a very mild or a subtle weakness, only mild or a subtle weakness. What happens, I've seen this in the casualty rooms, very common. The patient will come with a weakness which is very mild, and he finds himself to be having difficulty or clumsying in hand muscles, especially if you remember the corticospinal tract, I've discussed this yesterday, was having the motor innervation, the lateral corticospinal, for which part of the body? The distal part. Okay, so they might just come with some subtle weakness, like I'm holding an object and I'm having a problem in gripping it well and it is falling down from my hand. This is a very common thing. And I'll tell you what blunder as an intern or a postgraduate I have done in my days. A patient came with a weakness, very subtle, very mild in the hand. So what did I tell the patient? To just hold my fingers like this, round fingers, So he just tried to grip it like this. So for example, I'm having a right hand dominant. So obviously the grip on this side will be very good. On the left side, comparatively it will be less. And that very patient of mine was having a problem on his left side. Okay, and it was due to a lesion right side of the brain, corticospinal, correct? And right cortex has not any kind of a speech area. So he could understand, he could speak. So there was no speech deficit in him, and he had only mild weakness on the left hand. So I thought this is all subjective. Don't worry, go home. You must be having some neuropraxic injury while sleeping in the bed. So take Neurobion and all these multivitamins. Come tomorrow. Come tomorrow. Stri Kalana. And now what happened was, the patient, when I was in the OPD next day in medicine department, I saw the patient. And to my surprise, this time he had full upper limb weak, lower limb weak, complete left-sided hemiparesis. Oh my God. Now this time I got a CT scan done for him, and the CT scan in an early phase, although misses infarct, but this time it was not early, it was late now. The CT scan showed an infarct. Now my HOD blasted me. This patient came in the emergency room yesterday with a subtle weakness. If you could have admitted him, got his imaging done, we could have thrombolized him, we could have prevented this kind of a neurological deficit. So for this kind of patients, remember, we got a test known as a pronator drift. Pronator drift, look at this. We tell the patient to close the eyes, hold the hand like this. Okay, that is a normal position. And suddenly with time we find the hand on the weak side, for example, this is the left side of the patient, will move. Look at this, will fall down. Okay, I'll make the arrow like this, will fall down. Okay, like this, and slowly and gradually it will drift down. So look at this, we are telling the patient to hold the hand like this with eyes closed in a normal position. Suddenly we find there is a pronation of the hand seen with a downward drift. That's known as a pronator drift sign. What do you mean by this sign, and what are we finding in it? That the patient is having left-sided weakness which is distal due to lesion where? Corticospinal tract. On which side? Right side. Look at this confusion. There should not be any right to left confusion. Right-sided corticospinal tract injury will cause left-sided weakness which is distal initially, which could be easily known by this sign known as the pronator drift sign. So that's the normal position and that's the abnormal position. Okay, so this is known as a pronator drift sign. Let me write this down also somewhere. In pronator drift sign, the hand on the weak side will undergo pronation, okay, with a downward drift, all because the lesion is in the corticospinal tract. Okay, so mild and subtle weakness. Yeah, why the patients have been asked to close the eyes? Maybe if I'm opening the eyes, I'm going to hold it better and trying. You see, it's a very mild weakness. If I try, I can overcome that kind of a weakness. So I don't want the person to just be very conscious about it. The eyes closed and just do this. Okay. Pronator drift sign, a very simple sign. Okay. Now I'll draw a diagram of a section of the spinal cord, which is very important to understand all the disorders of myelopathy lined up together. Okay. Remember this, somewhere we find that there is a track which is going up with the signal of pain, touch and temperature, the spinothalamic. Vibration, joint position, fine touch, that is a posterior column. Let me draw the posterior column first. It is located in the posterior part or the dorsal part of the spinal cord. That's why it is also known as the dorsal or the posterior column. But very important in this, how are the tracts arranged inside it? Okay. If I want to look at the dermatomes, if you remember yesterday we were trying to discuss, there were two fascicles which are going up. One is a fasciculus gracilis and the second one is a fasciculus cuneatus. The gracilis goes from the lower limb, right? That was medial, and cuneatus for the upper limb, that was the lateral of it. If I want to see the lower limb, the innervation is sacral and lumbar. When I want to see the upper limb, it is cervical. Between the two is thoracic. So look at the arrangement. Basically, dermatomes which are arranged in posterior column, medial to lateral, are like this. Sacral is medial, then lumbar, then thoracic, and then finally cervical. SLTC. Okay. But when I look at the spinothalamic tract, the arrangement is just the mirror image of it. I'm using the word now mirror image. Why? What was lateral now? What was lateral now will go medial. What was medial now will go lateral. CTLS. So the spinothalamic arrangement is just the mirror image of the posterior column. Okay. Well, and look at the corticospinal tract. It's medial to lateral again, CTLS. So what do you get a message out of this diagram? If I know the sacral innervation was foot region, right? And the cervical innervation was the upper limb. That means all the pain, touch and temperature of the foot will go to the brain laterally. On pain, touch and temperature on head and neck and the upper limb will go up to the brain medially. Any movement of the foot that I do is always coming down laterally, sacral. Any movement of the upper limb which I do will go down as cervical, that is medial. Why I'm drawing this diagram? Because yes, the pronator drift will have ipsilateral weakness, yes, but due to involvement of the corticospinal tract, which is in the cortex. If the lesion was a cortical lesion, then it is on the opposite side. Okay. Now, there are two kinds of lesion which are trying to involve the spinal cord. One is extramedullary, the other one is intramedullary. Remember, these two lesions are there anatomically in the spinal cord. One comes from outside, extramedullary, one grows from inside, that is intramedullary. Now in the extramedullary lesion, what do you find? The spinothalamic and the corticospinal are involved. Now tell me, look at the diagram and tell me which segment will be involved first. Will it be cervical or sacral? If it is an extramedullary lesion, which segment will be involved first? C or S? C or S? Tell me please. If there is an extramedullary lesion coming from outside in the spinal cord, which segment will be involved first? C or S? Sacral, of course sacral. So what do you see now? You find that in extramedullary lesion there is very often in these patients early sacral loss, which can be sensory, which could be motor. Now the word sensory stands for what? The tract spinothalamic. The word motor stands for what? The tract corticospinal. Okay. So extramedullary lesions, whenever they happen, they result in early sacral loss, which is spinothalamic sensory and corticospinal motor. Okay. But a reference which I want to take on this disease to explain it better is a disorder that you read in orthopedics again. There are two vertebrae which are bony prominences, bones. Between the two, there is a very small soft tissue to hold it together. And that soft tissue is nothing but your intervertebral disc. Due to sudden trauma or jerk, the intervertebral disc comes out from its space and it tries to press upon the spinal cord from outside. So it is anatomically, when I look, and as a disorder, prolapse of intervertebral disc. Yes, it is a disease which comes from outside the spinal cord, extramedullary lesion. Okay. Now, if this drama happens, if you know this in orthopedics, there is compression of something which is entering the spinal cord initially, and that something is nothing but my nerve root. Nerve root. The nerve root that you have is T9 and T10. Okay. I'm not going into details of the location of the disc prolapse. I'm just telling you a general idea on this, that if there is a compression of the spinal cord by a prolapse of intervertebral disc which is coming from outside, it is going to compress the nerve root. And most of the time it compresses the nerve root below the level of prolapse. T9 and T10, now what will happen? It will compress the T10 segment. If there is a compression of nerve root, now look at this. If there is compression of nerve root of the T10 segment, patient is going to have pain. Where? In the T10 dermatome. Can you remind me, where is the T10 dermatome sitting? Yes, it is sitting just at the level of what? umbilicus. That means what will happen now? Pain will start in the back, go to the umbilicus. From umbilicus, it will turn back to the point of origin. As if someone has tied a tight belt over his umbilicus and that belt is pressing only that part, not above, not below. Yes. Can you define me this kind of a pain? You read this in orthopedics again. This kind of pain which happens due to compression of nerve root and the pain radiates in a particular dermatome only. What this pain is known to be clinically. Don't tell me the word radiating pain. No, it's not a radiating pain. There's a definite term for it. It's known as a root or radicular pain. Look at the name. The nerve radical nerve root is getting compressed. Okay. So it's known as a root or a radicular pain. I've just tried to explain this with an example of prolapse of intervertebral disc. Any extramedullary lesion is going to have it. Root or a radicular pain. Right. So extramedullary lesions have this drama. Now let it take you back into the diagram of this. One thing in extramedullary lesion that we found clinically, that the sensory loss and the motor weakness was initially involving which segment? Sacral. Followed by which segment? Lumbar. Followed by which segment? Thoracic. And then finally cervical. Look at this now. If I want to make a diagram and see this one, in extramedullary lesion, the first segment involves sacral, followed by lumbar, thoracic, and then cervical. That means the weakness and the sensory loss which you see will be initially sacral, then lumbar, then thoracic, and then cervical, like this. That means the problem will start below and move up. Okay? We call this as what? If you want to see this as starting below in the foot and going up, yes, this will be known as ascending. Ascending kind of a sensory or a motor loss. So don't forget, in a patient with an extramedullary lesion, okay, we'll have a root and a radicular pain, one thing, and we'll have an ascending kind of a sensory and a motor loss. Correct? Okay. If you have understood the extramedullary, okay, I'll give you another good example. I'll give you an example of this disease, extramedullary lesion, a very common disorder that you read in orthopedics again. Carey spine, pot spine, also known as what? The generic name is what? Vertebral TB, the generic name. The pot spine and caries are all trade names. Vertebral TB, the generic name. If you know tuberculosis of vertebra, surrounding the spinal cord is a vertebral column. Okay, don't write it, just listen to me. A patient of tuberculosis, will come to me with a fever of a very long duration. Very long duration fever will come to me. And along with this fever, there is going to be some systemic symptoms like weight loss and all that. Correct? But I'll tell you the story. If you sit in medicine OPD, in a metro city especially, patients are customers. They don't believe in doctors. They believe in labs and investigations. I've seen this very common in this COVID pandemic. Anyone falls ill will not go to the doctor, will go to the chemist, buy some medicine from him. Then he will Google and go to a lab and get the test with him. After taking a bogus medicine, after doing some funny investigation, he will consult a physician. And then it will eat his head that why did I get all these things done? Well, you got it, I did not get it. Now the irony is that any patient I've seen in the OPD who come with fever, they get one great test done, Vidal. That should be banned actually now. And they have a titer somewhere as 1/80 or 1/160 positive, and they keep on telling me that I've got enteric fever or typhoid. A month-long fever is not enteric fever. In 1 month, either the salmonella will survive or the patient will survive. They will develop complications because of that if it is untreated. Now the irony is this, we miss upon the national disease, tuberculosis. Fever, weight loss, TB. Remember this. Apart from this, the patient will come and tell me that he's having an upper backache. And the pain is not only in the upper back, it is radiating ahead. So whenever he goes and does some yoga asana, which he thinks is very good for him, suddenly the pain in the back will go ahead like this. Radicular pain. Correct. Now he will go and tell me, maybe because of some bad luck in his life, or maybe because of yoga, not because of the disease. Now he'll curse yoga. He has started developing lower limb paresthesia. Now paresthesia is a term in which you find initially the patient has got tingling and numbness, and now the lower limb he cannot feel anything. Anesthesia. Because of the nerve involvement now, which may be an extramedullary compression by a vertebral TB. Along with this, he will now tell me, doctor, for last few days, I came to you because for last few days, I am having a problem in the lower limb. Weakness. And the weakness is in the foot. That means when he is holding his slipper tightly while walking, his slippers are slipping off. And now the problem is he cannot he cannot get up from a lying down or a sitting posture, because the weakness has now involved the leg and the thigh region also. So look at the drama now. The problem started with fever, weight loss, systemic complaints. Then the patient started having some sensory abnormality which he neglected, and he came to me in a stage of disability maybe, or a sequelae of the disease, which is a motor weakness. So the weakness started in the lower limb and then went up. Even the sensory loss started in the lower limb and then went up. Okay, so never miss upon these patients. They're very common. The national disease is not typhoid fever. It is tuberculosis, and COVID is made in China. Don't worry, it will go away. All is well. Intramedullary. If you have understood the extramedullary, intramedullary is much easy to understand. In intramedullary, what will happen? Look at the diagram, please. In intramedullary lesion, what is involved first? Cervical, followed by thoracic, lumbar, and then finally sacral. So the problem will start above and come down like this. I'm using the word start above and come down. That means it will be cervical, thoracic, lumbar, and sacral like this. Okay. So intramedullary lesion is going to have a descending kind of a sensory and a motor loss seen in them. Just the opposite of the ascending in extramedullary, this is going to be descending. And don't forget, in these patients, there's going to be a typical burning pain being felt. Like root and radicular was extramedullary, burning pain is found in intramedullary lesions. Okay. Why is it burning? I'll come to that later on. Okay. Now, let me try to increase your knowledge by solving MCQs. See, don't think these MCQs are some burden kind of a thing on you. They are always, neurology is never understood in a theoretical way. It's more practical, and it's best understood by solving MCQs. You'll have a clear understanding of the topic that you just read. Okay. So MCQs, I always feel, are like dopamine to maintain the rhythm and the movement. Otherwise, you'll have rigidity, bradykinesia. Okay. Which of the following is not a feature of extramedullary tumor? Okay, extramedullary tumor which is coming from outside is not a feature of it. So just imagine this is the spinal cord and there is a tumor sighting outside, extramedullary. Early corticospinal signs and paralysis, yes, it can happen with it. Root and radicular pain can happen in it. Asymmetrical weakness, yes, I agree with you. Because tumor is on one side, not on both the sides. So corticospinal of this side is involved, not the other side. The other side is absolutely fine. Does it have sacral sparing? Yes, everyone is giving me clear, good answers. Rhythm correct. Nation knows it. Sacral sparing. Okay. That's not seen. In fact, early sacral involvement is seen in them. Okay. All of the following statements about extramedullary tumors are true except. What is not correct about them? Radicular pain is often prominent. Yes, that's correct. Early sacral sensory loss occurs. That's also correct. Look at this line. Spastic weakness in leg is an early feature. Yes, true or false? That's also true because if it is a corticospinal involvement, the first segment, cervical, thoracic, SNL. So L, that is a lumbar, will also be involved just after the sacral, and because of the lumbar involvement you're going to have UMN findings. And we remember the UMN finding was what? Spasticity. So look at this, there is weakness in the leg which is spastic. The spastic weakness is nothing but a UMN finding in the patient. Now when you don't know the answer, apply this old trick. Read every option, you will get the best possible answer. The answer is they can lead to Mr. Brown-Séquard syndrome. No. See, I'll tell you the story. Whenever an extramedullary tumor comes and compresses the spinal cord, it doesn't cause a Brown-Séquard like picture so often. It completely turns the spinal cord like this. Complete transection of the spinal cord. Complete transection of the spinal cord. That is our elder brother of the disease, known as what? Transverse myelitis. Transverse myelitis. Okay, by exclusion you can solve this question maybe. So there is a complete transection of the spinal cord caused by them. Later on, of course, see why does a Brown-Séquard happen? Now the doubt is this, sir, if it is asymmetrical, one side is affected, you can call it as Brown-Séquard. Why does Brown-Séquard happen then? See, Brown-Séquard doesn't happen so classically by extramedullary tumors. It happens because of this, if you remember the blood supply again, anterior spinal artery and the posterior spinal artery. So maybe one side, branch of it has got occluded. So maybe the occlusion has happened on one side of the anterior and the posterior spinal artery. Because of that, there is a hemisection being created. So it is more likely because of some intramedullary disorder, like vasculitis or any thrombus, which has tried to occlude the artery anterior and posterior spinal on one side only. So that can be the major cause of it, not the Brown-Séquard occurring due to extramedullary. It's not so common. Okay. The blood supply of the corticospinal is in the interior part, lateral part. It is through the anterior spinal artery. Okay. Spastic weakness, how? Because if at all extramedullary lesion involves the corticospinal, sacral and lumbar are involved, that basically is marked for the lower limb. And if the lower limb is involved due to corticospinal, it is UMN. And UMN has got spastic weakness because LMN on the other hand, if you remember, has got what? Flaccid weakness. Okay. Okay, I think so you're getting confused in this concept. So there is a tumor outside the spinal cord, extramedullary. If it has compressed it, then in that case it will involve the anterior cell element. See, element in these patients is a very small segment, but most of the patients will always have it as a larger segment below the level of lesion, UMN. So UMN finding is seen below the level of the lesion in these patients, and the UMN finding happens in the lumbar and sacral region, which will have a spastic weakness phenomena, that is the lower limb or the leg. See, anterior cell involvement in extramedullary tumor is of a very small area, not a very large area like this. Okay. See, tumor compressing the blood supply, will often cause a transverse myelitis picture, not a Brown-Séquard like this picture very often. Anyway, Brown-Séquard could happen rarely, but what is the best answer? If such a question comes to you, don't mark the answer as Brown-Séquard. Think about it. This is something not so common, it's rare. Okay. It's right. Now let's see another disease which is a very interesting topic. This is an intramedullary disorder. Now this intramedullary disorder, okay, is syringomyelia. See, again I repeat, in a tumor which is extramedullary tumor, the element finding will not be very large. It will be small in a particular zone only. Okay, syringomyelia. Syringomyelia is a disease which is intramedullary. It is in the spinal cord. Okay. Syringomyelia happens because of this. If I see this as a transverse section of the spinal cord and I find the spinothalamic is coming from either side, crossing the midline in the anterior half, spinothalamic tract, okay, spinothalamic tract. Now the spinothalamic tract is coming from either side, crossing the midline in the anterior half, just in front of the central canal. What will happen is this: at the point of crossing over of the fiber, suddenly I will see a speed breaker, and this speed breaker is known to me as a term syrinx. Syrinx actually in a Greek terminology means cavity. Okay. Now what is the reason for this disease? Look at the concept now. Why is it known as syringomyelia? Myelia goes for myelopathy, and the word syrinx is a cavity inside the spinal cord. That's why the name kept was syringomyelia. But why will this cavity or a syrinx happen? One reason that we find is by birth, that is congenital. So it can happen from birth itself in the patient, that's congenital, or can be secondary to 3 idiots, 3T. 3T stands for what? Trauma, tumor and TB. 3 idiots are back again. Last time also I told you, if in an exam you have to go and write a long note or a short note and you are falling short of words to write it, not short of pages, in any disorder you can just fit in there trauma, tumor and TB. You'll get good marks. But at below, if you write in India most common cause TB, 1 mark extra. Yes. So trauma, tumor and TB, one reason, and congenital cause because of for this cavity is syrinx. Okay. Now look at the diagram again. Something which we find is intact all the time is what? The posterior column. In these patients, the posterior column is totally spared, right? It's not involved, only the spinothalamic tract is involved. So when I see the patient clinically, in the patient there is selective loss of pain and temperature signal seen. Selective loss of pain and temperature is seen in them, involving the spinothalamic. So this is known to me as a term referred as dissociative anesthesia. So dissociative anesthesia is a term applied for these patients. There we find a selective loss of pain and temperature with intact posterior column, vibration and joint position. Okay. Now one thing is very clear from the diagram itself. You know, the cavity syrinx starts expanding laterally, and when it starts expanding laterally, it is going to catch someone sitting at the gate, and that someone is nothing but my anterior horn cell. So one thing is very clear in this diagram, that at the level of the lesion in the patient, the anterior horn cell could be affected, resulting in a typical pattern of the weakness in the patient known as the element. But we know this fact that below the level of the lesion in the same patient, the corticospinal tract would have been affected, which could have an impact on the patient and resulting in a UMN weakness. So at the level of the lesion element, below the level of the lesion UMN. That's a myelopathy disorder. Same goes for a syringomyelia also, because of the cavity within the spinal cord syrinx, right? Now one thing important in these patients is this: the cavity goes on one direction more than the other one. So the syrinx expand laterally like this. Just imagine it is expanding laterally and it is catching the anterior horn cell of one side more than the other side initially. So what do you find? The element UMN weakness could happen in the patient on one side, not the other side. We call this as the word asymmetric. So somewhere we find in these patients the problem initially, I'm using the word again and again initially because I want to explain this with the help of a onset. So there is an asymmetrical onset of this problem seen with them. Okay. of a motor weakness especially. Okay, but remember this, syrinx or a cavity inside the spinal cord in syringomyelia, where does it really sit? The most common site that we find could be a lower cervical part. The lower cervical part of the spinal cord could be a site where we find it more frequently. Now, when I look at the lower cervical part of the spinal cord, the upper cervical segment, if you remember, I'll come to that separately, is C1. There are 8 cervical segments, if you remember, above 4 high and below 4 low. The lower cervical is C5 to C8. So maybe the C5 to C8 segment of the spinal cord is involved. Okay. So let me make a normal human being again. And in this normal human being, I'll find there is a sensory loss initially in the low cervical part of the dermatome. So when I look at the dermatomes for the upper limb, they are low cervical. Maybe it will go into the neck region also and the upper thorax. So when I look at my patient of syringomyelia, I find this kind of a sensory loss in this pattern. Yes, as if he's trying to cover his body with a covering which is not a shawl. This is known as a cape. If you see Game of Thrones, they keep on wearing this cape with them. Yeah, that's why they keep on telling winter is back. They're ready with it. Cape like distribution. So remember this, cape like distribution of sensory loss is seen in patients of syringomyelia very often. Why I'm drawing this diagram, because around 2 years back in NEET PG itself, we got a MCQ related to this. They've shown this image and asked what disease are you expecting it to be. It is nothing but my syringomyelia. Now, if this kind of a thing has come, maybe something else could come. So we can just make some images. Okay, some fugax is there. Don't worry. Get all right. Don't worry. Don't worry. All is well. 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 Okay. Lord Ganesha is there with us today. Okay. I'll draw some images and then we'll try to see what disease are we expecting it to be. You answer me on this. There's a patient with me who has got a sensory loss in this segment and in this segment. And in both the segments in the patient, maybe diagonally opposite, I can see the spinothalamic is lost. While here the spinothalamic is normal. I can put the word normal with a tick. While posterior column is lost over here and posterior column is lost over here. While here the posterior column is safe. So please tell me what is it. This is a disease in which you find spinothalamic is involved at the level of lesion on the same side. Spinothalamic is involved below the level on the opposite side. At the level, below the level, posterior column is involved on the same side. Nothing but Suryavansham, yes, they are Thakur, known as the Brown-Séquard syndrome. Brown-Séquard syndrome. A must know topic. Okay. I'll make another disease, maybe, in which we find like this, that below the umbilical region, there is a symmetrical sensory loss seen on both the sides, in which the spinothalamic is involved and posterior column is involved on both the sides. Tell me please. There is a disease in the spinal cord which is standing at the level of the umbilicus, that we can mark it as T10 anatomically, and on both the sides the spinothalamic, on both the sides the posterior column may be equally involved. What is it? Yes, very good. That is elder brother of Brown-Séquard, Mr. transverse myelitis. Transverse myelitis. Okay, good. Now, there is a disease with us. You know that one also. There's a disease with us in which below the umbilical region, in the patient, I get a sensory loss in a pattern on both the sides. Spinothalamic is involved equally on both the sides, while the posterior column is safe. Please tell me, you know this one also. There is equal and symmetrical sensory loss on both the sides below umbilicus. Spinothalamic is involved equally on both the sides as well as the posterior column. What is this one? This is the occlusion of the artery that we have been following, known as the anterior spinal artery. So anterior spinal artery occlusion can present like spine. I agree. Syringomyelia could also be a differential, but syrinx cavity is most often cervical, not like this below. I'm just trying to make it in a way that you don't confuse it with syrinx. Syrinx cavity will always have the problem initially above, but this is so down below T10. It is more likely due to occlusion of the anterior spinal artery. Okay. Another very easy diagram I'll draw. You know the answer for this also maybe. I have a patient in whom the sensory loss is in this pattern. Tell me please. He is wearing socks and he is wearing gloves. He is having glove and stocking kind of a sensory loss. Yes. Diabetic neuropathy, symmetrical sensory neuropathy, or rather distal on the hand and the feet, equal symmetrical sensory neuropathy, diabetic neuropathy. Okay. So these are image based questions that might look difficult to you, but if you solve them once, it's very easy if you understand the concept behind them. Okay. Now I'll switch back to the old topic, syringomyelia, that we were trying to read. Syringomyelia. Syringomyelia as a disorder has been found more frequent in males than females. Okay. The usual onset of the disease could be found in a bracket of 20 to 40 years of age most of the time. Okay. And they found that this disease, syringomyelia, has been often associated with a brain folding defect known as the Chiari malformation. Chiari malformation. Now, Chiari malformations are of various types that we read in peds and radiology also, but one malformation that is seen very typically in them is a type 1. Now, type 1 Chiari malformation is seen in more than 50% of patients with syringomyelia. Right? What is Chiari malformation type 1? Now, in this, if we try to understand, the brainstem part, it has got a cerebellum behind. Anterior to the brainstem, in cerebellum is pons. Below that is the medulla. Above that is a midbrain, and this is the cerebellum for me. So I'm just trying to draw a rough diagram in which this problem is there. Now, if you remember, the medulla exits the skull at the point which is the biggest aperture below. That is known as a foramen magnum. Now, these cerebellar tonsils, which are hanging actually downwards also sometime and posteriorly, suddenly herniates into the foramen magnum. So, what is Chiari malformation type 1? Is a tonsillar herniation. It's a tonsillar herniation into the foramen magnum. But how is it related to your syringomyelia? Let's try to understand this also. If you remember, we were trying to draw something as a pathway of the CSF yesterday as well. Okay, so I'll draw my Mickey Donald again today. The two lateral ventricles, yes. Below comes the third ventricle. Then my aqueduct of Sylvius and the fourth ventricle, and down below into the spinal cord is what? The central canal. Okay. Now suddenly what happens is this. When the cerebellar tonsils herniate into foramen magnum, maybe at the level of fourth ventricle or just below it, it will try to compress this part, the upper part of the central canal or even the fourth ventricle. So because of this kind of a compression caused by the cerebellar tonsils, what will be stopping? Of course, the CSF which is moving down and up in it, right? So if I try to obstruct it from outside, I'm going to block what? The CSF pathway. Okay. Now just imagine in a different story. This is a pipe, okay, this is a pipe flowing with a water under pressure. You have connected the pipe with a tap and the water is flowing across it, and you start compressing the pipe from outside like this. You try to press the pipe from outside like this. Okay, I'll draw it in a horizontal plane. This is a pipe running with water under pressure. Okay, and you start pressing the pipe from outside like this. Okay, so obviously the water flow inside will be to some extent stopped, and of course around the site of compression what will happen? At this point as well as this point, the pipe will start dilating. Look at this now. So suddenly when I start compressing the pipe from outside, which is running with water under pressure, near the point of compression, maybe proximal and distal to it, the pipe will start dilating because the fluid pressure inside it is high. So it will try diverting like this, finding a way out. Okay. Now, how is it related to our disease? Let me explain this. If I want to see this cerebellar tonsil, which is trying to herniate into foramen magnum, and it is trying to compress the central canal or the fourth ventricle, what will dilate? The central canal will dilate here. Central canal will dilate here. Now, how is this dilatation causing syringomyelia? For this, I'll do one thing. I'll take a transverse section at this point. I'll just take a transverse section at this point and show you what has happened now. If this was a very small and a slender central canal, because of the tonsillar herniation, it is getting compressed. The central canal will now have more CSF, and once it has more CSF, there is going to be what? Expansion of what? The central canal, correct? Now suddenly when there is expansion of the central canal, in the interior part of the spinal cord, it will start giving itself an outpouching, and this outpouching is known as nothing but syrinx. Look at this. So there is expansion of the central canal at the point of compression, and now because of that there is an outpouching appearing in the interior part of the spinal cord, that is known as syrinx. So at the end of the day, what does my syrinx contain? It contains what? CSF. It keeps on filling itself with CSF, and now it starts expanding laterally. First, what does the syrinx cavity with the CSF catch? It caught the spinothalamic. Later, what does it catch? Anterior horn cell and the corticospinal tract. Simple. Now, why this pathogenesis part is important? Because if you understand this concept, you can easily treat the patient. Just imagine a patient of syringomyelia came to you. One thing you can do, tell the patient that you're going to puncture this cavity and take out the CSF from there. But puncturing the cavity, or rather I can use the word drainage to be much better, it's a very raw name, puncturing. So if I drain the syrinx cavity, do you think the problem will be resolved? No, it is connected to the central canal. It will refill again. So drainage of the syrinx cavity has been found to be quite an unsuccessful thing. It is not done because relapse is very high. So what else can I do? Think about it. I'll do one thing. If I cannot get rid of the cavity, I cannot drain it. At least one thing I can do. Prevent the compressive effect. How? If this was the central canal and this one is the syrinx cavity surrounding it, when the syrinx cavity is expanding laterally and it is involving the anterior horn cell as well as corticospinal tract, what will happen? Everything will get crushed. Why? If you know this fact, just surrounding the spinal cord is a thick bony cage known as the vertebra. Can vertebra expand? No. So you just imagine like this. This is a very thin caliber spinal cord. Surrounding it is a very thick bone vertebra. And the spinal cord slowly expands. And the vertebral column doesn't expand. So everything inside it is basically facing itself against a hard wall vertebral column. So if I remove a part of the vertebra, at least that compressive effect of these syrinx cavity is removed. So which part of vertebra do you remove? Lamina. Laminectomy. To release the pressure of the cavity inside. Decompression laminectomy. Read this name very carefully. Laminectomy. We remove a part of the vertebra lamina to release the pressure of the cavity inside. Decompression laminectomy. Okay. Second treatment, maybe if it is a Chiari malformation more than 50%, I can do this. You know what is this? Just here is your occipital bone. Occipital bone. I'll not correct the cerebellar tonsil. I'll do one thing. I'll remove the occipital bone. Okay. If I remove the occipital bone, what will happen? The cerebellar tonsils will not herniate into foramen magnum. They will come down like this. Don't worry, they will not fall out. I'll put a small dural graft to cover it. So look at this. There is another surgical treatment for these patients. I can remove this part of the bone, occipital bone, okay, so that the cerebellar tonsils don't herniate into foramen magnum and they just come out and we cover it with a dural graft. Yes, people know the name. Suboccipital. Below the occipital bone, you remove a skull part, craniotomy, to set the thing right. There are two things that we find. One thing, suboccipital craniotomy is done for treating what? Chiari malformation. The type 1 that you saw in this case. Because in last year exam NEET PG we got a question. In Chiari malformation type 1, what is the treatment? Suboccipital craniotomy. Okay. Another thing is decompression laminectomy. That is done for treating patients of syringomyelia. But the unfortunate part is this, the disease meets a dead end. Dead end in a sense that even after doing all this hard work and hi-fi surgery, in most of the patients, symptoms are unaffected. That means we can just prevent maybe a progression of the further disease. So whatever symptom they're having, they're going to have it forever. So the unfortunate part is this. The symptoms are unaffected in these patients even after doing this. Okay. Decompression laminectomy means you remove a skull part below in the occipital bone so that the cerebellar tonsils don't herniate into foramen magnum. They come down here and you cover it with a dural graft to just cover them. Okay. Some people are asking me, does hydrocephalus occur in them? No. Most of the patients that they have seen with syringomyelia, they don't come with a very high or raised ICT. You might have some mild symptom of raised ICT, but not a very bad or a very severe kind of hydrocephalus. Okay. Okay, I'll give you some questions related to this topic that obviously will You'll understand the topic better through MCQs. Shunting surgery and all, no. All not very good kind of things. Which of the following statement about syringomyelia is true? Okay. More than half of the cases is syringomyelia is associated with Chiari malformation. True. Okay. Do one thing. I was just wondering. I wrote something wrong in between. ये onset है ना? This onset. I just wrote the timing of it wrong. The onset, just correct it. You take it 10 years back. Okay, 10 to 30 years. The onset of the disease is not 20 to 40. It is 10 to 30 years. Okay. So this problem commonly starts in the adolescent age group that we find. Okay. So it is associated with Chiari malformation type 1. That's a true statement. Symptom begin in middle life. No, it can start in adolescence. Syrinx cavity is always congenital. No, it can occur due to 3 EDS, 3T. Neurosurgical decompression is effectively relieving symptoms. No, unfortunately, symptoms are unaffected by it. Okay, that is the answer is A. Just make a correction. The age of onset is 10 to somewhere 30 years, maybe not the middle life. It's 40 years plus is a middle age. Okay. Which of the following is not true regarding cervical syringomyelia? Okay. Cervical cord has got a syrinx cavity. Cervical cord is having a syrinx cavity. Okay. Extensor plantar, yes or no, true or false? Syrinx cavity is something which is cervical now. Okay, so cervical sensory loss will occur, cervical segment will have LMN, but below the level of the lesion is going to be UMN. And if you know the plantar response, okay, the plantar response is having a root value of what? L5 S1. So below the level of lesion you find a UMN weakness, and extensor plantar goes with it perfectly. Yes. Biceps jerk, root value is what? C5, C6. The root value of the biceps jerk is what? C5, C6. I'll just show you the video of the biceps jerk. How do we try to do it? We might tell the patient to lie supine in the bed or maybe in the sitting posture, semi-flex the elbow, and we try to strike the knee hammer like this. Yes. But one thing is very clear, you don't have to see the flexion of the elbow. You have to focus on the contraction of the biceps muscle. So you need to expose the patient below the shoulder for this one. Okay. So how you do a biceps jerk? The bicep jerk has got a root value of C5, C6. Now if the cervical has got LMN, it's a very easy guess. At the level of the lesion cervical, it's LMN. So the bicep jerk is going to be absent, because at the level of the lesion, what do you find? Areflexia. So absent bicep jerk is a true statement. Again, I'll write here also, the plantar has got root value of L5S1, that is below the level of the lesion, that is going to be extensor or UMN. At the level of the lesion, that is C5, C6, okay, is going to be LMN. Okay. Now painless burning of hand, find this term correctly, painless burning of hand. Why? If the cervical part sensory loss is occurring, okay, for what modality? Pain and temperature. Now just imagine you touch a hot object, a cup of tea or something. You get a sense of temperature, it's hot. But if it is very hot, do you hold it there? No, you leave it. Because touching a very hot object will burn the skin on your hand, and burning the skin on the hand will induce what? Pain. Now in this patient, temperature and pain both are lost. So what do you find here? Loss of temperature. The patient will touch a hot object and will not know it is hot. The patient will have a burn injury on the skin due to touching a hot object. But the pain that should happen on burning the skin will also not happen. So there is no pain, there is no gain, there is only a loss occurring. So loss of temperature, loss of pain will lead on to what? Painless burning of hands. Simple. But something very important. At this point, what will happen? At this point, on the painless burning of the hand, there is going to be a pustule formation. And soon the pustule will rupture to become what? An ulcer. An ulcer, if it is not painful, it will grow like a crater inside. What is that known as? A trophic ulcer. So that's a sad story in patients of syringomyelia that you come across later on. They develop a trophic ulcer at the site of the burn injury because that ulcer went unnoticed by the patient because it was a painless ulcer. Okay. So what is the correct answer? Hypertrophy of abductor pollicis brevis won't happen. If you know this muscle is of the thumb that goes to the upper limb. Now I was talking about this, the upper limb is element. In an element, do you find hypertrophy? Now Baba, you always find atrophy or wasting. So there is not going to be a hypertrophy of this muscle, there is going to be atrophy of this muscle. Okay, so that's a very correct answer. Now, in every exam that you guys go and attempt, we always get a different recall by every student. And the same paper, some student gave me a different recall on the same question. Which of the following is not true regarding cervical syringomyelia? Extensor plantar, that's a true statement. Yes, we know it. Absent biceps jerk is also a true statement. Yes. Hypertrophy of abductor pollicis brevis, no. Burning sensation in hand, true or false? True or false? Now the problem here is, if you want to catch this topic, you can catch it through this. Syringomyelia is an intramedullary lesion, correct? In intramedullary lesion, what kind of pain do you find? Burning pain. Simple. Why you get a burning pain? I'll just explain you the example of syringomyelia. That the syrinx cavity is coming out from the central canal, correct? And when it is not crushed, it has just touched the spinothalamic. What will happen? So when the syrinx cavity just touches the spinothalamic, not crushes it, just touches it, what it will happen? It will start increasing the pain and temperature sensation here. That means the patient, instead of having anesthesia initially, will have what? Paresthesia. Without touching a hot object, the patient would feel that he is touching one of it. That is known as the burning sensation in hand. So remember this, burning sensation or paresthesia complaint in syringomyelia patient could happen in the early stages of the disease. Yes. But what is not seen? Hypertrophy of abductor pollicis brevis. I repeat, syrinx cavity is cervical region will have all the signs and symptoms of element. So hypertrophy doesn't fit it here. Okay. Yeah, this is something I got as a question from one of the anatomy question bank. In enlargement of central canal of the spinal cord, which group of muscle fiber is affected first? If you find the syrinx cavity, okay, I'm just not going to the syrinx cavity, I'm seeing it as a central canal now. Okay, which group of muscle fiber is affected first? Shoulder flexor, elbow flexor, finger flexor, trunk extensor. See, I'm not going to flexor and extensor drama, but I know this concept of the CTLS. The diagram of CTLS, the corticospinal from medial to lateral is like this. Cervical, that is medial, is cervical, the upper part of the body is medial, the sacral part, that is the lower part, is lateral. So look at this now. Syrinx cavity, not syrinx but a central canal now this time. Whenever starts enlarging, the weakness that you find in them intramedullary is what? Descending. So obviously the shoulder fibers which are anatomically placed medial as compared to the elbow, finger or the trunk will be affected first in these patients. So don't forget. This is something important, that shoulder flexors as compared to rest of the fibers that you find will always be affected first, okay, in this kind of disorder, right? Don't go into shock. Don't go into shock. All is well. I am the same person who was there yesterday, but I'm not a Sakta teacher. Don't worry. We'll take a small tea break, because I'm very happy today that no one from the Tukde Tukde gang came and asked for a break. Till now, I'm so happy. Binod ke daddy is so happy. Okay, I'll tell Binod also. Their Tukde Tukde gang people are not there with you. So we'll take a tea break of another 15 minutes. Okay, and we'll come back. Am I audible and visible to all of you? Chalo, let's start again, and now let's move into another concept, that is an organ which is controlled from the brain via the spinal cord, that we know as a urinary bladder. The urinary bladder. Okay. The urinary bladder is a very important organ for our daily life. We know why, but something important, like God has created it in a very perfect manner. Like for example, the urine is formed in a kidney and it pours into a ureter. If it is not stored anywhere in our body, then the whole life I'll be born with Foley's and I'll move around in life with Foley's catheter. But something we found that the bladder is something which is an important storage organ for urine any time that we have. Now, a urinary bladder is under the control of the brain, the frontal cortex that we were trying to discuss yesterday. Yes. Now there's a control on the brain center for the urinary bladder, that is a frontal lobe. The frontal lobe is a part of it, if you remember, which was trying to control the bladder through a part medialmost, the paracentral lobule, correct? And it actually always guides me to where to micturate. The sense of where comes from there, the urinary bladder. Yes, it comes from the paracentral lobule. Can someone of you type on this keypad or chat box that which artery supplies this part? Can someone of you type on the chat box that which artery supplies this part? Yes, the anterior cerebral artery, ACA, supplies this part. Now the signal from the frontal lobe will come down to the level of pons. Okay. Now when the signal comes down to the level of pons, it has to come into the final structure where the supply has to come in, that is the spinal cord. Now spinal cord has got two kinds of innervation for the bladder. Now if I can make this wala as a bladder, it happens to have two kinds of innervation for it. One which is above, one which is below. Okay, one which is above is the sympathetic, one which is below is the parasympathetic. Okay. Now when I look at the sympathetic connection of the spinal cord with the bladder, it all comes through a nerve root of T11 till L2, thoracolumbar. Okay. Then we have the sympathetic. The sympathetic is going to be sacral, S2, S3 and S4. So three parts of the sacral segment of the spinal cord, sorry, I wrote sympathetic here, it should be parasympathetic, is going to be the sacral part. Now what is the main function of the sympathetic and what is the main function of parasympathetic outflow? If you remember, sympathetic outflow will always dry the secretion and parasympathetic will always increase the secretion. So what do I understand now? The sympathetic flow towards the bladder, it's going to relax the bladder, one, and secondly it is going to help me for storage of urine, okay. While the parasympathetic outflow is going to contract the bladder and is going to help me for the process of micturition. So what do you understand by relaxation of bladder muscles and storage of urine? That means the sympathetic flow towards the bladder is going to be what? Inhibitory. The inhibitory goes in a sense that it is not going to send any signal to the detrusal muscle to contract, correct? While on the other spectrum, the parasympathetic one is going to be in a sense stimulatory, because it is going to send a signal to the bladder muscles to contract, okay. So sympathetic is something which is going to be inhibitory for the bladder, and the parasympathetic is going to be stimulatory for the bladder, okay, fine. But most important thing that we all should know about, that the urine has filled inside the bladder. I should know that. I cannot see what is happening inside my bladder. When the bladder wall gets too much distended, I will always have an urge to micturate. But that should only happen when there is a stretching of the bladder muscles. So that means there is something which has to go from the bladder towards the spinal cord, okay, as a sensory input. And this sensory input is coming into a part of the spinal cord S2 and S3 and S4. So something as a signal which goes from the bladder sensory to the spinal cord is sacral. Something which goes from the spinal cord for contraction of bladder is again sacral, okay, that is parasympathetic. While the outflow from the spinal cord towards the bladder to relax and store urine is inhibitory, that is sympathetic. Now look at the concept. It's very easily understood in this very diagram. This is the first slide, don't worry. The topic is urinary bladder. Now if at all the urine keeps on filling inside the bladder, right, and I keep on storing urine and the bladder starts distending, and now I have a urge to pass urine. I feel like I should go for urine, but at that very moment there is no toilet nearby. Do I micturate in my pants? No. I will try to hold the urine inside the bladder till I get a right place to do it. Now who is going to hold the urine inside the bladder? Sympathetic. But when I get that particular place to do it, then in that case, what is going to the bladder? The parasympathetic. So that is a well synchronized system in you and me. We do have a urge to pass urine, but we do not micturate because we can hold the urine inside the bladder like this. Now that's the basic anatomy and physiology and the innervation of bladder. But most important thing, where is the actual micturition center being located? I've seen many of the anatomy books giving me an answer frontal lobe. No. Yesterday when I was writing something about the frontal lobe, paracentral lobule, I very cleverly mentioned the term as micturition area. I never used the term as micturition center. So remember this, the micturition center in all the neurology book they mention is located in pons. So there is a micturition center in pons which will always switch off and switch on. That means it has got a button inside it, the center part. Switch on center, parasympathetic, switch off center, that is sympathetic, okay. So this is the anatomy, this is the physiology. Now let's build our concept on neurology, very important. Now what is a neurological concept in this? Bladder dysfunction or abnormalities. What are the bladder abnormalities or dysfunction that we find classically? Okay. For example, just imagine this. You guys be with me on this. If at all the lesion in the spinal cord is affecting the sacral part, S2, S3 and S4. That means the sacral part of the spinal cord is dead due to some disease inside it. If the sacral part is dead, then in that case, what will not come towards the spinal cord? The sensory input. And what will not go outside the spinal cord is the parasympathetic output. That means the bladder will not contract on one end, and secondly, the brain will not get any signal that the bladder is distending. So the motor output, that is a parasympathetic, is lost and the sensory input is lost. Okay. Now, for example, you see big boss, some people are there in our life. We have got some people in our society who still follow big boss and they're a great fan of it. If in a big boss house, one inmate is not there, the other inmate will always try to over dominate. Now the other inmate in the big boss house of spinal cord is what? Thoracolumbar. The thoracolumbar part is working more now because it is not having any parasympathetic, only sympathetic output is increasing now. Now if the sympathetic flow towards the bladder is increasing, what will happen? It's very clear. The bladder will distend. Okay, the tone of the bladder will come down. I'll put it neurologically as a term: hypotonic, flaccid, large capacity. And you keep on filling water into a tank, does the tank explode? No, tank overflows. Same goes with the bladder. There is an overflow, incontinence seen in these patients. Correct? Now this bladder happens to have a name with it as the autonomous bladder, in which the bladder keeps on distending. Okay, right. Now I'll just give you a clinical example of a patient that I saw with this disease. As the saying goes, what the mind does not know, the eyes will never find it. And the intern is a person, Dr. Kabir Singh, whose mind only knows one thing, not medicine sometimes. So what happened was, in my internship, I got a patient who came from home with a chief complaint that for the last 2 days he has not passed urine. And now what happened? I thought he's having anuria. Oh God. And I am great doctor there, so I got his kidney function test done. The kidney function, the urea and creat. And to my surprise, his KFT was perfectly normal. So I thought he's not having renal failure. Let me send him for an ultrasound, because I'm a very busy doctor. I don't want to touch them. So I sent the patient for an ultrasound. On the radiologist on the other end, gave a report like this: distended bladder. Please correlate clinically. Yeah, I was born for this only. So immediately I put a Foley's catheter inside the urethral end, and to my surprise, 2.5 liters of urine came out. I was happy, patient was satisfied. He wanted to go home, I wanted to send him home. Stri Kalana. So I sent the patient home and I told the patient to follow up in the urology OPD, next day. And to my surprise, I came to know it was a male patient, that after a few days they removed the prostate of the patient. Poor chap. Now, what the concept was, the first day, first show, when he came in emergency, he had a stage of urinary retention that was due to distended bladder. Now, there was almost 2 liters of urine inside the bladder. He should have felt the fullness of the bladder. He did not have any pain of fullness of bladder. No pain, no gain, only a loss like this. So remember this concept. Bladder related abnormalities is not always urological. They could be neurological like this also, known as the term autonomous bladder. What the mind does not know, the eyes will never find it. Second bladder on the other spectrum is this: thoracolumbar. Thoracolumbar system is not working. That means the sympathetic is not working at all. That means there is nothing like a relaxation of bladder or a tone decrease of bladder that is going towards it. Now it's a big boss house. The sacral part will work more, or rather it's not being opposed by sympathetic. So just imagine this: if the sacral or the parasympathetic part towards the bladder works more, what would happen? Hypertonic bladder. Tone increases. Tone increases is also known as spastic bladder. Low capacity bladder, for the reason we are storing a lot of urine inside the bladder. And now this time what will happen? The urine will come in the bladder and the bladder will start contracting. The urine will come in the bladder and the bladder will start contracting. You know what will happen? The urine will come in the bladder will start contracting. Now when the bladder contracts immediately, the patient will find the urine is coming out. So the patient will get up from the spot he's sitting on and start running towards the toilet. And on the way to the toilet, the patient will micturate. Now this is known as what? Urge to pass urine. On the way I cannot hold it. Urge incontinence. Simple name. This is a bladder which I find technically is working on its own, in a sense that the urine comes in and the bladder contracts and the urine moves out of it. So we name the term as automatic bladder for it. Automatic bladder, right? So there is a autonomous and there is a automatic bladder. Now I could find some names given in your surgery books related to them. Not totally correct, but still okay. Spastic is UMN and the flaccid is LMN. So the spastic is UMN and the flaccid is LMN. So they got some terms from your urology or neurosurgery books as automatic as a UMN bladder, autonomous as a LMN bladder. Okay. Number 3 bladder that we have discussed yesterday itself. People were telling me a name for it, cortical bladder. Or maybe if you remember the infant bladder, who knows when to micturate, but who forgets what? Loss of social inhibition, way to micturate. Now because of this, what will happen? The patient will have incontinence. Whenever the bladder fills in, irrespective of the place around him, he will micturate in the clothes itself. This was also given a different name, bladder of an infant bladder. Correct? And which artery is involved in this patient? Anterior cerebral artery. Yes. And where is the lesion in the brain? Which exact part? Cortex. The paracentral lobule. Right? So this is something, the very basics of urinary bladder that we should know about. Okay. What is neurogenic? I'll come to that word because I'm very sure half of you or most of you know the word only neurogenic. And what is neurogenic bladder? I'll come to that later. Now we'll do one thing. Take one full page for this one. Take one full page for writing the next thing as a topic that we all should know about. Okay. There's a topic that you read very often in orthopedics also, but somewhere in neurology I need to highlight upon this. Two topics, conus medullaris and the cauda equina. Conus and the cauda. Okay. So we'll try to understand bladder abnormalities in a clinical way through these two topics, conus and cauda. Okay. So take a full page and write them. The Karan Arjun of neurology, conus medullaris and cauda equina. First of all, we find this, when the spinal cord is ending, every student has only one doubt. They are logging in asking me, when will endocrine start? Endocrine will start when the neuro will end. Okay. When the neuro will end. When will neuro end? I don't know. It all depends on your speed and my speed sometimes, and the internet connectivity, of course. Somewhere after 6 p.m. if we end the neurology, we'll start endocrine. Because class today is till. Tell me. I'll give you 4 options: A, B, C and D. Option A, 10 p.m. Option B, 11 p.m. Option C, 9:30 p.m. Option D, 9 p.m. What is your answer? 4 options. Yes. Yes, you're all right. I've given you the best option. Some people want to stay till 11 p.m. Okay, we'll play the DJ music. You can dance. Right? So don't cry. Don't cry. All is well. Now, first of all, what is conus medullaris? What is conus medullaris? Conus medullaris is a part of the spinal cord with a distal tapering end like a cone shape. Cone shape, you know. So, what is lying inside the conus? First of all, is the sacral segment, S1 till S5 segments of the spinal cord. So remember this, the sacral segments of the spinal cord is sitting down inside the conus part. Okay. Now conus medullaris is something, spammers, Vinods, don't spam. Okay, I know there is so many conferences. Conference sunenge. As if you gain great knowledge there. Arey, this is better. You can watch the recorded version later on. It's all webinars. Opposite. Now tell me, where does the spinal cord end? If you remember. Yes. Can you tell me, where does the spinal cord end? Opposite which vertebra? L1, L2, L3. Tell me please. Where does the spinal cord end? Opposite which vertebra? L1, L2 or L3? Answers please. Just a second. Just a second, I'm there only. Yes, great answers I'm getting from your end. L1, L2, L3. Rajab. In adults, it is ending at the lower border of L1. But in case in your body it is ending in L2 or L3, please grow up now. You are an adult, because in children it might end down, but in adults at the lower border of L1 vertebra, it might end. So on a safer note, I can write like this: opposite L1 and L2 vertebra. Okay, opposite L1 and L2 vertebra is a cone shaped enlargement of the spinal cord which contains the sacral segments. Okay, which contains the sacral segments. Okay, now chordae equina. What is chordae equina? Chordae equina is something which is below the conus and around the conus. Below the conus, around the conus. That is known as chordae equina, and this is nothing but your nerve roots. Nerve roots of L1 till L5 and S1 till S5 segments. So the lumbar and sacral nerve roots are sitting around the conus in a form of a chordae equina. Why this name came in? Chorda means a tail, equina means a horse. So it looks like a horse tail to me. Chorda equina. Right? Now how do you differ them? It's a very simple trick. With the help of two jerks that you do. Knee jerk, and the second wala is an ankle jerk. Ankle jerk. Now how do we elicit these jerks? Knee jerk is elicited, yes, and the root value is L3, L4. Okay. An ankle jerk is having a root value of S1, S2. Okay, so we find that the knee and ankle jerk have got a different nerve root with it, L3, L4, and ankle jerk is S1, S2. Right. Now, how do you do a knee jerk? If you have ever done it in your ward yourself, you'll never forget it. Yes. We try to semiflex the knee joint by putting our hand behind the popliteal fossa, telling the patient to completely relax. We strike the knee hammer on the lower end of the patella and then we do like this. And what you find is the extension of the knee joint, and we need to expose the thigh muscles of the patient to see the flexion of the quadriceps muscles over there. Okay. So this is how we do a knee jerk. Don't forget this. And whenever you are doing a knee jerk, try to stay away from the patient because the patient might kick you back. Okay, some kickback from the patient you might have. And don't forget, whenever you are doing any kind of a jerk, the movement of the knee hammer, right, should only be like this on the wrist joint, right? Because I still remember, one of the intern I saw, he was taking a knee jerk like this. He was trying to hold the knee hammer in his hand and striking it like this. Dr. Kabir Singh. So tell me please if you want to see a knee jerk, and the root value is L3, L4, correct? In conus medullaris disease, that is conus medullaris syndrome, what should happen to the knee jerk? Please tell me. Tell me, should it be normal? Should it be absent? Or should it be brisk? Apply your mind and tell me please. Should it be normal? Should it be absent? Or should it be brisk? Yes, it should be normal, not absent, my dear friend. Look at the concept, please. The concept is this, the root value of the knee jerk is L3, L4. And the conus is the problem sitting down below, S1 till S5. So L3, L4 part, afferent and efferent arc of the knee jerk is perfectly normal. So what do you find now? Anything above the level of the lesion, all is well, normal, because the lesion is at the level of S1, S5. Anything above it will be perfectly normal. A normal jerk is always written with 2 plus. Normal jerk is always written with 2 plus. So if you know this from bedside clinics, you can just write it somewhere else here. 1 plus, 2 plus, 3 plus and 4 plus. How do you grade a reflex? Now this is not the grading up part that we saw yesterday. This is a grading of reflexes that you see. Grade 2 plus, 2 plus means normal. 1 plus means hyporeflexic. Okay. The 3 plus means brisk or hyperreflexes. And what does the 4 plus stand for? If you have ever done this grading, you will never forget. It is a sustained rhythmic contraction that is known as what? The clonus. So hyperreflexia, normoreflexia, hyperreflexia, and then the final stage comes is clonus. This is not the MRC grading, please. Okay, so grading reflex is this way. Okay, so something very simple, very basic to understand and to remember. Don't put the word. Okay, I'll just rewrite it. Okay. So 2 plus is normal, 3 plus is brisk. Ankle jerk, ankle jerk. Ankle jerk, yeah. Knee jerk sometimes in a normal subject, I'm asking if the patient is overconscious, can be brisk. But in this case, we can take it as to be normal most of the time. Ankle jerk, now explain me ankle jerk. What do you do? How do you do an ankle jerk? People are asking me this also. So how do you do an ankle jerk? First of all, while doing the ankle jerk, the patient has to lie supine in the bed. We'll try to hold the foot upwards like this and maybe slightly dorsiflex is fine. If the patient can hold it like this on his own is also okay. I take the knee hammer now, I strike it on tendo And now what will happen? When I strike it on tendo I'll find the contraction of the gastrocnemius or the calf muscle over here, and the foot will go up and come down. Could go up and come down, right? So whenever you are doing an ankle jerk, don't try to focus on the ankle joint. Try to focus on the calf muscle or the gastrocnemius. Okay. So ankle jerk, very simple now. Ankle jerk in a patient with conus medullaris syndrome. How will be the ankle jerk like? If the root value is S1, S2, signal is coming through S1, S2, going out through S1, S2, and the door of S1, S2 is closed. Yes. Since we saw this, above the level of lesion, all is well normal. At the level of the lesion, element. So what do I find now? The ankle jerk is absent in these patients. Now apply your mind and tell me about cauda equina. What should happen to cauda equina syndrome? The ankle jerk and the knee jerk. See, the root value of the knee jerk is L3, L4, correct? And the L3, L4 nerve root is not working this time. The door is open but the road is closed. Any disease on the nerve, I reclassified again. It is LMN. And in LMN, reflexes are typically absent like this. Ankle jerk, yes, S1, S2 nerve root is closed. Again absent. So in cauda equina, areflexia is seen for both the reflexes. While in conus, yes, the knee jerk is normal, but the ankle jerk is absent, right? Another quick difference between the two will be related to bladder. Please tell me, what kind of bladder do you see in conus? What kind of bladder do you see in conus? If it is a sacral root involvement, the sensory and the parasympathetic will be gone. Only the sympathetic will be alive, which will result in a bladder of the type distended, hypotonic, overflowing with urine, autonomous. Correct. While on the other spectrum, the cauda equina will be a very difficult task. In cauda equina, the lumbar L1, L2 is lost. For example, lumbar L1, L2 segment is lost of sympathetic. That means it might present as a automatic. If sacral is involved, it might present as autonomous. Could be that, could be this, mixed bladder. Could be that, could be this, mixed bladder. Now the term comes in, neurogenic bladder. When the doctor doesn't know what kind of bladder is he actually seeing, he is very proudly writing the term as neurogenic bladder. You yourself diagnose it, what is it? So the word neurogenic bladder is a term applied for a mixed bladder abnormality. Could be that, could be this. We'll give it as a broader term, neurogenic. Now another quick reference here is that the bladder involvement in conus is found to be early, while in cauda is found to be late. Conus, the bladder involvement is often found to be early, and cauda it is often found to be late. Now I'll have a reasoning for this. I'll give you the reasoning behind this. There are two sets of disorders that we came across. One was extramedullary, coming from outside, and the second wala was intramedullary, which is trying to grow from inside. It's trying to grow from inside. Now, if you read the anatomy books, it clearly states one thing. There is a gray matter of the spinal cord, the central part of it has got a gray matter in it. Okay, the gray matter has got two horns in every segment, the posterior and the anterior horn. If you know, the posterior horn always receives the input, that is sensory, and the anterior horn always gives out an output, that is motor. That's why at this point we have got an anterior horn cell with us, because it is sending me a motor output, correct? But between the two, there is another horn, that is a lateral horn. The word lateral comes with a belief because it is projecting laterally. Now if you read in anatomy books, it's clearly given there that the bladder autonomic fibers, the preganglionic fibers which are autonomic of bladder, are somewhere located in the lateral horn of the spinal cord. The bladder autonomic fibers are somewhere located in the lateral horn of the spinal cord. Now just imagine there is a disease within the spinal cord intramedullary. Correct? What will happen now? If it starts growing outwards, it will involve the bladder fibers early because they are somewhere inside this part, quite proximal to the disease. While extramedullary will come from outside, and obviously it will take a lot of time to involve the bladder fibers. Sorry. So have this clear understanding. In intramedullary lesions, the bladder involvement that you see is quite early, correct? In extramedullary lesion, comparatively, I'm using the word comparative, it is found to be late, correct? Now look at the disease now. Conus. Conus is a disease which is within the spinal cord. Cone shape enlargement S1 till S5 has got a disease. Now conus is an intramedullary lesion. So the bladder involvement will be early. Cauda is a coming from outside. So it is an extramedullary lesion anatomically. So we find it as late. Okay. So remember another quick difference, intra and extramedullary lesion, the bladder involvement in intramedullary is early, in extramedullary is comparatively late. Okay. Now the term cauda equina, I'm quite sure you must have heard somewhere in orthopedics again, because in orthopedics they too teach this topic. I think Bahubali must have taught about this topic, that around the spinal cord and the nerve root there is a thick bony cage known as vertebra, and the vertebral disorders can involve this nerve root in a particular fashion, causing a cauda equina syndrome. Now what are the problems of the vertebral column? Yes, there are again 3T. 3T, 3 idiots: trauma, tumor, TB. Just imagine there is Carey spine, TB of the vertebra. Does the vertebra collapse like this? No. It goes on one side, the other side remains intact. If there is a tumor met in the vertebra, it comes on one side, the other side is intact. Maybe there is a fracture of vertebra, it happens on one side, the other side remains intact. So I can just imagine this, if this is a thick bony cage vertebra, okay, inside this thick bony cage vertebra is sitting my spinal cord, and there are 3 idiots of vertebra: trauma, tumor, and TB. Trauma, tumor, and TB affects one side, like vertebral body is affected and eroded on one side. The other side remains totally intact. So it might happen the nerve root which is entering from this side is affected, while the nerve root which is coming from the other side is unaffected. Now look at the concept please. In cauda equina syndrome, due to trauma, tumor, TB of the vertebra, the nerve root of one side is affected, the other side is intact. Okay, so reflexes, knee and ankle are lost on one side, the other side remains normal. So when I see this patient clinically, he might have lower limb weakness, yes, but areflexia is seen on one side, the other side is normal, asymmetrical. The problem is not that equal, it's asymmetrical. Both the reflexes are typically absent, areflexic. It's a disease of the nerve seen, element paralysis. So don't forget, cauda equina syndrome is a disorder being referred as an asymmetrical areflexic element paralysis, okay, with a late bladder involvement, okay. Cauda is a part of the nerve root, and the nerve root is outside the spinal cord, okay. So it is a disease which is coming and involving the spinal cord from outside, with a late bladder involvement, because the bladder fibers in an extramedullary lesion are quite away from the disease. So if this is the extramedullary lesion, it is quite away from this. Okay, I'll repeat this concept again. Cauda equina syndrome is a disease involving nerve roots of the lumbar and the sacral part. If at all the vertebra which is surrounding the spinal cord is affected by a disorder like tumor, trauma and TB, it will involve the vertebral body of the one side, and the other side the vertebral body will be totally fine. Because of this, the nerve root which is entering and leaving the spinal cord of one side is affected and the other side remains intact. So the lower limb weakness can happen on one side, reflexes loss can happen on one side. So it is a areflexic element paralysis. Why element? Because nerve root is involved. Why asymmetrical? One side is lost. Why areflexes? Because knee and ankle jerk both are absent in these patients. Okay. Why element? Because nerve root is involved. Okay. Yes, extramedullary can involve sacral also. See, if there's a nerve root compression in S3, S4 segment, it can cause a problem there. Okay. Why not this vertebral point in conus? See, the conus concept happens because of a disease or a tumor within the spinal cord. So there is a tumor there sitting. It will cause the problem, not someone from outside harming it. Okay. Yeah, bladder is not asymmetrically involved in that. Doesn't happen like left side of the bladder is working, right is not working. That's why I'm writing now bladder involvement is late in them. Late. Conus is also element. Okay, fine. You can think about it like an element because at the level of the lesion you find element. Okay. I'll give you a question on this. Don't worry. I know all these clinical concepts will never go into your head until you solve an MCQ. Okay, let us first solve this one for me. Which of the following is primarily responsible from switching the urinary storage stage to a urinary voiding stage? That means you are storing a urine and you are now voiding a urine. Who is primarily responsible for this? Is it a thalamic nuclei? Is it a sympathetic outflow? It's a local spinal reflex or a pontine maturation center? Okay, so conus is symmetrical. Yes, it can happen symmetrically. But I'm not commenting on it because it's not asymmetrical or symmetrical purely. Okay. Pontine maturation center. Yes. Pontine maturation center. Correct answer. Now this is a big but a easy question to understand. A 30-year-old male has a severe motorcycle accident while driving in a rain. He suffers an injury to his lumbar spine and the MRI image is given in front of you. You know, this one is a L2 vertebra and this one is a L1 vertebra, and the L1 vertebra has got fractured in the patient. Which of the following is not a likely component of clinical examination upon arrival in the hospital? Now follow this question please. Because of the L1 vertebral fracture, the spinal cord is damaged in the patient. And if you remember, just in front of L1, what was lying there? The cone shape enlargement. What is that cone shape enlargement? Conus medullaris. So my examiner wants to ask me questions related to conus now, and could be even cauda, because cauda is also surrounding it. Okay, so it can be related to conus or cauda, either of the two, because fracture is so deep, you know, it can compress the nerve roots which are entering at this point and can compress the cauda part also and conus as well. Now first of all, look at this. It is a case of what? Spinal cord injury. Spinal cord injury. Spinal cord injury in the books has been referred as a abbreviated term as SCI. Remember this, whenever there is a spinal cord injury, at the level of the lesion you find UMN, below the level of the lesion you find UMN, at the level of the lesion you find LMN, above the level of lesion all is well normal. But sometimes, and most of the times, the UMN weakness turns itself into LMN initially. Can you tell me what is this now? In a spinal cord injury, below the level of the lesion, instead of UMN, you find LMN. What is this known as? Yes, this is known as nothing but your spinal shock. Correct? So my examiner is so clever. He's not asking me about conus and cauda alone. He's asking me something related to spinal shock. So when this patient comes in the hospital, he always comes in a stage of spinal shock. Correct? Now the question reads like this. Which of the following is not seen in a stage of spinal shock? Correct? Bladder dysfunction. Yes, if you remember, the bladder was flaccid. Urinary retention was seen. Correct. Flaccid paraplegia. Flaccidity will occur due to sacral lumbar involvement. Paraplegia will also occur. What is this saddle anesthesia? Saddle shaped anesthesia. Sometimes in the gluteal and the perineal region in the patient, we find the anesthesia in this kind of a shape. And this kind of a shape is known as the term saddle. Saddle anesthesia. Why is it known as a saddle? First of all, let me clarify why this shape I have made it. Because it corresponds with the dermatome which is more often sacral. So if there is an injury to a nerve root which is sacral or a part of the spinal cord which is sacral, anesthesia will occur in the sacral dermatome, that is known as a shape saddle. The saddle is a part which is placed on the horse back. If you're doing a horse ride for a very long time, you might anesthetize this part of the inner thigh and the gluteal region known as the saddle anesthesia like this. Yeah, I've got a first-hand experience on this. I was getting married, and on the day of my marriage, dad showed me a horse. He told me that you have to sit on it and we are going to take out a barat for you. I said, no, I'm not going to do all this. He said, no, this is a ritual we have to follow. The donkey has to climb on a horse all the time. So I agreed because they told me only half a kilometer they will travel on the horse, or I will travel on the horse. And to my surprise, on my day of marriage, all my school and college friends came in, Chichore dost. The idiots wanted to do a Nagin dance, and they took almost 3 hours to cover half a kilometer. And for 3 hours, I was sitting on a horse. And when I came down from a horse, I was still feeling I'm sitting on a horse. And when I went to the mandap to marry, I was still feeling I'm sitting on a horse, I should run away. And the best part was a Panditji who asked me a very genuine doubt. What is your gotra? I said, doctor. Saddle anesthesia. Okay. Does hyperreflexia occur in spinal shock? No. In spinal shock, you always find areflexia. Okay. So the question is not asking you about conus and cauda only. It is asking you something related to the spinal shock, hyperreflexia. Okay. Which of the following is true about the following so many bad English for the reflex being tested except which of the following is true about the reflex being tested except this is a knee jerk, yes, and the root value of the knee jerk is what? L3 L4, right? Is it normal in conus? Yes. Occurs due to contraction of the muscle on the thigh quadriceps, if you remember, that's also true. Correct. There is a flexion of the knee joint. No, there is extension. So stay away from the patient. He'll going to kick you. Right? You cannot complain for a physical assault on this. Which of the following is a feature of conus medullaris syndrome? Asymmetrical areflexic element paralysis. Is it a feature of conus? No, Baba. It was a feature of what? Cauda equina syndrome. Okay. Absent knee jerk. Absent knee jerk. Absent knee jerk. No, knee jerk was typically normal in them. Gradual and unilateral onset. Yes. No. Unilateral and gradual onset is another way of writing the word as asymmetrical. English. No. Overflow incontinence is the best possible answer. That's why I'm keeping myself away to mention conus as a asymmetrical disorder, because most of the time we find it to be quite symmetrical disease. So one thing which fits in the autonomous bladder in this patient is a overflow incontinence. Okay, right. Now we'll try to see how is the spinal cord being supplying the body in a different way. Spinal cord supplies the upper limb as well as the lower limb both. Okay, and in the upper limb, the supply comes from the brachial plexus. Sir, how do we know it is a spinal shock? First of all, rule of thumb, that means it is going to happen. Any patient with a spinal trauma will always arrive in the hospital in a stage of spinal shock. Okay, so this is something, a rule of thumb. See, any history, that's why everyone asking me this is spinal shock, when should I think about? Always think about it in a case of spinal cord injury. It will happen in. Why spinal shock occurs is because there is anoxia below the level of the lesion which recovers in 2 to 3 days time. Okay, no clear reason, mechanism is still not clear. Okay, cauda equina nerve roots are affected, so it should be an early involvement. No. See, I'm not talking about the nerve root involvement causing a bladder abnormality. It is a preganglionic fibers of bladder. See, if one side nerve root is not working, the other side will work. Now, it will try to compensate the contraction and relaxation of bladder. Don't worry about it. Now, brachial plexus is something which is supplying the upper limb. Conus element weakness, okay, if you want to see it as element, it's bilateral most of the time. Okay. Now the upper limb. Upper limb is having a supply from the brachial plexus, and the brachial plexus is made of the cervical and the T1 segment. So the cervical nerve root and the T1 segment is basically for the brachial plexus, while T2 to T12, L1 till L5 and S1 till S5 has nothing to do with the upper limb. It is supplying to supply the thoracic, abdomen and the lower limb. Okay. Now, if at all, there is a lesion in the spinal cord, which is found to me in the patient above the T1 level, or maybe at T1 or above T1 is fine. Doesn't make too much of difference one segment, but above T1, for example, I take it. Then please tell me, in such a patient, if the lesion is above T1 segment or it is cervical, in other words, it is cervical lesion. I can write it here. It's a cervical lesion. Tell me what should happen in the upper limb at the level of the lesion. I'm going to find an element weakness. Below the level of the lesion, I'm going to see a UMN weakness. Now look at the patient. His upper limb is wasted areflexic, while the lower limb is spastic and hyperreflexic. That means upper limb and lower limb on either side are weak. LMN upper limb, lower limb UMN. All four limbs are weak. What is this known as? All four limbs are weak. Quadriparesis. Quadriparesis. Okay. Quadriparesis. While at all, if I see that the lesion is below T1 segment, if the lesion is below T1 segment, then what do you find? Upper limb and the lower limb. The upper limb obviously is unaffected, it's normal. The lower limb is going to show me a weakness. Now this weakness can be UMN element depending on the level. But one thing is very clear, the upper limb is spared and the lower limb is weak. If the lower limb is weak, it is known to me by the term paraparesis. Paraparesis. Okay. So upper limb weak, lower limb weak on both the side, quadriparesis occurs due to cervical cord injury, while paraparesis happens most often due to a thoracic one below injury, below that level. Okay. Okay. Now let us divide the spinal cord again into the segments C1, C2, C3, C4. sorry. C5, C6, C7, C8. This part of the spinal cord C1 to C4 is known as a high cervical cord, while C5 to C8 is known as a low cervical cord. High and low is the difference between the two. Above 4, below 4. Now very important concept, the C3 and C4 and C5 segment is a part of the spinal cord, and it supplies a nerve, phrenic. If you remember the nerve, phrenic nerve, that is very important for controlling and contracting which muscle for respiration? The diaphragm. Now below if I take C6 to C8, of course along with the thoracic, I'm not missing them, along with the thoracic is supplying the muscles that are going to innervate the muscles for respiration again, that is intercostal muscles or the intercostal nerve. So how is the respiration happening? Remember this way, the brain has got a center where the impulse has to develop even during sleep. Okay, C3, C4 and C5, the output will go out from the spinal cord to the phrenic, while the output C6, C7 and C8 will go out through the intercostal. But all this thing is going to travel from where? Spinal cord. Look at this. So there is a respiratory center in brain which fires even at rest, signals the body through the spinal cord like this, in which C1 and C2 has nothing to do with respiration directly, but it is going to send the signal down for the phrenic and the intercostal. So all these signals, phrenic, intercostal, is not developed within the spinal cord. They all develop in the big boss, the respiratory center. Why I'm stressing on this basic concept? Because if there is a lesion in the spinal cord which is high cervical cord, one thing is very obvious, the phrenic nerve will not throw out any signal. I'm using the word throw out because it will not send out any signal now, because C3 and C4 segment is not working. On the other end, the intercostal nerve will not get any signal. Listen to me. High cervical cord injury, the phrenic nerve will not send out any signal, and the intercostal nerve will not get any signal. Why? Now let's look at this. The intercostal nerve gets the signal from the brain respiratory center, and all this thing is coming down through the high cervical cord. So if I cut this part C1, C2, C3 and C4, nothing will reach over here and it will not work. So it's a very conceptual thing like this. Lesion which is high cervical cord will cause paralysis of the diaphragm and the intercostal muscles both, resulting in a disease in which the patient's brain may be fine, patient may be alive, but cannot breathe. Apnea. Loss of spontaneous respiration. I'll give you an example, don't panic. I'll give you an example. Again internship time. No, internship, residency time. I was a postgraduate there. And in post-graduation, you don't join department, you join gangs of Wasipur. So there is a definite and perpendicular always against you. You are the vessel, and there is your HOD who is Ramadhir Singh. So please watch Gangs of Wasipur to understand the story again. Now what happened was, I was in my post-graduation and there was a patient who came from home, and he was a very young chap, 20 years, and he was gasping, right? And now when the patient was gasping, I found his saturation was very poor, so I immediately intubated him. Now when I intubated him, I found that his respiration picked up normal. I was fine. But I asked the relatives what happened with this patient. So every relative told me that we don't know. He was just lying this at home. We brought him to you. You are our God. Save him. This and that. I said, okay, fine. So I sent the patient to the ICU on a ventilatory support. After 2 days, I got a thought in my mind, what happened with that patient? Let me follow up. So I went to the ICU and my batchmate was there on duty. And I asked him, boss, what is happening with this patient? He replied to me that the same thing is happening with the patient. I said, what? Continue same treatment. I said, what? He said, for the last 2 days he's still on ventilatory support. The moment we remove him from ventilatory support, he becomes breathless. We have to put him back. Now, but it's a government setup, so we are not that bothered. We went for a tea break, but from behind a great man came on morning rounds. Dr. Kabir Singh in gangs of Wasipur is there. And Dr. Kabir Singh, the intern, came on round and he found something on the patient neck and he came back and gave us a feedback. So the patient that you were talking just now about, and I could see a V-shaped line on his neck, right? But he's an intern. He initially thought it's some tattoo. Then he recalled it's something, not a tattoo, something else. And when we went and saw the patient, we saw a V-shaped ligature mark on his neck. Oh my God. But this is gangs of Wasipur, very important. So when everyone feels that they have done a blunder, they start looking at me. I said, why are you looking at me? So everyone in ICU told me that you got the patient admitted. So you didn't you see in the casualty? I said, for the last 2 days, this patient was in ICU. No one saw there in ICU also. Who saw? Or Dr. Kabir Singh. Who else? So to our surprise, we later on came to know that it was a case of hanging, an antemortem suicidal hanging. And in hanging, we find this, high cervical cord injury. And in that patient, in spite of putting him on a ventilator, he could revive. But when we switch him off or wean off from a ventilator, he becomes again tachypneic. Because of hanging has caused a high cervical cord injury, it is going to damage the innervation for the phrenic and the intercostal nerve. So this is how the whole story came in our limelight, right? So don't forget any patient who comes to your hospital. Why did the intern found out? We missed it. We are great doctors, but intern did only one thing, which he has done in his whole MBBS. You know what? General physical examination. He did it so perfectly and found a ligature mark, which we missed it for so much time. Because somewhere in a dark skinned person, you will not find the ligature mark so easily, apparent on day one at least. Okay. Now look at the concept. If the lesion is somewhere the low cervical cord, if the lesion is involving the low cervical cord, okay, what would happen? The C3 and C4 will partially work, partially work, and that will make the phrenic nerve work, okay. But on the other spectrum, remember this, C6 to C8 will not work. That means the intercostal will never work. Now look at this patient. It's different from a high cervical cord injury. Why? Because in this patient the intercostal nerves are not working, while the partial effect by the phrenic nerve, the diaphragm is working. So this patient, I can see, is able to breathe by the effort made by the diaphragm, known as the diaphragmatic breathing. Okay. So this is very important, that in a low cervical cord injury, there is a diaphragmatic breathing which is seen in this patient. Okay, while in a high cervical cord injury, you get an apnea. I'll give an example on this also. I came across a patient in emergency duty and the patient had a road traffic accident, RTA, road traffic accident. And I saw the patient gasping. When I saw the patient gasping, his thoracic muscles were only moving, not the abdominal muscle. Why? Because when the diaphragm goes down, the abdominal viscera will come out. When the diaphragm goes up, the viscera will move in. So in the patient, thoracic muscles were not moving. Why? Because the intercostal muscles are not working. Correct? That is a different kind of a breathing pattern seen in a low cervical cord injury, known as the diaphragmatic breathing. Why intercostal muscles in high is affected? I'll repeat. intercostal nerve is getting a signal from the brain which is traveling down through the high cervical cord. If I cut the high cervical cord part, the signal is not received over here. Okay. While in low cervical cord, a partial effect of the diaphragm happens and the patient is able to breathe through the diaphragm, known as the diaphragmatic breathing. Okay. What about the thoracic? T1 to T6, T7 to T12. Okay. Upper thoracic, lower thoracic. Like high and low, it's upper and lower this time. Now something about upper thoracic injury, you should know this. They say somewhere in the books, if the lesion in the spinal cord is above the T1, above the T6 segment now. The lesion in the patient is above the T6 segment. Okay. And patient gets a signal of pain. If there is a pain stimulation in the patient due to any reason, what would happen? In such a patient, suddenly there is going to be decrease in heart rate and increase in blood pressure. Now this rise of blood pressure happens in these patients due to vasoconstriction. Okay, vasoconstriction. Now why does it always happen in this segment level? It's not very clear in the books and there is no clear reason why it happens, but it's just a chance observation seen. Look this. Now what is the name of this drama? There's a different name for it. If the heart rate goes down, just imagine clinically, if the heart rate goes down, the blood pressure will also fall. There is bradycardia and there is hypotension. If the heart rate goes up, the blood pressure will shoot up. There is tachycardia and there is very often hypertension in the patient. But this time the bradycardia is happening. Maybe the parasympathetic is working more. BP is shooting up. Maybe the sympathetic is working more. That means the autonomic system, parasympathetic and sympathetic, are not working in a proper way. There is a problem in reflexes related to them, known as the autonomic dysreflexia. So don't forget this term. Autonomic, not Cushing. Cushing I'll come to later on. Autonomic dysreflexia. It's not Cushing reflex. No. Not Cushing exactly. That is for the raised ICT patient, not for them. In myelopathy, the same, maybe same as Cushing. I agree. Same as Cushing could occur, but it's not known as a Cushing reflex here. It is known as autonomic dysreflexia. Different name is given to it. Why dysreflexia? Because sympathetic and parasympathetic both are working at the same time. Okay. So bradycardia with hypertension, which occurs in a patient whose lesion in spinal cord is above the T6 segment, and especially if it happens whenever the patient gets a pain stimulation. Now pain stimulation from where? Just imagine if the lesion is T6, the patient will be bedridden, paraplegic for example. The pain stimulation can happen in two ways, like bed sore. If they are bedridden for a very long time, they are going to develop bed sores, or can be through urinary retention also. So in these patients, urinary retention and bed sores can be a very common source of pain stimulation. And if the lesion is above T6 in the spinal cord, suddenly the heart rate will fall down and the blood pressure will go up. Okay, known as autonomic dysreflexia. Okay, I've repeated and repeated. 3 times I've repeated. Okay. Now treatment is this, to control the blood pressure by two group of drugs. One is an alpha blocker or clonidine, and the second one is nifedipine. So when you want to treat such patient, you give two drugs, clonidine and nifedipine. Okay. See, urinary retention and all will occur in a paraplegic patient. No, there is a patient with paraparesis, lower limb weakness. So if at all he has got a urinary retention, okay, as a disease, suddenly we'll have to have a urinary retention. He is bedridden, he'll have bed. So all these problems happen in a patient who is bedridden. okay, bedridden or paraplegic. So most of the time we find them to be having all this problem in a special situation like pain stimulation. Okay, don't go into details of why it happens and how could it happen. Just know the name is more than sufficient. Okay, this has been asked 3 times at least. That's why I'm taking it out. Now I'll go into a cranial nerve whose number is fifth and whose name is trigeminal. There's a trigeminal nerve by name and the number is fifth for it, which is a cranial nerve, very important, and has got relation to the spinal cord. Okay. Now, trigeminal nerve, if you remember, has having two function. One is sensory and the other one is motor. The sensory function of the trigeminal nerve is basically meant for receiving any sensation, and the sensation this time comes from the face and from the eye known as the cornea. And the motor wala is for the muscles on the jaw to move up and down, left and right, the masseter and the pterygoid, that is the muscles of mastication. Sir, lower thoracic, you do not tell anything. There is nothing specific for it. Maybe a beaver sign that we read, okay, which could be related to a specific sign in these patients, that is a T10 level lesion. Nothing specific for the lower thoracic. Okay, maybe beaver sign, think about it. If the lesion is at or below T10, you can have a beaver sign positive. Okay, we have already done that one. Trigeminal nerve is having two things, sensory and motor function. Sensory is to carry the signal of any kind of sensation from the face and the cornea, and the motor is somewhere to supply the face for the jaw muscles, okay, to move the jaw up and down, masseter, left and right pterygoids. Okay, so this is the sensory and a motor mixed nerve. Now trigeminal nerve has got many nucleus. Let's try to read it. I'll start from below. There's one nucleus which is sitting down in the spinal cord for the fifth nerve, and this nucleus has got a spinal nucleus. Okay, C1 C2 segment, the high cervical cord C1 and C2 segment has got a spinal nucleus of the fifth nerve. The word is nucleus and spinal because it is sitting down in the spinal cord. Most importantly is this: the signal will enter from the fifth nerve, that is a sensory input, and will come into the high cervical C1 and C2 segment. So what do I see now? That the spinal nucleus of the fifth nerve is basically more and less of a sensory nucleus. Yes, so sensory nucleus is the spinal nucleus for me. Now what would happen is, the spinal nucleus, whenever the signal comes in, it is going to move up. When the signal tries to move up, okay, it has to pass through the brainstem first and then reach the cortex. And the brainstem is made up of three parts. The lowermost part of it is the medulla. Above it is the pons. Above that is the midbrain. Then we have the thalamus with us. And finally we reach the upper center, that is the cortex, right? Now when it is passing up in medulla and pons, it goes up like this, as the name, spinal nucleus only. And there is a nucleus somewhere sitting inside pons to receive all the signal, and that is the main nucleus. Whenever I use the word main nucleus, it is a primary nucleus. So the name given to this nucleus is the primary sensory nucleus, right? So there is a primary sensory nucleus of the fifth nerve sitting up in pons. But now what happens is all this thing which has entered now will actually cross the midline, and move towards the opposite side and go up through midbrain to reach thalamus. Again, I repeat my words. Whenever a sensory pathway has crossed the midline and it has gone up in the brainstem, it will be named with a different name known as the lemniscus. The lemniscus this time is carrying up the signal of the fifth nerve, trigeminal nerve. So we know and label this wala as the trigeminal lemniscus. And finally we reach a part that is the thalamus. In thalamus there is a nucleus waiting up for there, that is ventro posterior medial nucleus, not the VPL. The ventro-posterior lateral nucleus is for the rest of the somatic afferents from the body, while the ventro-posterior medial is for the cranial nerves. And then finally we reach the final destination, that is a cortex. Now what is important in this diagram? What is important in this diagram is this. If you got a lesion in medulla or maybe a lesion in the spinal cord and there is a damage to the spinal nucleus, the sensory loss on the face and cornea will happen on which side? Same side, ipsilateral. While if you have a lesion in midbrain or thalamus, in the midbrain involving the trigeminal lemniscus or maybe the thalamus involving the ventro-posterior medial nucleus, then the sensory loss in the face and cornea will happen on which side? Opposite side, contralateral. So one thing I understand that whenever there is a lemniscus injury, the sensory loss is always seen on the contralateral side. Let me rewind this. We have read 2-3 lemniscus yesterday: spinal lemniscus, medial lemniscus, and today we have got a trigeminal lemniscus. Yes, whenever there is a spinal lemniscus injury, that is connected to which tract? Spinothalamic. Medial lemniscus connected to which tract? Posterior column. Trigeminal lemniscus connected to which tract? Not the tract but the cranial nerve, fifth. Loss of pain and temperature now this time, contralateral. This time, again contralateral. Fifth nerve, again contralateral. So it's a very simple trick to remember these things, that whenever there is a lemniscus injury, we are going to have a contralateral sensory loss. Someone told me, and I forgot yesterday somewhere, there is another lemniscus known as a lateral lemniscus. Can you guys tell me? Lateral lemniscus is related to what? Yes, auditory. It has nothing to do with the sensory afferent, it is to do with the eighth nerve, auditory. That was actually formed when the trapezoid body, when we have crossed the fiber and pons and then everything goes up, is the lateral lemniscus. That is for the auditory fibers. So you just quickly make this one also. There was an eighth cranial nerve. Yes, we have drawn this. There is a nucleus in medulla, and somewhere in pons it crossed the midline and then it went up. So this was a pons part where the trapezoid body was seen, where the fibers crossed, and then it went in the pons up and then it went to the midbrain, thalamus, everywhere. And this part, when it has crossed the midline and it is going up in the brainstem, in your midbrain, okay, and even in pons, this is known as lateral lemniscus. So it's a very simple concept. Lemniscus are always formed after crossing over. Any sensory afferent, when it passes through the brainstem after crossing the midline, will be given as a word lemniscus. Okay. Right. Now there's another nucleus of the fifth nerve sitting there in pons. This is the motor nucleus. So there's a motor nucleus of fifth nerve in pons and there is a sensory nucleus of the fifth nerve in pons. Okay. Now these nucleus are left and right. On both the sides they have got representation, right? Now I'll come back to this diagram again. But before that I'll try to solve this concept in your brain. Just imagine things like today is Ganesh Chaturthi, and if you are at home or you may be in hostel, especially in the southern part of our country, they always make good food in the mess for a change today, if the mess is open provided, and you eat something really good, or someone serves you a modak or some sweet, correct? And suddenly you eat something sweet, like someone serves you dairy milk today, you said happy Ganesh Chaturthi, Ganpati Papa Moria, chocolate kha ke bhag gaya. So you start having a chocolate, chocolate melts in your mouth and you get what? The taste of the chocolate, right? You're studying and you start eating chocolate. Now when you get the taste of the chocolate, you get it on the tongue. Write it on a separate page if possible. And the interior two-third of the tongue is going to uh, give me the taste. Now the signal of taste we have tried to discuss has already gone to the brain through the seventh cranial nerve, and the branch of it someone was trying to tell me yesterday was a cauda tympani branch. Now there is a sensory nucleus of everything in the brain, and finally we receive the signal of taste. But the most important thing, you eat something nice, delicious, maybe a chocolate for example, you feel nice. When you feel nice, you always like to smile. Man mein laddu phuta. And when you want to smile, okay, you again require a cranial nerve whose number is what? 7th, the facial. And when I want to smile, I will stretch the lips laterally like this. Okay. And for this, I require a muscle, risorius muscle. Look at this. For smiling, you require just one muscle. But for frowning, you require more than one muscle. So use only one muscle, say VTP. Okay. Keep on smiling. मुस्कुराइए. आप e-medicos पे हैं. Now, another one is when the chocolate doesn't melt properly, you'll start chewing the chocolate. For chewing the chocolate, you require to move the muscles on the jaw, that is for mastication, right? And to do that work, there is a cranial nerve, yes, working, whose number is 5th and the name is the trigeminal. Now what has happened? You have tasted the chocolate, you have smiled, you felt better, and you start chewing the chocolate. Now the time has come to swallow the chocolate, correct? Now time has come to swallow the chocolate, that is to move the muscles on the pharynx, that is for deglutination. And to move the muscles on the pharynx, you require a cranial nerve whose number is 10th, the vagus, right? Because you are chewing a chocolate, not a chewing-gum. Like you eat a chewing-gum, you chew it and you spit it. I've seen some people chewing the chewing-gum and swallowing that also. Sticky people. Anyway, chocolate you have to swallow. Now suddenly after eating chocolate, you find yourself good, fine, and you feel like doing something great today, that is studying. And you open your book and start studying. That very moment when your friend sees you studying, he gets a absence seizure. Padai? And then he sees your chocolate just kept aside to your Harrison, if you are reading it. He picks your chocolate and starts eating it. And you warn your friend now, how dare you do that? This is my chocolate, keep it back. Take my Harrison, eat it, it's of no use. Now you start talking by forming the word in a brain, Broca's area. And when you talk out, you move the muscles of the tongue for articulation of speech. Now articulation of speech is something which is done with the help of another cranial nerve whose number is 12th. Okay, so this is how you try to do it. So you taste, you smile, you chew, you swallow, and finally you stop someone to take away your food. Articulation. Okay. Now, most important thing, the nucleus of every cranial nerve is located where? It is located in the brainstem. If you know the basics again, the 7th and the 5th cranial nerve have got a nucleus somewhere where? Pons. The 10th and the 12th cranial nerve has got a nucleus where? in medulla. So what happens is, the brain develops a signal to smile. In pons, the seventh cranial nerve is going to pick it up and send it out to smile. Brain develops a signal to chew. The fifth cranial nerve in pons is going to take the signal and you're going to chew the food. This is how it happens. But just example, it happens in a different way. The brain develops a signal, okay, and instead of the seventh cranial nerve here, the fifth cranial nerve picks it up. So what will happen? Just imagine. The brain tells you to smile. Instead of smiling, you start chewing. How's the joke? Very tasty. But now instead of fifth, seventh cranial nerve nucleus opens for you. What would happen next? That means your brain tells you to chew the food which the people are eating with you, and instead of fifth, the seventh opens up for you. So what would happen now? The moment everyone is eating the food like this, fifth, you start eating the food like this. How's the food? Very funny. So this is how it happens. Things are going to open up whenever they are supposed to open up, whenever the commanding brain center tells it to do. Okay. And who opens up is a cranial nerve nucleus. So now the cranial nerve nucleus works like a gate to work. Let me put this into another diagram, very small one. For example, this I see as a nucleus of a particular cranial nerve. It is getting a signal from the brain. The signal from the brain is coming down to the nucleus and coming out as a nerve for a particular muscle. Okay. Same thing parallel. I'll draw like this. There is a gate which is sitting in the spinal cord, the anterior horn cell. To control it is a corticospinal tract, and to give the signal towards the muscle is a nerve. Okay. Now why I'm drawing this diagram parallel? Because that's the thing that should also move in your brain parallel. Okay. Anything above the anterior horn cell involving the corticospinal tract, we have defined this as UMN. Anything involving the anterior horn cell and the nerve, we defined it as what? LMN. Same thing would happen again. Anything above the nucleus from the brain, you define it as what? UMN. Anything in the nucleus and the nerve, we define it as what? LMN. So I'll put it in a different way, more anatomically. Supranuclear, anything, any problem, any lesion actually, to define it as a lesion, any lesion in the brainstem which is supranuclear is UMN. Correct? Any lesion, nuclear and infranuclear. So I'll put the word as in the nucleus, nuclear, outside the nucleus towards the nerve, infranuclear. So supranuclear lesions are UMN, okay. Nuclear and infranuclear is LMN. So this is something clinically and anatomically very relevant concept, that in a cranial nerve lesions, lesions which are involving the cranial nerve, okay. In the cranial nerve lesions, if it is supranuclear, the presentation is classically UMN. If it is nuclear and infranuclear, the presentation is classically LMN. Okay. Apply this concept in a different way. What I'll do one thing. I'll take you back to the fifth cranial nerve and the diagram there. Now what we'll do, we'll write a reflex over there, which is important to know the integrity of the fifth nerve, and the name of the jerk is your jaw jerk. Jaw jerk. I hope you know how to do a jaw jerk. You take the knee hammer, you tap it on the mandible midline like this. Once you tap it over here, the signal from the face will go to the brain. That means the sensory afferent to receive the signal from the brain towards from the face towards the brain is going through which cranial nerve? Fifth. And the normal response, the motor, yes, is what? When I do this reflex, do I smile? No. I chew. In the sense, I move the jaw up by the movement of the muscle masseter. That means the efferent or the motor output is fifth and the afferent is fifth. That means the nucleus of fifth works for it. Fifth kidney nerve is afferent for a jaw jerk and efferent for the jaw jerk. So the jaw jerk, the afferent is fifth, efferent is also fifth, right? Now please be with me on this topic. It's a very easily understood topic in the classroom. Jaw jerk is brisk. Please tell me. If you find a patient with a brisk jaw jerk, is the lesion supranuclear, nuclear or infranuclear? Just type the initials, I'll be happy. S, N or I. The jaw jerk is brisk in a patient, anatomically speaking. Is the disorder anatomically supranuclear, nuclear or infranuclear? S, supranuclear. Yes, good answers are coming. Nation knows it. Supranuclear. If it is supranuclear, good. That means it is a brisk reflex. Why? Because a brisk reflex is a part of a UMN finding, and UMN lesion happens when the lesion is supranuclear. Where is the motor nucleus of the fifth nerve sitting? In pons. So I can write this, the lesion is supranuclear or above pons. Hence prove like a theorem of maths, Neuro is maths, that's why it's very difficult to understand, because your maths is weak and that's why you became a doctor. So jaw jerk is brisk, it's a supranuclear lesion. The lesion is UMN and it is seen above pons. Simple. Now there's another cranial nerve which helps me to smile all the time, that is a seventh, or the facial nerve. I agree you'll read this more into your ENT classes, but sir told me that something about neurology needs to be addressed here. Okay. Now the seventh, or the facial nerve. If you remember, the seventh and the facial nerve is something which is supplying the face for expression, the facial expressions. There is a right and there is a left facial nerve with us. Okay. The right facial nerve supplies the right face complete. The left facial nerve supplies the left face complete. Okay. But something different, this, I'll come to this diagram again. But before that, what is the innervation of the facial nerve from the brain? If I divide the face into four quadrants, if I divide the face into four quadrants, the line which is given in the book of neurology at least is the upper two-third, lower one-third. Some of the authors are different on this. Some people say upper half, lower half. That's fine. It doesn't really matter here. Upper two-third, lower one-third is more appropriate, which we also see in our clinical practice. Upper two-third, lower one-third. Why I'm writing this innervation in this way? Because upper two-third of the face is having bilateral cortical innervation. So upper two-third of the face is having a bilateral cortical innervation, right? Lower one-third of the face on the other spectrum is supplied by the opposite cortex. Upper two-third of the face is having a bilateral cortical innervation. Lower one-third of the face is having a supply from the opposite cortex. So we can make this diagram like this. Upper two-third of the face is getting a supply from both the cortex, right and the left, right? While the lower one-third of the face is supplied by the opposite cortex like this. So that's a very simple diagram. The lower one-third of the face is getting the supply from the opposite cortex, while the upper two-third of the face is getting the supply from both the cortex. Okay. Now, why did I make this diagram? Because we need to understand through this. If I make and give you a puzzle like this, I divide the face into four quadrants A, B, C and D. and I create a lesion in the patient's cortex. Maybe from the patient end, if I look, it is a right cortex of the patient. There is a lesion in the right cortex of the patient. Okay. If there's a lesion in the right cortex of the patient, which quadrant of the face will show the weakness? Answer me. Will it be the quadrant A? Will it be the quadrant B? Will it be the quadrant C? Or will it be the quadrant D? Which quadrant of the face will you see the weakness on the face if the lesion is cortical on the right cortex? It is D. Okay. So what you see here, that if the lesion is in the cortex, the lower half of the face is weak on the contralateral or the opposite side. Okay. Correct in the diagram, no confusion on this. Now, what kind of lesion do you classify it into? Please answer me. Do you want to call it as paralysis? Yes. But will you call it as a UMN paralysis, or will you call it as element paralysis? Please tell me. What kind of paralysis should I label it as? The lesion is cortical. Yes, the lesion is cortical above the nucleus pons of the facial nerve. That means it is supranuclear. That means it is going to be a UMN paralysis for me. Simple. So UMN paralysis of the face, the lower 1/3 of the face is weak opposite to the lesion like this. Okay. Now I'll give an example. I was in my emergency room and a patient came with a weakness on maybe the right side of the body. And now I told the patient to smile. Now since his muscles, okay, the lesion was on the left side, the weakness was on this side, he started smiling like this. The face got pulled towards the normal side. Okay. Now when the face got pulled towards the normal side, he started smiling like this. I also started laughing at him. Ha ha, how are you smiling? The patient looked at me like this. Don't angry me. Why? Because the upper 2/3 of the face was perfectly fine. Only the lower 1/3 of the face is weak for him. Got my point? Now, facial nerve again is going to supply the face after it gets a signal from the pons. Okay. Now, when it supplies the face, the nerve, okay, it supplies the face complete, the right nerve and the left nerve. And if there is a right facial nerve injury, look at the diagram please. If there is a right facial nerve injury that you read in ENT very often, the right face is weak, almost complete. If there is a right facial nerve involvement, there is a right face weak, almost complete in this patient. And this is known as the element paralysis of the face because it's a disease in the nerve. Now, depending on the lesion of the facial nerve, it can be UMN or element. Now, this is below the nucleus in the nerve, so we classified it as element. So, just imagine if you can see me on the camera better. Okay. If at all I'm having a right facial nerve palsy, okay, when I want to raise my eyebrows, I might be able to raise the left and the right won't go up. So you can find some wrinkles on my left forehead. The right side will not have it. Now I want to close the eyelid. Left will close, right will not close. And you read in ENT also, when there is an attempted closure of the eyelid being done, there is uprolling of eyeball, Bell's phenomena seen. Now when I want to smile or chew, not chew, smile, the face will deviate towards the normal side. So this is something, when I see a patient with a complete facial nerve weakness on one side, it is an element kind of a facial nerve palsy. Okay. Now you know the causes for this problem: unilateral element facial nerve palsy. Unilateral element facial nerve palsy, yes, on one side is seen due to certain disorders like trauma, fracture of the skull, compression of the nerve, direct evidence. Then we have another virus with us, herpes zoster virus. Yes. And there is a name syndrome for this drama that is known as a Ramsay Hunt syndrome. Ramsay Hunt syndrome. And don't forget this one, idiopathic, unknown cause. And I know this idiopathic facial nerve palsy, yes, has got a name again that is known as a Bell's palsy. So don't use these terms very lightly. Ramsay Hunt for herpes zoster and Bell's palsy always for the idiopathic type. But we find patients with us which have got a bilateral facial nerve palsy on both the sides. This is another very hot topic, commonly asked. In ENT, sir also teaches this, that it often happens in patients with Guillain-Barré syndrome. We'll read that topic today, GBS. Infections like HIV and granulomatous inflammation like sarcoidosis. One or two are more here, but just remember these three, the common ones. Okay. Okay. Let me take you into some questions now so that we are able to understand these topics better. All of the following features are seen in myelopathy except facial sensory impairment. Look at this question. Myelopathy, disease of the spinal cord. Okay. If it affects high cervical cord, that means it involves the C1 and the C2 segment. So if there is a myelopathy in the C1 and C2 segment, answer me, will it cause facial sensory impairment? Yes, because of the involvement of what? The spinal nucleus. The spinal nucleus of the fifth nerve will be involved in these patients. Because of this, you can have a problem related to the fifth nerve in this patient. Now, breast pectoral curve is something new for you and me even, because I have to also go back and read. They say somewhere if the lesion is low cervical, if the lesion is somewhere seen as the low cervical lesion or cervical lesion, then in that case we find a breast pectoral jug. In this jug, what do? We tell the patient to lie supine and you strike the knee hammer onto the pectoralis major tendon. And there is sudden brisk adduction and flexion of the shoulder seen. So we strike with the knee hammer, we strike or tap the pectoralis muscle insertion near the shoulder joint, and then suddenly you will find certain kind of a brisk adduction of the arm that occurs. So there is a brisk adduction of the arm on tapping the pectoralis insertion on the shoulder joint, somewhere near the shoulder joint, okay, the humeral end. So this is known as a brisk pectoral jerk. Urgency and incontinence of micturition. Now urge incontinence goes with what? Automatic bladder. Whenever you come across an automatic bladder, the lesion is what? The lesion is likely to be what? The lesion is thoracolumbar. That means the sympathetic part is not at all working now. So brisk jaw jerk is something odd one now. Let me repeat my words. Jaw jerk is brisk. The problem is UMN. The problem is supranuclear. That means the lesion is where? Above pons. Okay. Not in the spinal cord. Myelopathy is a lesion exclusively inside the spinal cord. There's another question which got repeated many times. Cervical cord injury does not cause Horner syndrome. Oh, ophthal again. Ptosis, meiosis, anhidrosis, loss of ciliospinal reflex. Yes, if you remember Horner's. And cervical cord injury can cause Horner's. Why? Because of the damage of what? The sympathetic trunk. Because of that. Loss of sensation over face. Obviously, if there is involvement of the spinal nucleus, then it can happen. Spasticity of foot. Yes. Cervical cord injury is coming from outside. And if the corticospinal tract is involved now, what would happen? Sacral and lumbar will be involved first. That will result in a UMN kind of a weakness. So, spasticity of foot due to cause of the involvement of the corticospinal tract supplying the lower limb. Okay. Wasting with fasciculation of the lower limb. Tell me please, true or false? Just imagine this. Cervical cord injury has occurred. Cervical cord, spinal cord is not working. Correct. Now what will happen? Below the level of the lesion, there is UMN. At the level of the lesion, there is LMN. Is it below the level of lesion LMN, wasting and fasciculation of the lower limb? No, this won't happen because the lower limb clinically will always have a UMN weakness, while the LMN will only occur in the upper limb, not the lower limb. So it's a very clear answer. Question 17 is somewhere from Opthal. Horner syndrome, all are true except meiosis, anhidrosis, heterochromatic iris, apparent exophthalmos. Answer me this Opthal question. Yes, the answer is apparent exophthalmos, not anophthalmos. Now you might wonder, ये कहाँ से है? Heterochromatic iris. I've never heard about this. Arey Baba, this happens in congenital Horner syndrome. Read it back in Opthal. It's being discussed. There's a congenital Horner syndrome in which you find all this problem, heterochromatic iris. But there is always an apparent anophthalmos, not exophthalmos. Got it? So don't get confused by looking at option C. It happens in congenital Horners. This one is easy. Patient with traumatic paraplegia due to injury in the thoracic cord at the T3 level is observed to have a blood pressure of 210 by 120 and the heart rate is 53 per minute. The BP is high and the heart rate is low. We are having what? Autonomic dysreflexia. How do we initially manage this patient? Nifedipine. See, why I'm taking out this question because when I wrote this thing, hypertension, everyone came with the answers. A Cushing reflex, and Cushing reflex, that you wrote Cushing reflex happens in patients with what? Raised ICT, correct? So in a hurry, worry, curry, maybe you might end up marking the answer as steroid. Now, my dear friend, first of all, the question is given as traumatic paraplegia, not head injury. So raised ICT may be seen in patients of head injury, not in paraplegic patients. So please don't mix up this whole concept as Cushing syndrome and in a hurry mark the answer as steroids. No. Easy one. A patient involved in a road traffic accident presents with quadriparesis. All four limbs are weak. So whenever it is a quadriparetic patient, the lesion is what? Cervical. Sphincter disturbances find sensory level up to the upper border of sternum. Answer me please. And the respiratory rate of 35 per minute. Easy question. Upper border of sternum, not T1, T2. It is C4, C5. The upper border of sternum, I wrote it with you. That is somewhere manubrium sterni joining with the clavicular head is C4, C5. Correct? A middle-aged woman is involved in an automobile accident. Following this, she experiences pain around her umbilical area. In addition, she had a bladder and a bowel disturbance. She has got a pain around her umbilical region. She has got paralysis of her lower abdominal muscles and some weakness in her leg. Okay. A subsequent neurological examination, okay, is coupled with an MRI. What is a likely conclusion reached regarding the level of the lesion? Can you localize where is the level of the lesion? Since her pain is around her umbilical region, this is something very well fitting with T9 and T10. There should not be any doubt on this. Okay. During a neurological examination, you ask a patient to stand with the whole hand holes fully extended like this, parallel to the ground. This is something that you've already read and understood, is known as a pronator drift sign. There's nothing new, already the whole thing. Now some tricky questions I've got for you. These are image based questions. If you can see them, it's fine. Look at this one. There's a combined loss written this, combined loss, slightly blur, but read it. This is a combined loss in the blue kind of a shading. That means in the patient's spinothalamic and posterior column both are lost. Answer me please. There is a patient with me below the umbilicus, spinothalamic and posterior column both are lost. It's a combined loss. Below the umbilicus, what disease is it? It's a complete transaction at the level of T10, right? We know this. A. Okay. Now this one, look at this. This is easy. There's a combined loss blue here, spinothalamic posterior column. Okay. Below the spinothalamic is lost here, and below posterior column is lost here. This is nothing but your right hemisection at the level of T3, image B. This is a spinothalamic loss only at this part. Okay. It can be an intramedullary lesion at T3, T6, syrinx cavity, although not so common there, but can happen. Yes. So we can mark it as C. And look at this. Look at this carefully. Blue color shading means spinothalamic, posterior column. Yes. Are involved on both the sides. But one thing is spared, what? The sacral area. Can you tell me, in this patient you find what? Sacral sparing. So please tell me, if there is a sacral sparing, is the lesion intramedullary or the lesion is extramedullary? It's a very simple guess. Apply your mind and tell me, if it is a sacral sparing occurring with a combined loss, is it intramedullary or extramedullary? Yes, it's an intramedullary lesion, because in an intramedullary lesion which starts inside the spinal cord, spinothalamic, not the posterior column, but at least spinothalamic, you will find what? The sacral sparing. Okay. Okay. Correct. So that goes with D. So this is something I'll give you later in the Facebook today, that this is match the following. This we have actually drawn already. I've tried to project it in an image. Okay. Now which of the following depicts the anterior spinal artery occlusion? Answer me. The shaded part is only the spinothalamic loss. This is spinothalamic and posterior column loss both. This is only spinothalamic, and this is glove and stocking. You already know. Please tell me. Which of the following image basically depicts an anterior spinal artery occlusion? Yes, answer is A. You know this. You've already drawn this actually. Drawn with me. Okay. Now I remember a patient, he came in our hospital once, and he came with a complaint that his, upper limb showed wasting and some amount of fasciculation also. That means the upper limb was LMN. The lower limb on the other end showed spasticity with hyperreflexia. That means the UMN. Please answer me, if a patient has come to you with all four limbs weak, quadriparesis, okay, whose upper limb is LMN and the lower limb is UMN, right? Can you localize the lesion for this patient? Can you please localize the lesion for this patient? Where is the lesion likely to be? Yes, it has to be a cervical lesion most likely. Good. Cervical lesion most likely. Okay. But the only problem in this quadriparetic patient like this, I had seen in the patient, that his sensory system was perfectly normal. That means you had a patient with cervical injury but sensory normal. How is it possible? No, it's impossible. It's impossible. So it is not a lesion which is cervical. That was something which I was just carrying in my brain wrong. I thought it was a case of myelopathy, cervical cord injury causing quadriparesis, but this patient had a sensory system intact. That was a problem. It was not a case of myelopathy for me. So what do we do now? We went for a great thing which we always get done in neurology practice, MRI. Because at the end of the day, we always have to correlate it clinically. Now what we did was an MRI of the complete nervous system. And we found in the patient a story like this. His corticospinal tract, which was originating from the brain, crossing the midline in medulla and coming down, and the anterior horn cell which was there in the spinal cord were involved. Look at the diagram, please. In this patient, corticospinal in the brain, corticospinal in the spinal cord was involved, while the anterior horn cell in the spinal cord was involved. Okay. So be with me on this topic. This is a very easy topic to catch. In the patient, if the corticospinal is involved, we have a problem that is UMN type. If in the patient the anterior horn cell is involved, we have a problem which is of the type LMN. Okay. Now I have a patient like this only. But look at the diagram. In this patient, the spinal cord, the rest of it, apart from anterior horn cell and the corticospinal, is perfectly normal. That means the ascending tracts are totally spared by the disease. Only the descending tract and the gateway, anterior horn cell, is affected in them. Now, what are these diseases known as? Yeah, some of you are writing the correct name. Known as the motor neuron diseases. Motor neuron diseases, being abbreviated as a term MND. Now in this patient, as I told you, okay, they've got UMN, they've also got LMN findings, both of them together. Such a patient has got a name with it to explain. The name of the disease is amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis, ALS. Follow the name, please. Sclerosis means degeneration of the lateral column. If you remember, the lateral column was a corticospinal tract which has crossed the midline and coming down. Amyotrophic, the muscle is not getting any trophic factor today because the anterior horn cell has stopped it. Look at this, please. Anterior horn cell has degenerated. Nerve is not getting any signal, not sending any signal to the muscle as well as trophic factor. So the muscle is not getting any trophic factor on the other end because the nerve is not giving it any signal because the gate is closed. So we have a constellation of symptoms which are LMN and UMN both. Amyotrophic lateral sclerosis, ALS. Very important. This disease, ALS, we should know, is something which is affected very commonly the population that you find as elderly. It often affects the population that we see often as elderly population. And one thing which we find is in these patients a typical phenomena, that is fasciculation. Okay. Fasciculation is something that is seen to be pathognomic of these patients. Pathognomic. Why pathognomic? Yesterday when we were reading fasciculation, we told you that something that happens in an LMN injury when the lesion is at the level of anterior horn cell. So same happens in these patients. Anterior horn cell is affected and they have this phenomena which most of the patients don't have it. Okay, fasciculation. But remember this very, very important thing. Few things are perfectly normal in their life. Don't worry. Few things which are normal in them is this. The eye muscles are typically spared. There is no ophthalmoplegia, there is no ptosis at all with them. Second, sensory system is well intact in these patients. Third, the autonomic system with reference to bladder is perfectly normal in them. And most important above all, the cognition, that is the upper story of the brain, is perfectly normal. They don't have any kind of a dementia. Okay. So eye muscles are normal, sensory is intact, autonomic with the reference to bladder is normal, and cognition is also spared in them. Okay. But you should know this fact. Why does this disease ALS, if at all happens, why does it really occur? No. There's a very small explanation attached to it. In a cell, maybe a neuronal cell for an example, after a lot of cell cycles, there is a free radical being generated whose name is superoxide. And there is an enzyme to digest it every time. The name of the enzyme, I hope you know it, is superoxide dismutase, being abbreviated to me as a word SOD. Now the SOD1 enzyme this time is not working well. Because of this, I'll come to that. If it doesn't work well, what will happen? Now superoxide is something which is a free radical, can damage it. Now SOD enzyme is going to convert it into water and oxygen. In between there is a hydrogen peroxide also. I'm leaving that catalase enzyme, but water and oxygen are generated, but that's not a very harmful thing. It's fine. Now in patients of ALS, we find that some of the patients have got deficiency of this enzyme. Once you have a deficiency of this enzyme, what will happen? The superoxide moieties will get accumulated in this neuronal cell, okay? And superoxide moiety get accumulated inside the neuronal cell will kill the cell in a way of a programmed cell death. What is that known as? Apoptosis. Apoptosis. But very important thing to understand here is this. There is someone as a neurotransmitter which can increase apoptosis. How? There is a neurotransmitter which is released from the adjacent nerve. The name is glutamate. It's excitatory every time. And how does glutamate function? You already know that it opens up channels for what? A cation which can easily enter and damage the brain cells further, which is then as what? Calcium. Now when calcium enters any cell, it will obviously increase what? The rate of apoptosis. Why I'm telling this story? Because if you understand the etiopathogenesis, remembering the treatment is quite easy. There's a very old drug that we still use whose name is riluzole. Riluzole. Okay, this is a drug which has been found to actually inhibit the release of glutamate from the adjacent nerve. So there's an old drug riluzole which are still being used that will inhibit the glutamate release from the adjacent nerve. If the calcium doesn't enter because there is no glutamate there, the calcium influx will not occur, or maybe the apoptotic process might happen slowly. That means riluzole as such is not a cure, it's just like a control of the disease in which I can delay the apoptosis in the patient, right? But over the time we got a lot of knowledge on this disease and a lot of researches happened in abroad, and we came across another drug. The name of the drug is edaravone. They found like this, that edaravone is a drug which works like a superoxide dismutase enzyme. Almost works like that. So whatever deficiency we had, we could easily correct it with the help of this new drug with us known as the edaravone. Okay. Now remember the name. It is motor neuron diseases. It's not a singular, it's a plural name. Okay. So we have got two more brothers in the family. Remember the name? Spinal muscular atrophy, being abbreviated as a word SMA. Now in this patient, remember this, there is degeneration seen. It's a neurodegenerative disorder like ALS again. but degeneration is seen at the level of anterior horn cell only. So if it is anterior horn cell with corticospinal, we label it as ALS. If it is anterior horn cell only, we label it as SMA. Find the name. There is muscular atrophy. Yes, atrophy is a sign of element finding. Correct? Element weakness. Due to the lesion in the spinal cord. Where is the lesion now? It is at the level of anterior horn cell. Spinal muscular atrophy. Treatment has been asked quite recently on this topic. That's why I'm taking it out. Nusinersen is a new drug which is available in India nowadays. We are trying this out in treatment of these patients of spinal muscular atrophy. How does it work? Leave that story. Just remember the name. It's more than sufficient. Nusinersen. There is another brother in the family that is known as primary lateral sclerosis. Primary lateral sclerosis, being abbreviated as a word PLS, in which we find in the patient there is degeneration. Okay, there is degeneration at the level of corticospinal tract only. Only the corticospinal tract is involved. This would result in a typical UMN weakness pattern. Follow the name, please. Follow the name, please. Primary, without any reason. Lateral column is involved, corticospinal, and it involves in a form of degeneration. Okay. So nusinersen is a drug applied for patients with SMA. PLS, we don't have any treatment as yet. But ALS, yes, we were using riluzole, which inhibits the glutamate release from the adjacent nerve to inhibit the calcium influx into a dying neuron in order to inhibit apoptosis. But a new drug, which is a free radical scavenger, can be used in patients of ALS, that is edaravone. Now, a famous scientist who passed away, he had this disease ALS. Everyone knows him so well, Stephen Hawking. If you have ever seen him sitting on a wheelchair, he was all the time on the wheelchair because his lower limb was what? Element. Anytime in any of the interview that you must have seen on camera, he was never sitting still like this on the chair. He was all the time moving like this because his upper limb was UMN. So he had a different presentation in every segment. But anytime you would have seen him on a camera, he was looking at the camera so well. His eye muscles were intact. There was no squint and ophthalmoplegia at all with him. Even the sensations he could feel normally. He never had a catheter with him. His bladder was normal. And above all, his brain was sharper than mine and yours. His cognition is perfect. Was perfect. Stephen Hawking. But look at the disease, amyotrophic lateral sclerosis. It is nothing but a neurodegenerative disorder anytime. Correct? And in medical colleges, it has always been said that ALS is considered to be the worst neurodegenerative disorder. Okay, because of the rapid progression of the disease and to a larger extent, no good treatment available with it. I used to wonder why this patient dies, Just imagination like this, If the bladder is normal in the patient, autonomic is normal, okay. If the autonomic system is normal, the heart is beating normal. No one should die if the heart is beating normal. If the cognition is normal, that means the cortex as such is normal for understanding and speaking out. Why did the patient die? I still remember, one of my intern, as usual interns, told me, sir, it's a big challenge, even bigger than the ice bucket challenge of ALS, Sir, when you go and intubate the patient and want to put an endotracheal tube, sir, you ET tube, it's not a blind procedure. You see the vocal cords moving away from each other like this. And you put the ET tube, suddenly the ET tube doesn't go into the larynx, it goes into the esophagus. Now the intern told me, sir, when I go and do a blind procedure, that is putting a Ryle's tube, sir, my Ryle's tube doesn't go into the esophagus. It always goes into the larynx and trachea. Okay, so why does it happen? Why don't they know where they have to go? I said, yeah, you are so lucky. You tell me to put a rice tube just now in the hospital. A rice tube will go in the nasal cavity, will go into the oral cavity, will start rolling there, and very next second it will come out from the oral cavity like a snake. So in internship process, you must have seen yourself that you want to put a rice tube. Instead of going down, it rolls back like this. So why does it happen? The reason is somewhere different from the normal neurological disorders that we find. There's a very small concept of bulbar and pseudobulbar palsy. Now, what is bulbar and what is pseudobulbar? It's very simple. There is a bulb of the brain known as medulla, which happens to contain the lower cranial nerve nucleus with it. The 9th, the 10th, the 11th, and the 12th all together. Now, there is a disease, or rather there is a connection of this medulla from the cortex of the brain with the help of a tract. The name of the tract is corticobulbar tract. Like corticospinal is for the body, corticobulbar is for the bulb medulla. Now suddenly what happens is this. The medulla has stopped working. This is known as a term bulbar palsy. On the other spectrum, the corticobulbar tract has stopped working. This is known as falls, also known to me as pseudobulbar palsy. So there is a bulbar palsy and there is a pseudobulbar palsy in the patient. Two things. How do we differ them is very simple. With the help of symptoms maybe which look almost similar in both of them, dysarthria and dysphagia. Remember this. Dysarthria basically means difficulty in articulation. Dysphagia basically means difficulty in swallowing. These are the terms. We had discussed somewhere earlier also, if the 12th cranial nerve is not working, okay, then we have a problem in moving the tongue. That is known as what? Dysarthria. If the 10th cranial nerve is not working, we'll have a difficulty in swallowing the food. That is known as dysphagia. Dysphagia and dysarthria happens in both of them. Why? Look at this please. In bulbar palsy, the 12th cranial nerve and the 10th cranial nerve nucleus is not working. That's why these symptoms are occurring. Simple. While in pseudobulbar palsy, there is no signal from the brain that is being received over there. That means the Broca's area in the brain should send me a signal towards the 12th cranial nerve through the corticobulbar tract to move the tongue. That is not coming. The cortex in the brain should send me a signal through the corticobulbar tract to the 10th cranial nerve to work. That's why I am swallowing. Okay. So pseudobulbar and bulbar palsy. Symptoms are more severe, in bulbar palsy. That's what we know. Another thing that we have very often is a labile effect. This has been asked this year, last year, every year this question comes, labile effect. The word effect comes from psychiatry, which means mood, and the word labile means a changing mood. In pseudobulbar palsy, remember this, labile effect is seen. In bulbar palsy, it is not seen. What do you mean by the word labile effect? It means uncontrolled emotions. Uncontrolled emotions. Right. That means like a person feels very sad, he starts crying a lot. The person feels very happy, he starts laughing loudly. The emotions are not under the person's control. Okay, like you're asking repeatedly for only one thing, lunch break. Let me ask, he'll give. Nahi milegi azadi. We'll take a break after this topic. Okay, let me complete another 5 minutes, not more than that. Okay, so start looking at your watch. Don't type on the keyboard please, or your keypad. There is uncontrolled emotions in a patient that happens very commonly in patients with pseudobulbar palsy. Right? Pseudobulbar palsy very often comes to us with a labile effect, uncontrolled emotions. Okay, while bulbar palsy don't have it. Now a quick difference between the two is a gag reflex. Gag reflex. Gag reflex, yes. How do you do a gag reflex? If you have ever done it in the ward yourself, you stimulate the posterior pharyngeal wall, yes. And when you stimulate it there, the ninth kidney nerve will set the signal to the brain, and the patient will start coughing through the 10th. So afferent is ninth and the efferent is 10th when I want to do a gag reflex like this. Please be with me on this topic. Bulbar palsy, okay. Bulbar palsy, yes. What will happen to the gag reflex? Answer me please. In bulbar palsy, what will happen to the gag reflex? Will it be brisk? Okay. Will it be normal or will it be absent? Three conditions. Answer me please. In patients with a bulbar palsy disorder, okay, what should happen to the gag reflex? Obviously, it will be absent, no doubt on this. Why? Because the nucleus is not working. Look at the concept now. The nuclear lesions are element. In element, the reflexes are obviously anytime absent. So don't forget, in patients with bulbar palsy, the gag reflex is often found to be absent. Right? In pseudobulbar, apply your mind and tell me. In pseudobulbar, what will happen to the gag reflex? Again, same story. Apply your mind and tell me. In pseudobulbar, when the lesion is corticobulbar, will the reflex be brisk, normal, or absent? Three things. In pseudobulbar palsy, will it be brisk, normal, or absent? When the lesion is corticobulbar, yes, it is supranuclear. In supranuclear lesions, it is UMN, and in UMN, the reflexes are anytime brisk. So you find a good difference between the two disorders with the help of a gag reflex. So what do, you tap it like this, and suddenly there is clenching of the teeth tightly. That is a brisk gag reflex seen in pseudobulbar. Now students ask me this, sir, why do you find labile effect in these patients? I'll tell you the story. Just a word on it, not a full story. You know, this pseudobulbar palsy is often associated with a disease that we have done yesterday, frontotemporal dementia, FTD. If you remember, FTD, frontal lobe behavioral abnormality. So this pseudobulbar palsy is very commonly seen with a disease known as frontotemporal dementia. Now there is a reason behind this. Because the mutation which is causing FTD and pseudobulbar is the same. That is C9 open reading frame 72. If you remember this name, C9 ORF 72, the behavioral variant of FTD. Yes, we have discussed it yesterday. That is responsible for FTD, and the same mutation is seen in these patients. So this is something which we see associated with. So whenever there is a frontal lobe problem, we end up having what? A labile effect. That means a behavioral abnormality. We cannot control our emotions. Now another small difference, small difference. Pseudobulbar patient has got dysarthria and dysphagia, which is referred as spastic. Why spastic? Can you explain me why spastic? Because it is UMN. In UMN you always find spasticity. Now what do you mean by the word spastic, dysarthria and dysphagia? Like I want to speak something. I have a word in the brain and it will come here and maybe talking like this with a lot of effort. Okay. I remember, Modi ji's friend, Trump uncle came before the COVID pandemic, and he pronounced the name of a great saint in a different way. If you remember that, it was a spastic dysarthria. Okay, so that is spastic dysarthria seen in patients with pseudobulbar palsy. That's why I find this Trump as a mad person. Frontal lobe has gone for him. Okay. Which of the following is pathognomic for motor neuron disease? But Modi ji was smart, he pronounced Donald Trump name in a scanning speech. You can just go back and see the videos, you'll understand what I'm talking about. What is pathognomic of motor neuron disease? It is fasciculation. Fasciculation is a simple answer. Okay. Now, conduction velocity of the nerve is not affected in which of the following disorder? Now, this came as a tricky question. Everyone was wondering, like, what is this, sir? But it's simple, na? Conduction velocity of the nerve is affected typically in a disorder like neuropathy. Now, you have to mark an answer which is not a neuropathy disorder. AIDP is a Guillain-Barré syndrome that we'll read today, is a disease which is neuropathy. Leprosy is a neuropathy. Hereditary neuropathy from the name is neuropathy. So what is not affected or conduction velocity is not affected in MND patient? Like look at this. Motor neuron disease is corticospinal, antihonsal. Okay. Corticospinal and the antihonsal. Okay. So that's affected in them. The nerve as such in these patients, there is no disease in the nerve per se. So you can connect this topic with this concept. Conduction velocity of the nerve, we'll read it later on, is affected in disorders known as neuropathy. But in motor neuron disease, the nerve is perfectly normal. There is no neuropathy disorder seen. Okay. Now, a middle-aged man with a progressive atrophy and weakness of hand and forearm. Look at this question. There is progressive atrophy and weakness of hand and forearm. That is element. On examination, he is to found spasticity of leg and generalized hyperreflexia. Now, the lower limb is becoming UMN. Increased signal intensity in the corticospinal tract on T2 weighted images on MRI. Correct? Now answer me. There is LMN in the upper limb and there is UMN in the lower limb. And there is a corticospinal tract hyperintensity in the MRI. I know the answer is ALS because anterior and posterior we are discussing topics related to ALS. But if it comes in exam, you will not strike the right answer. Now, spinal muscular atrophy was only LMN, if you remember. Nothing like corticospinal involvement. Subacute combined degeneration, we'll read later on, is corticospinal only. Okay. And multiple sclerosis will always have a periventricular demyelination, plaque collection. If you remember, we have discussed this. But the answer best fitting is always ALS for them. Okay. This one came recently, unilateral extensor plantar is usually seen in. Plantar is extensor on one side only. That means, answer me. Plantar is extensor on one side. What does it mean? The corticospinal on one side is affected. The other side is perfectly normal. Amyotrophic lateral sclerosis, ALS if you remember, yes, is a disease involving the corticospinal tract and eventually of both the sides they are involved. Cervical myelopathy due to cervical spondylosis, which is a diffuse disease. Again, both sides is involved, correct? Multiple sclerosis, periventricular demyelination can involve corticospinal, yes, on both the sides. But the answer is very simple. Even if you don't look at the option, go to D, you will answer it correctly. There is a right MCA ischemic stroke, which will result in left-sided weakness and UMN sign only on one side, not on the other side. So answer by exclusion maybe or by inclusion is always D. There should not be any doubt on this because in rest of the disorder, corticospinal could be involved on both the sides. Which of the following drug is used in treatment of spinal muscular atrophy? We know this as nusinersen. Okay, we read it. Oh, the image went missing. I don't know where. Okay, I can just make it as this. Jaw jerk will be brisk in all of the following conditions except. Jaw jerk will be brisk in all of the following conditions except. Answer me please. Very simple question. Any guesses? Jaw jerk is brisk when the lesion is eumen. That means when we have a lesion sitting above pons. Correct? That's the concept. Pseudobulbar palsy was above medulla and just above that was pons. So we can have a problem like this. The corticobulbar tract, which is coming down, okay, can be involved in a lesion that is suprapontine here. Yes, you can have a brisk jaw jerk in pseudobulbar. Motor neuron disease is another disease in which corticospinal tract is involved and even the corticobulbar tract involved, like in pseudobulbar palsy. So again brisk. MS is a disease in which again suprapontine lesions are there in the cortex. Answer is syringomyelia. See, basically the question being asked indirectly is that which of the lesion is not maybe a cortical or maybe a supranuclear lesion. Answer is very simple, syringomyelia. Why? Syrinx cavity happened where? Did it happen in the brain? Na baba. It happened in the spinal cord below. So will it come to me with a brisk jaw jerk? No, this won't happen. Okay. Happy? विनोद खुश हुआ? So we'll take a lunch break. That you are actually, you come for taking break sometime. I feel you have to come. Welcome back into the post parental session, right? Let's start. Let's move into another zone, which is somewhere related to the brainstem and the various syndromes related to it. Okay. For this, we'll start with a very basic concept about the brainstem and what does it really contain inside it. Okay. If you remember, the brainstem was a house for almost every cranial nerve except for the first two. Okay. And it was also a passage for any sensory input which was going up after crossing like a lemniscus, or it is coming down like a corticospinal tract. Okay. Now we'll make a rough diagram to understand this, the brainstem and especially the cranial nerve nucleus. The cranial nerve nuclei which are located in the brainstem. And where all are they located inside? For this we'll make a rough diagram in which we'll make a box like this and we'll divide it into 3 floors. Okay, and we'll take this dotted line as a midline. Okay, and now we'll try to make these 3 boxes into different zones that we know. The topmost floor of the brainstem is a midbrain, and then after that comes is a pons, and later below comes is a medulla. Right. Now the third and the fourth cranial nerve. If you remember, the third and the fourth cranial nerve is having a house in the midbrain. Third, the oculomotor nerve, and below that is the fourth cranial nerve. Both of them are having a house in the midbrain, the cranial nerve nuclei. Why I'm making this above and this below? Because of the basic concept. There are two sections of the midbrain taken. One section is taken above, that is superior. Another section is taken below, that is inferior. So we have this concept like colliculi or colliculus. Okay, if you remember, the superior colliculi or the superior colliculus was receiving the input from the eye. The inferior colliculus was receiving the signal from the ear. And at the section in the midbrain, if I take it, the superior colliculus level, the third nerve is sitting. At the level of the inferior colliculus section, fourth nerve is sitting. Right. Then we have the cranial nerve nuclei of the 5th, 6th and the 7th sitting in the brainstem. We got a nucleus of the 7th cranial nerve sitting in the brainstem. Adjacent to it is a 6th cranial nerve sitting in the brainstem. Also we have got the nucleus of the 5th nerve also sitting. But I am trying to make two nucleus of the 5th nerve over here. If you remember, the 5th nerve was sensory as well as motor. So the motor component of the 5th nerve or the nuclei which is motor for the 5th nerve is sitting somewhere in the medial part, of the brainstem in pons, while the sensory part is lying slightly lateral. So whatever signal from the spinal nucleus has to end, it has to end in a primary sensory nuclei in the brainstem in pons, that is lateral, while the motor nucleus of the 5th nerve is medial, right? Then we got the 8th. Remember this very simple trick, the cranial nerve nuclei which I know as motor or sensory. Remember this way, the cranial nerve nuclei which I know as motor or sensory, the motor nuclei are always found to be medial, while the sensory nuclei are more commonly found to be lateral. M for motor, M for medial, this is how you can remember them easily. Like the 3rd and the 4th are not sensory nuclei, they are the motor nuclei, so they are medial, okay? While the sensory nuclei of the any cranial nerve is always seen to be lateral. Like the 5th, for example, the motor nucleus in pons is medial, while the sensory nucleus in pons is found to be lateral. Then we have another cranial nerve, that is 8th. If you remember 8th, right? 8th cranial nerve, vestibulocochlear nerve, correct? It was located in medulla in the upper part with a border with pons. Now please tell me, 8th cranial nerve nuclei will be medial or lateral? It's a very simple guess. 8th cranial nerve nuclei in the brainstem will be medial or lateral in the brainstem? Answer me please. It is a sensory nucleus because it is receiving a sensory input. No, my dear friend, 8th cranial nerve nuclei will be lateral. Why lateral? Because it is receiving a sensory input from the auditory pathway. Yes, so it is going to be lateral. Then we have a combined nucleus, the 9th and the 10th. Okay. Now 9th cranial nerve, if you remember, was a sensory nerve. The 9th and the 10th cranial nerve nucleus combines together. Can someone of you tell me what is the name of this nucleus, which is present in the lateral part of medulla, and the nucleus doesn't know who is he, and we also don't know who is he. It is somewhere ambiguous. Yes, the name is nucleus ambiguous, right? 11th also, yes, 11th also, some of the authors write 11th is also a part of it. It's okay, correct? Then there is a 12th cranial nerve nucleus. Now apply your mind, apply the formula and tell me 12th cranial nerve nuclei will be medial or lateral? It's a very simple guess. 12th cranial nerve nuclei will be medial or lateral in the brainstem? 12th cranial nerve is moving the tongue for articulation of speech. Correct? So it is a motor, and motor wala is always medial. Good. See, I'm not teaching you anything hi-fi. You already know most of the things. We're just trying to arrange it in your brain. Now, why am I made this diagram? Simple guess again. There is a lesion in the lateral part of the midbrain. Will any cranial nerve palsy happen? No, it has to be in the medial part. If there is a lesion in the lateral part of pons, facial nerve sensory will be gone. Motor will be spared. Correct? 12 cranial nerve nuclei. Medial part of medulla will be lost. Yes. While the lateral medullary syndrome we'll discuss will have the involvement of the 8th, 9th, 10th and the 11th. In the lateral part of medulla, I just forgot this also. There is an ascending tract. Okay, I can include it under cranial nerve. Okay, there is an ascending tract which is moving up in the lateral part of medulla related to the cranial nerve 7th, 9th, okay, 7th and the 9th mainly. Yes. Can you tell me what is this tract? 7th and the 9th cranial nerve taking up to the brain. What is this? Yes, we have drawn this yesterday. It was carrying a signal of taste to the brain. What is that? Nucleus tractus solitarius. NTS. Good. So in a lateral medullary syndrome, nucleus tractus solitarius will be gone, taste will be lost. 9th and the 10th will be gone, so there can be a problem related to dysphagia. 8th can also be gone, so there can be some ataxia. Simple concept. Medial medullary syndrome will have the involvement of the 12th, that will cause dysarthria. So if you have this concept of all these kind of things in your mind, then it's very easy. Okay. Now looking into the brainstem again in a different way. See, there can be some discrepancy between me and the anatomy textbook. See, what I'm trying to teach you is not a hardcore anatomy. I'm trying to put it in a simpler way in which we can understand the clinical syndrome. So there can be some problem in few of the nucleus, are they lateral, are they medial and all that. But this is more than sufficient to understand most of the syndromes. Okay. Now we have got tracts which are moving up in the brainstem, which are known as the ascending tracts. Ascending tracts. Increase the volume. Okay, I'll just try to adjust it fast. Bob Ray, I'm already at 10 decibel. I'm at the under mode. Can't you hear me? Oh my god. Am I audible? Am I visible? Am I louder now? Am I louder now? Is my voice okay now? Midbrain, pons, and the medulla. Okay, the nation can hear me. Okay. Yeah, there's a little break in my voice post-pharyngeal, I agree, In the post-pharyngeal session, student and teachers become nephrons of acute tubular necrosis. They cannot concentrate. Okay. Now, ascending tract. Let's try to reach every ascending tract in this. There's one tract that we all know. I'll make a spinal cord section also to make it very clear what are we going up in the brainstem with, right? Now we got a spinothalamic tract which enters from the posterior side with the pain, touch and temperature, crosses the midline in the interior half of the spinal cord, 1 or 2 segment above, and then it happily goes up in the sorry in the brainstem as a lemniscus known as the spinal lemniscus. Okay, right. So there's a spinal lemniscus which is running up with a signal of pain, tension, temperature in midbrain, pons and medulla. And look at the diagram please. I've tried to make it on the lateral aspect. Make it very clear, when the brainstem is trying to develop somewhere, the sensory part comes lateral and the motor part comes always medial, like this. Okay. Then we have another track with us that was known as the posterior column. The posterior column is going to go up, yes, end at a point that is a nucleus gracilis and cuneatus in medulla, and then it is going to cross the midline and it is going to ascend up as what? If you remember, the name was medial lemniscus. Now that's the aberrancy part, that it is sensory but it is placed in the brainstem medial. That's why the name medial came for it. Just to remember it better, it is running up in the brainstem, although sensory, but in the medial part, medial lemniscus. Right. Same goes for a cranial nerve fifth. I'll make the fifth now. The fifth cranial nerve comes with a sensory input from where? The face and the cornea that we have discussed. Will go up in the lateral part of medulla, yes, and will end in a nucleus which is there in pons, again in the lateral part. And the part which ascends up in C1 and C2 segment, and one part which ascends up in medulla, together what is this known as? If you remember, together it is known as what? The spinal nucleus. Okay, so this is defined as a spinal nucleus for me. When it ends in pons, yes, it will happily cross the midline and then go up as what? A lemniscus, which is known as a trigeminal lemniscus. Simple concepts. We have already done this homework since yesterday and today morning. Okay, correct. Things are very clear, things are very simple. Any lesion in medulla, pons and midbrain in the lateral part involving the spinal lemniscus will cause loss of pain, touch and temperature on the contralateral side. Any lesion in medulla involving the medial lemniscus, in pons medial lemniscus, in midbrain medial lemniscus will cause vibration, joint position sense loss on the contralateral side. Any lesion in pons, midbrain of trigeminal lemniscus will cause sensory loss on the face and cornea on the contralateral side. While any lesion in spinal nucleus in medulla or the spinal cord for the fifth nerve will cause ipsilateral loss. Correct. So that's the ascending track, you already know this. So if there is a medial medullary syndrome, medial lemniscus is involved, vibration, joint position, fine touch will be lost. While if there is a lateral medullary syndrome, the spinal nucleus of the fifth nerve will be lost, as well as the spinal lemniscus will be lost. Okay, we'll come to them individually. Now a very simple thing. Descending track. Now as the name suggests, it's coming down from the cortex, the motor cortex, the corticospinal tract for me. So I'll make again 3 boxes. You can make a small diagram for it, do not make a big one, because there's only one tract that we try to consider clinically here. The midbrain, the pons and the medulla. Now the corticospinal tract originated from the cortex, yes. It ran down in the midbrain in the medial part. It came to the level of pons again in the medial part, but in the lower part of medulla, I again stress at the lower medulla, it crosses the midline. Yes, it crosses the midline to come down in the spinal cord in a slightly lateral part to end at a gate anterior horn cell to become a nerve for a muscle. Yes. So this is the projection of your corticospinal tract. More important. Now, very simple guess, any lesion in the medial midbrain, medial pons, medial medulla will cause what? Contralateral weakness. Any lesion in lateral pons, lateral midbrain, lateral medulla will not cause any kind of a weakness. Got my point? Because corticospinal is not running down there. We have been following this in myelopathy. Any lesion in spinal cord below medulla, of course, will cause the ipsilateral weakness. Okay, so I've tried to draw rough diagrams to go into this topic. It's a very simple brainstem syndromes. Okay, because for me brainstem syndromes used to be like Stree. It was like a ghost. Stree movie you must have seen, but it's based on an old Kannada saying "Nade ba." I'm not pronouncing it correctly, which means come tomorrow. Whenever a student sees a difficult topic and it comes in exam, the only thing that he says is "Nade ba, come tomorrow." And next day when he comes and sees the topic, he again says the same topic, come tomorrow, until the ghost meets you in somewhere in the exam hall by calling out your name. Okay. The spinocerebellar tract, I'll deal with them in ataxia differently. Okay. Okay, now take one full page for this work. Take full one page. Okay. Take one full page for this and we'll write midbrain. Midbrain. Now I'll make a transverse section of midbrain. I'll make a transverse section of midbrain. So this is the transverse section of midbrain that you know. Okay. We'll try to differentiate various parts of the midbrain. Right. If I know this part, which is a smaller part of it, is known as the tectum of the midbrain. This wala part is the tegmentum of the midbrain. This wala part you already know is substantia nigra, the depigmented part which is supposed to synthesize dopamine for me. And this was the interior part that was carrying down the facial and the fibers of the corticospinal tract known as the crus cerebri. Okay, why I've tried to differ them into various parts is a reason because everything is going to be separated from each other depending on these parts. First, I'll start with the third cranial nerve. Third cranial nerve has got a nucleus in the midbrain and that is located in the tectum part of the midbrain. It is a cranial nerve which is motor, yes, and it is going to exit out like this. In the medial part of the midbrain, it's going to come out like this, right? Now, one thing I want to clear at this point, this is a midbrain section at the level of what? Superior colliculus. Because fourth cranial nerve syndromes are not given in any of the brainstem syndromes. So whenever they want to consider syndromes of midbrain, they always consider to be like this in the level of superior colliculus. So I'm not showing the fourth at all in it, just to avoid any confusion. Now, apart from this, in the tegmentum part, there are few things located. One thing which is located in the tegmentum part is a nucleus. Okay. It's red in color. Yes. Rn. This is what is known as a red nucleus located in the tegmentum part of the midbrain. Good. Now you know this from neuroanatomy very well. What is this red nucleus connected with? Can you guys tell me? What is this red nucleus connected with? Can you give me an idea? It is connected with what? The cerebellum, the dentate nucleus over there. Yes. So the red nucleus on this side has been connected with the cerebellum of the opposite side. Yes. Now, what we find here is that if at all there is a lesion in red nucleus in the midbrain, the patient is going to have symptoms of cerebellar ataxia and all that. On which side? Contralateral side, because the connection is always from the contralateral cerebellum. Remember this. There is a tract which tries to run between the red nucleus and the cerebellum, and this is something which is going to affect the patient in a way cerebellar, like a lesion in a midbrain. Yes, will affect cerebellum also by the involvement of this dento-rubro-thalamic cortical pathway. Yes, so the symptoms cerebellar are going to come from the opposite side. Okay, contralateral. Now the crus cerebri. Crus cerebri has got fibers which are running down from the brain, the corticospinal fibers, as well as the corticobulbar, or I can use the word as frontoparietal fibers to explain it better. So there are frontoparietal fibers also now. What is the mean by the word frontoparietal? See, one thing is very clear in anatomy. Where you start with, it's not frontoparietal, it's frontopontine. Where do you start from? You always put the name front prefix, and where you end in, you always put the name later on the suffix. Frontopontine fibers. Remember this. These are the fibers which are regulating one cranial nerve for me. For smiling, seventh, or the facial nerve. So frontopontine fibers are there which are regulating the movement of the facial muscles, okay, which are lying medial to the corticospinal tract in the crus cerebri part of the midbrain. Okay. Right. I'll do this. I think so. This should be much visible for you. Now, midbrain section at the level of the superior colliculus. The third cranial nerve is located in the tectum part, and red nucleus is located in the tegmentum part. The frontopontine fibers in the crus cerebri, and the corticospinal tract just outside or lateral to it. Okay. There are a lot of things apart from this. I'm not taking them out because it is just going to invite a lot of confusion. Now the very first syndrome. Write it carefully. There is an involvement in these patients of the tegmentum part slightly and the crus cerebri. This syndrome has got a name as the Weber syndrome. Weber syndrome. In Weber, what do you find? Third cranial nerve is involved. Yes. The frontopontine fibers are involved. Yes. And the corticospinal tract is involved. Okay, Weber syndrome. It's Weber's or Weber, it doesn't matter much. It's Weber, I think so. Confusing me also. Already my grammar is very weak. Third cranial nerve. Third cranial nerve involvement on this side, yes, will cause ipsilateral third nerve palsy. Okay. If the frontopontine fibers are involved, it is going to cause facial nerve palsy. Of which type can you tell me? Of which type can you tell me? It is going to be of the type UMN because the lesion is above pons, supranuclear, so we define technically it as UMN. Corticospinal fibers are involved, yes, so it is going to have a contralateral weakness. Okay. Second syndrome now. Second is a syndrome which involves this part. This is known as a Claude syndrome. Claude syndrome. What is this Claude syndrome? Claude syndrome. In the Claude syndrome, what do you see? There is involvement of one red nucleus in the patient. Second is the third cranial nerve. Again, I'll ask you, why ipsilateral third nerve palsy? Arey Baba, third nerve of same side is involved. Why contralateral? It has not crossed anywhere. It is just coming out like this. Third nerve palsy on Claude syndrome will also cause the ipsilateral third nerve palsy. Okay. Red nucleus involvement will cause ataxia. On which side? Contralateral side, opposite side. Because it is connecting with the cerebellum of the opposite side. Are UMN facial nerve palsy will cause which quadrant weak? Tell me. If this is the midbrain lesion, the disorder will come on the contralateral lower one third. Okay. Now there is a combo of the two. Weber and Claude together. Plus and plus. This is known to me as a Benedict syndrome. Benedict syndrome. I'll caution you on this because in Harrison itself, in volume 1, they have given a different version of what I have written. Slightly different, not too much different. Hardly matters. I've tried to follow my textbooks of neurology like Adams, Bradley, and even Dijon, where it is clearly given like this. Benedict is Weber plus Claude. I'm very sure when you go back and read somewhere else, you'll always have a controversy on this. Take my words, in clinical settings also we find it the same. Benedict is Weber plus Claude. Okay. Okay. So these are the three syndromes for you to understand. So where do we make our Benedict syndrome? We'll make Benedict also in this diagram. Maybe I can make it on the opposite side. It's a diffuse kind of a disease like this. Now this one is the Benedict. Okay, so we have a Weber, we have a Claude, and a combo of the two becomes a Benedict syndrome. It's asking this question, I don't know. They've not attended the morning session. Why in element the complete face is weak? If I cut a cranial nerve, when it has left the nucleus, it is supplying the face completely. So you have this complete facial nerve palsy. Why contralateral ataxia? Red nucleus is connecting with the cerebellum of the opposite side. So all the cerebellar symptom will be seen opposite to the lesion. Okay. Gait ataxia can occur. Yeah, see, the ataxia means a gait disorder also. Read it again. I think so you guys are getting unnecessarily confused. Okay. So just remember this way, red nuclear lesion in midbrain will always cause a contralateral ataxia. Okay. Don't get over confused because you've got too many knowledge in your brain, this syndrome, that. Just remember these three. Okay. Now take another one full page, one full page again. Okay. The substantia nigra disorders are not so common in these patients. We have not documented like Parkinsonism kind of a disease. Now take one full page and we'll go to Pons now. Nottinghal, oh Nottinghal, Opthal. You read it in Opthal, you have read it in Opthal. Okay. Yeah, I know anatomy people keep on telling a different story on this, that Benedict is Nottinghal plus Claudia Renedo. This is what is given in Dijon, right? Go with it. If you open up many books, Vishram Singh of Neuroanatomy, it is a good different version of everything. Okay, Nottinghal you have read in Opthal. I'll not go into Nottinghal. Read it from their notes. Okay, it's given there. Pons, right? Pons is something which is having a house for a lot of cranial nerve nuclei. One of them is this, the seventh, right? Okay, and just adjacent to it becomes the sixth. I've been very careful in marking it because somewhere the exit of the seventh cranial nerve will be around the sixth cranial nerve like this. So on either side, the seventh cranial nerve will be medial in the nucleus, but the exit of it will be lateral. Okay, sixth is this, seventh is that. Okay. Now there is something which is coming down in the whole drama with the information of the movement of the body, that is known as a corticospinal tract. So corticospinal tract is in the medial part of the pons. Just behind this we find the projection now going up, yes, of the vibration and the joint position sense, that is your medial lemniscus, okay. And then somewhere maybe in this back side we've got a connection. Can you tell me this part? I'll be very happy. This is a connection of the sixth with the third cranial nerve on either side. If you remember the previous classes in Optal also, they discussed this concept that the frontal eye field will give a signal which will go to the sixth cranial nerve of the opposite side, and now the third will receive the signal through this. It's a bundle of fiber which moves longitudinally from sixth towards the third. Yes, the MLF, medial longitudinal fascicle. Good. Okay. Now there is this fifth nerve sitting here. Okay. And in the lateral part of pons we have the sensory part of it. Sensory component of the fifth nerve, the sensory part, the sensory nucleus actually. And then laterally we have a peduncle which is connecting the pons with the cerebellum. Can you tell me the peduncle? A very simple concept. If I look at the cerebellum, this is the cerebellum for me. So if I look at the cerebellum, it is connected to the brainstem anteriorly. This connection is with the midbrain. This connection is with the pons, and this connection happens with the medulla. And what are these connections? Yes, this one is a superior cerebellar peduncle, this one is a middle cerebellar peduncle, and this was the inferior cerebellar peduncle. Okay, you know this. Good, happy, Mugambo bahut khush hua. So middle cerebellar peduncle on either side. See, keep it simple, keep it simple. If you take a cross section given in your textbook, you will go mad somewhere. Even I take a day time to understand what is going on in the sections. We are just concerned in medicine to know the neurological deficit. So I'm not putting a lot of masala into it and just keeping it as simple as possible. Okay. Now what we see is this. The first syndrome, a very important one to read, is this. Again, a controversy. Some of the authors do believe like what I'm telling is not there, but we'll follow the standard textbook. There's a syndrome which happens in the ventral pons, okay, the interior part of it. The name of this syndrome is Miller-Guebler syndrome. Now, as you can see in this diagram, what happens in a Miller-Guebler syndrome? What are the things involved in them? There is involvement of this 6th cranial nerve. Yes. There is involvement of the 7th cranial nerve. Yes. Also, there is involvement of the corticospinal tract. Again, I warn you on this because some of the authors don't include 6, some don't include 7, but most of the higher books, they put them all together. Okay. 6th cranial nerve is lost on the same side. See, this is not crossing anywhere the midline, So we find the ipsilateral 6th nerve palsy. It's very clear in the diagram also. Can you guide me if it is a 7th nerve palsy this time? Please guide me on this. Will it be LMN or will it be UMN? My question is, will it be LMN palsy or will it be a UMN palsy? It's a disease in the nerve that you find. Correct? It's a disease in the nerve that you find. It has to be what? LMN. LMN facial nerve palsy. Corticospinal tract involvement. Now that's important. Corticospinal tract involvement will cause weakness. Please guide me on this again. Be with me on this. It's a very simple trick to remember them. Corticospinal tract involvement will cause weakness. On which side? Same side or contralateral side? Of course, contralateral side because the lesion is still above medulla. I can show this in a diagram. I can show all this thing in a diagram. You know what happened with my patient? He had a lesion in his pons on this side. Okay, I can mark this as a pontine lesion with a cross. Okay. So the weakness happened on his body on the contralateral side. Fine. But the facial palsy, since it was LMN, happened on the same side. Look at this, please. In this very patient, when the lesion was in pons, Miller-Guebler syndrome, the body was weak opposite to the side of the lesion, contralateral, but the face was weak on the same side of the lesion, LMN. Can you see this and tell me what is this known as? This is weak. Half face is weak. Half face is weak, half body is weak. But both of them are weak on the opposite, diagonally opposite side. Yes, some people are giving me correct answers. Mogambo बहुत खुश हुआ. Crossed hemiparesis. I tell you in MBBS, the first thought in your mind to read brainstem syndrome was this. Because in Viva they asked, tell me what is crossed hemiparesis. And every student answered like this, sir, hemiparesis which is occurring due to opposite cortical lesion. Examiner said only one word, cross from here. Okay. So it is a pontine lesion. Okay, not a cortical lesion. Right? Now let's look into the second syndrome. Again, a controversy in the naming part. Again, I'm using this word because many authors, many things they have tried to see. What happened, I've seen in the standard textbook like Harrison or even Bradley, they have not given any name for them. They just made dents, ventral, dorsal, lateral, and they keep on mixing everything together. But most of the examiners I've seen, they ask you these name syndromes, very common. Chalo. Now that's the next one. The next falla is this. Which is actually occupying anterior and posterior part of pons. Look at the diagram, I'm trying to make it in such a way that it is occupying the anterior and the posterior pons, but it is from anterior to posterior, but most often in the medial part of pons. Okay. This is a medial pontine syndrome you can understand through. The name of this syndrome is the Fovley's syndrome. What are the things involved in a Fowley syndrome? Let's try to write it in a sequential order. Okay. There are two cranial nerves nuclei involved. Now I'm using the word nuclei this time. Be careful, nuclei is involved. Seventh cranial nerve nuclei is involved. Okay. You can see corticospinal tract is involved. Fine. The medial lemniscus is involved. Yes. And the MLF is also involved. Okay. Grammar. Please correct my spellings, please. 6 cranial nerve nuclei. Okay. We find in the patient ipsilateral 6th nerve palsy because it has not crossed. 7 nuclei involved will cause 7th nerve palsy. Of which type? See, again I repeat my words. Nuclear involvement will present clinically to me as what? LMN. Tick. Corticospinal tract is involved. Contralateral weakness will happen in the patient. Okay. MLF is involved. Can you tell me if someone is telling me UMN? LMN. Nuclear lesion is LMN. Medial lemniscus is involved. We'll have what? Contralateral loss of what? Vibration and proprioception of the joint position sense. Medial longitudinal fascicle is involved. We'll have what? Internuclear ophthalmoplegia. We have done this earlier. We have done in ophthal also, I know this. Okay, so this is a Fowley syndrome. Right. Another syndrome that is sitting on the lateral part of pons. Now we have done a medial syndrome, we have done a ventral anterior syndrome. Now we'll go to the lateral part of it. There is a syndrome which sits on the lateral part of the pons like this. This wala has got a name as the lateral pontine syndrome. Lateral pontine syndrome. But everywhere we want to give it as a name. It's known as the Mary-Fox syndrome. Okay. In these patients, I just forgot to mention this also. Spinal lemniscus is also involved. So spinal lemniscus was going up like this, So in these patients, spinal lemniscus is involved. Fifth nerve sensory nucleus is involved. Okay. And the middle cerebellar peduncle is also involved. Quickly tell me what would happen in the patient. Contralateral, okay. Contralateral, yes. Loss of pain and temperature sensation in them because spinal nucleus is involved in them, right? That is connecting the spinothalamic of the opposite side. The fifth nerve sensory part is involved, which is receiving the impulse from the spinal nucleus. So ipsilateral, facial, sensory loss can occur. One thing you know from anatomy that whenever the peduncles are injured, you find ataxia on the same side, ipsilateral. Any doubts except for when the class will end? Class will end at 9 p.m. You have given me the answer earlier. Let the neuro end, then I'll start with endocrine maybe at 6 p.m. onwards. Okay, depends on your speed, the internet speed also. Okay, so this is something, the lateral medullary or the Mary-Fox, lateral pontine or the Mary-Fox syndrome. There are 2-3 more syndromes, I know that, but it's too much for you guys. At least you remember 3 syndromes at least in every section is more than sufficient. What is written in MLF is internuclear ophthalmoplegia, INO. Yeah, the trigeminal lemniscus is not that thing which has been mentioned with it. Okay, most of the authors have mentioned the sensory nucleus, which is receiving the efferent from the fifth only. Okay. Okay, someone is encouraging me to be quick. Very good, I'm happy. Now, we have a medulla part, very important. We have got a medulla also, which is there in the lower part of the brainstem. See, about the fifth motor part, they were not mentioned in any of the syndromes. They've tried to omit it because they don't find that can more handy in most of the syndromes. Okay, medulla. Now we find this part medulla in a transverse section as a butterfly shaped structure. You know, it's not made a good butterfly, but still it's a butterfly kind of a structure. And we find a lot of things which are sitting in the medial part of the medulla and some of the things which are sitting on the lateral part of the medulla. Now let me start with the medial part of medulla first. There are pyramids which have not crossed as such with the tract corticospinal in the interior part, we know this. Behind the corticospinal in the medial part, we have the medial lemniscus with us. Okay. And then behind this is a 12th kidney nerve. The 12th kidney nerve is something which is coming out with a signal on the medial part of the medulla again, like this. Okay. So first syndrome that we'll like to understand through this diagram is a syndrome involving the medial part of the medulla. Okay, I'll just shade it like this. So there's a syndrome which is there on the medial part of the medulla. It's all very clear in this diagram what will happen with the patient. It's very simple. Follow the diagram. Medial medullary syndrome, correct? Now in medial medullary syndrome, what are the things which are involved? As you can see in a sequence, anterior to posterior corticospinal, the medial lemniscus, okay, and the 12th kidney nerve, right? Answer me, it's very simple. If the corticospinal tract is involved in the patient, we're going to have a contralateral weakness. Now make this very clear. Most of the authors that they mention the medial medullary syndrome, they mention before the crossing over. So this is a section of the medulla which is not taken exactly at the lower pontine level, slightly above it where the fibers haven't crossed yet. So we're going to have a contralateral weakness in them. Medial lemniscus, yes, will cause contralateral loss of what? The posterior column sensation, that's the vibration, and the proprioception. 12th nerve is gone, yes, and it will cause the palsy of the 12th nerve on the same side. Ipsilateral, some fugax happened, don't worry. Oh my god, it's recurrent now, don't worry, we cannot. Ipsilateral 12th nerve palsy. Right. Now can you guide me on this? You know this from anatomy, I'm 100% sure sir has taught you this, that if this is the tongue, if I see, and the lesion is in medulla, the medial medulla, involving the 12th kidney nerve, when I tell the patient to protrude the tongue, will the tongue deviate towards the lesion or will it deviate away from the lesion? You can just type A or B. That means, is it deviating towards the lesion, the site of injury, or is it deviating away from the lesion? When I tell the patient to protrude the tongue out. Very good. क्या बात, मोगैम्बो बहुत ही खुश हुआ. Yes, because when I protrude my tongue, the tongue doesn't fan out. I'm not a snake who's going to hit everyone. You know, see a teacher, and now the tongue is protruding out like this. When the tongue is protruding now, the fibers which are moving the tongue outwards are trying to contract the muscle medially inside the tongue. Now what happened is, if this muscle is weak on this end, right, the opposite wala will try to drag it like this. So the deviation of the tongue happens towards the lesion, to the side of the lesion. Why I'm telling this? Because on the face, yes, because on the face, if you remember, facial nerve palsy, when I asked the patient to smile, correct, the muscle that happened to move on the face was what? The risorius muscle, correct. Now the risorius muscle was stretching the lips laterally like this, and there is a facial nerve palsy on this side. So this side there is no movement at all of the face, and the face will be dragged to the opposite side. So have this clarity in your mind. In a facial nerve palsy, the face will deviate towards the normal side. Okay. While in a 12th nerve palsy, the tongue will deviate towards the abnormal side. Have this clarity in your mind. Okay. Medial medullary syndrome. Now let's go to the lateral medullary syndrome. There is a lateral medullary syndrome with us, in which we find like this. Initially I'll try to make this one. There is a peduncle which is connecting the lateral medulla. There is a peduncle which is connecting the lateral medulla with the cerebellum, the inferior cerebellar peduncle. Okay. And then there is a kidney nerve which is at the junction of pons and medulla, the 8th kidney nerve with us, right. Then we have another kidney nerve sitting, I'm not going in a correct order but approximate order, that is a 5th kidney nerve, the spinal nucleus of it. Then we have 9th, 10th and 11th combined together, that's the nucleus ambiguous also. Okay. Then we have ascending tract which is going up, that is the spinal lemniscus. And we also have got a sympathetic trunk somewhere over here. I may not be correct in the order, but it's fine, but at least you can remember it. Now we'll go in a very systematic manner. Look at this. If the 8th nerve on this side is gone, don't tell me that we're going to have deafness. No, we are going to have a problem in the vestibular part with ataxia. Same happens due to involvement of the inferior cerebellar peduncle. If the inferior cerebellar peduncle is involved, we're going to have ataxia. But every time it is going to happen on the same side of the lesion, ipsilateral. Correct. Now the 5th nerve. 5th nerve, spinal nucleus is involved. We're going to have the sensory loss of the 5th nerve, yes, on the same side, ipsilateral. because the spinal nucleus is not crossing anywhere, it's bringing the signal of the fifth nerve from the same side. Nucleus ambiguous, if it is involved, there can be some problem in voice production, that is hoarseness, right? While the spinal lemniscus is involved, now this is important, we're going to have contralateral loss of pain and temperature sensation because lemniscus injury is going to cause this problem. While the sympathetic trunk, if at all is involved, will result in ptosis, meiosis, anhidrosis, that's known as the Horner syndrome, right? Okay, you can include vertigo also, because of the eighth nerve. Now I want to explain this in a different diagram. Like my patient has got a sensory loss. In this case, for example, I'm taking this case. There is a lesion in medulla at this point. Okay. Due to the involvement of the spinal lemniscus, the anesthesia of pain and temperature is happening on the opposite side. Correct? But due to the involvement of the facial spinal nucleus, the sensory loss on the face is happening on the same side of the lesion. Yes. So this is anesthesia on this side and anesthesia on the opposite side. What do you name this as? What do you name this as? Crossed hemianesthesia. Like crossed hemiparesis was a pontine lesion. Crossed hemianesthesia is something which is involving the medulla. I agree, fifth nerve nuclei was in pons, yes, but this is the spinal nucleus. Don't forget, this is coming down from the spinal cord and going up. The primary sensory nucleus was there in pons. The spinal nucleus is below. Okay. There is an innervation of sympathetic trunk from this end of medulla, the lateral part. Okay. Another quick fact in the lateral medullary syndrome that you should not forget. Lateral medullary syndrome. Right. It occurs due to involvement of which artery? Can you guys tell me on this? You have read this in anatomy, I'm sure. The lateral medullary syndrome occurs due to occlusion of which artery? Lateral medullary syndrome occurs due to involvement of which artery? Crossed hemianesthesia occurs in this only, lateral medullary. Basilar, pica, vertebral. Remember this, it occurs due to involvement of vertebral artery more than the posterior inferior cerebellar artery, pica. There have been documented fact on this. Vertebral more than pica in them, most of the times. Okay? Right. So that's a syndrome related to the medial and the lateral medulla, lateral and medial medullary syndrome. You should know them. Now let's go into another track which I intentionally left at this point, that was the spinocerebellar track. Spinocerebellar track. The spinocerebellar tract, you should know, is a tract which is connecting the spinal cord, okay, which is with the cerebellum. So this is the spinal cord, and on the opposite end here I'll make a cerebellum. Cerebellum as an organ which is supposed to connect this basically control the movement of the body in order to prevent ataxia and to maintain balance. Okay, there are two spinocerebellar tracts, remember this. And what does the spinocerebellar tract connect to the brain? It basically helps me for a kind of a movement or a proprioception to maintain the balance. Okay, now we've got two. There are two spinocerebellar tracts with us. Okay, now one tract, as you can see, is somewhere in the anterior part of the spinal cord, that is known as the anterior spinocerebellar tract. Other wala is in the posterior part, posterior spinocerebellar tract. Actually, it's not unconscious proprioception, it's not unconscious, it's subconscious. Okay, write it down, subconscious proprioception, not unconscious. What happens is this, when you're walking on a floor, do you look at the floor? No. Do you look at your knee joint? Is the left flexed, the right extended? And God has given you a power to maintain balance. When you flex the left knee, you extend the right knee. At the same time, when you flex the right, you extend the left. You don't look at the joint, neither do you look at the floor, but you're able to maintain the balance perfectly. This is through a subconscious route, okay? Through a tract spinocerebellar. Fine. Now I'm making this because the anterior spinocerebellar has crossed the midline in the anterior half of the spinal cord, will reach a part of the brainstem midbrain and then again cross. So anterior spinocerebellar tract, as you can see, is something which is going to double cross. First it crosses in the spinal cord, then it crosses in the brainstem when it reaches the midbrain. Posterior spinocerebellar, as you can see, is not crossing midline anywhere, it's just reflected to the cerebellum like this. There are three peduncles, yes, the superior, the middle and the inferior cerebellar peduncle, through which the entry has to happen. The inferior cerebellar peduncle, yes, is getting the input from the posterior spinocerebellar. The superior cerebellar peduncle is getting the input from the anterior spinocerebellar. Now, what I could learn from your anatomy books, why are they kept separate? Because the anterior wala is for the gross movement and the posterior one is for the fine movement. Now, what do you mean by gross and fine movement now? Like you're walking on a floor, you flex the knee joint, that is a gross movement, okay? While you are playing a piano, okay, you don't look at the piano. Some people are blind also, they play piano, Andhadhun movie you must have seen. So what happens, you even type on a keyboard, you don't look down, this has to move like this. So these are the fine movements, okay, which travel up through the posterior spinocerebellar, and the gross movement for the sort of a knee and ankle or maybe a hip joint is going up through the anterior one, okay. So why I'm drawing this diagram, because we have understood this also. Whenever there is a lesion in superior cerebellar peduncle, middle, inferior, anywhere, the cerebellum directly is involved and you have ataxia on which side? Same side. So look at the concept again, that in a cerebellar lesion, the ataxia is always happening on the same side, ipsilateral, okay. Right. Take a full page again, we'll just try to complete this stuff. Take one full page. Take one full page. We'll make a table on this. And we'll write three disorders with each other in a comparative. This is a very big chapter in Harrison which I could never understand what to teach and what to leave. There are few things which are memory based and a lot of things need to be explained also. Let's go with the explanation part first. Friedreich ataxia, one disease under the ataxia heading. The second interesting and a very well-known disorder, that is Taves dorsalis. And the third wala is subacute combined degeneration. SACD. Okay. Friedrich's, Taves, and SACD, three things. All coming under one roof of ataxia. Right. Now, what are the things involved in them? The tracks. Tracks now. Okay. What are the tracks involved in each one of them? The common track in all three of the brothers is the posterior dorsal column. Remember this. The posterior dorsal column is involved in all the three brothers. In the first and the last brother, don't forget, there is involvement of a track which is the not spinocerebellar. I'll write the pyramidal or the corticospinal tract. Then we have a track which is involved in Friedrich's patient, that is the spinocerebellar tract. And this fella is the involvement of the peripheral nerves. Vibration and joint position. Tell me please. Vibration and joint position, that I know as proprioception, okay, will be lost in all the three brothers. Yes, because the posterior column is involved in them. Right? While as you can easily understand, the pain and the temperature will most of the time be intact in all of them. Why is the pain and temperature intact in them? Okay, why is the pain and temperature intact in them? Can you tell me? What is spared in all of them? Yes, the spinothalamic is not involved in either of the three brothers, so pain and temperature sensation would remain intact in them. I agree that you might be thinking in the mind that peripheral nerves also are involved in SACD, correct? But remember this, the peripheral nerve involvement is very late in these patients, quite late in the disease, and is often found to be mild involvement of the peripheral nerves. So the pain and temperature sensation remain to be intact. Okay. I'll just take you out from this and I'll ask you simple doubts. There is a patient with me whose spinothalamic is lost, whose corticospinal is lost, okay, but the posterior column is normal. There's one patient. There's a patient with me, okay, whose corticospinal is lost, spinothalamic is normal, posterior column is normal. This patient. Yes, this wala, if I look at every point, I think of one thing. What? Maybe a syrinx cavity inside the spinal cord, syringo Milia, one disease. Or maybe I can think about what? Anterior spinal artery occlusion. While this patient I saw was a myelopathy kind of a thing, but there was sensory abnormality. No, the sensory system was normal. Maybe I can write here also anterior horn cell is lost. Tell me please. If the anterior horn cell is lost in the patient, corticospinal is lost, but the sensory is normal. What is that? That was a disease, motor neuron disease known as what? Amyotrophic lateral sclerosis, ALS. Right? Or MND. So think about all the disorders in a way that you can easily recollect even in the MCQ that this is on, this is safe, this is gone, this is safe. What can be the basic problem? Okay. Now let me go back here. Look at this, Friedreich's ataxia. Posterior column is gone, spinocerebellar is gone, even the pyramidal is gone, but the spinothalamic is safe. Okay. So that's a Friedreich ataxia. The deep tendon reflexes, the DTR that we know, are found to be absent in Friedreich's, found to be absent in patients of TAPES, while in patients of SACD, initially there are 3 plus, that means brisk, and later they disappear, Okay. Then we have, sorry, Beminsky sign. The Beminsky sign is read as positive Beminsky when the lesion is involving what? Corticospinal. So I can write like up arrow upwards. That means the plantar is extensor. Also known to me as a Beminsky sign positive. Also known as Beminsky sign positive. While in TAPES, the plantar is downgoing or flexor, which I can write as a Beminsky sign negative. Are Baba, deep tendon reflex, DTR, deep tendon reflex. Can write this down. Deep tendon reflex. Okay. Now the doubt comes in every student's mind, sir. You have been talking about this since yesterday. Whenever the corticospinal is involved, you get a UMN sign that is extensor plantar. But every time you get a brisk reflex. But this time you wrote the absent reflexes are seen in these patients. Why this cola veridi? Yes. Let me take you into this cola veridi also. First thing you can write over here, in patients of TAPES as well as in patients of Friedreich's, both of them, the first part of the nervous system which gets involved is a dorsal root ganglia. Dorsal root ganglia or the DRG. Okay, DRG. That is the first thing to get involved in both of them. Now I'll tell you the story behind this DRG and why does it causes areflexia. So have patience on this. Okay. Now this I see as a spinal cord segment. Okay. When I strike the knee hammer, I give an input to the spinal cord through a sensory afferent. So there is a sensory afferent or a sensory nerve every time bringing me an input to the spinal cord through the dorsal root. Whenever a sensory afferent comes to the spinal cord, it has to come and meet at a point that is the dorsal root ganglia. That is a toll plaza kind of a thing where it is trying to collect everything and send it in an appropriate direction. Now the problem in this patient is this. You should know this fact. They deny this fact in physio and anatomy book, but in neuro books they rarely give this. When I'm doing a deep tendon reflex, I'm sending a sensory afferent. Just imagine this, you take your knee hammer and strike it deeply on a tendon. Tuck. Do you stretch the tendon wall? They write it as a stretch reflex. No. You actually send a signal of vibration to the spinal cord. When you strike it there, the tendon is hit by a knee hammer and a signal not of touch, but a vibratory signal will go. Now this vibratory signal will be collected at a point DRG. Okay. And then it will be sent into the spinal cord to go up as a track what? The posterior column. Look at two concepts behind this. One concept, the posterior column is gone in these patients. So will the vibration signal be received in the brain? When I strike the knee hammer on a tendon, will the brain know that someone is knocking my door? No, because that signal of vibration is not moving up to the brain. I know people do deny this fact because in physio book they always write there is a local arc moving around it. No, in neuro books, higher books, they clearly mention it's not always a local arc. Some signal to the brain is always moving for it. Now look at this. From the brain there is a signal which is inhibitory all the time to control a particular reflex, that is through the corticospinal tract. So once you remove the inhibition of the corticospinal tract, the signal will go up and it will come down and the reflex will be what? Brisk. But when you involve the posterior column, will the reflex happen? No. The reflex will be absent in these cases. So there's another school of thought on this. Make this one also clear. The dorsal root ganglia are of two types. For the large fibers, right? And for the small fibers. Correct. The large fibers are conveying to the brain the signal of vibration and the proprioception. And the small fibers are all the time conveying the signal of spinothalamic. What is that signal? Pain and temperature. And most important, touch. Now look at this. When you are hitting the knee hammer on a tendon, a sensory input is coming to it as a vibratory input. And now the DRG of the large fiber is gone. Will I receive the vibratory input? No. Finish. The reflex arc won't be complete. Why I am telling this story? Because you might ask me, so why is the plantar extensor? The signal for plantar should also not come in. Look at this. The plantar, when I strike the knee hammer, the blunt end or maybe a key on the foot like this. Can you kindly tell me what signal on this foot sole am I giving? What signal am I giving? Is it vibration this time? Yeah, you do it. You trying to touch it deeply. Yeah, it can cause pain. But what signal are we giving? It is more of a crude touch signal we are giving. Not the pain. You might do it deep. It's pain, but it's more of a crude touch signal. Okay, now look at this. The plantar response, the plantar response that you get can follow a local arc. First of all, the sensory nerve will give me a signal of crude touch. It will go to a DRG of a small fiber which is normal and intact, and then through a local arc like a superficial reflex it will function to give a motor output for flexion or extension. And it is all the time under constant inhibition of what? Corticospinal tract. Okay, I'll repeat, don't worry. I know it's a hi-fi thing for you to understand, and that's why every student keeps on asking me why reflexes are absent. I'll repeat. I'll start from the basic. Whenever I do a ankle, knee, biceps, triceps, or any DTR or a deep tendon reflex, I strike the knee hammer deeply on the tendon. I try to send a vibratory signal through a nerve which will reach a dorsal root ganglia first. Now vibratory signals that you send through a nerve are passing through large fibers. Okay. Large fiber DRG is involved in these patients, so the door is shut over here for this. So nothing will complete. Actually, the whole local arc will also not complete. But on the plantar side, all is well. Why? Because when I do a plantar, I send a signal of touch, and that travels through a small fiber. Small fiber DRG is intact in this patient, so we are able to receive the signal and able to send out a signal. So the local reflex arc can also complete in them. But it is under constant inhibition of corticospinal tract. If the corticospinal tract is gone, the inhibition is lost, the plantar automatically will stand extensor. Okay, clear or not? See, everything is going above your head because a lot of things are already there in your head. You go for a movie and you start thinking about your patient. Will it ever happen? No. You go and see your patient and you'll start thinking about the movie. That will always happen. So clear your mind all the time, especially while studying. Okay. Fine. I know for the regular batch students, it is a cakewalk. They know this concept is very simple, is very clear. For the foundation batch who are just asking me class is till what time, lunch break, this break, nothing will happen great for you. Okay. Now, another exclusive point, one thing about SACD, I want to explain this one. SACD, why the reflexes are initially brisk, you are very clear because although the posterior column might be involved in them, but the DRG is not involved in them. Secondly, the corticospinal involvement occurs first in them. In patients of SACD, you find an early corticospinal tract involvement, yes, while the reflexes become absent because of the involvement of the nerve. I already explained this. The nerve involvement in them is found to be late. Okay. What causes a brisk reflex? Remember this way. The brisk reflex happens when the corticospinal tract is injured. I'll repeat once more. I don't know. Pay attention, please. When I want to do a kind of a jerk, that is a deep tendon reflex, I strike my knee hammer deeply on the tendon. When I strike it deeply on the tendon, the signal will come through a nerve, and that nerve will belong to a large fiber, and the signal that I try to send is a vibratory signal. Now the dorsal root ganglia of the large fibers are gone in these patients, so no signal reaches the spinal cord, nothing comes out. Simple, the reflex goes absent. While when I do a plantar, I touch the sole of the patient's feet with a knee hammer or maybe a key, and I touch and try to elicit a sensation of crude touch. Crude touch signal is going through to the brain through a small fiber. Sorry, small fiber. Now this small fiber DRG is intact, the signal will go in and the signal will come out. But it all depends on the inhibitory pathway of the corticospinal. If the corticospinal is gone, the inhibition is lost, the plantar automatically will become what? Extensor. Okay. Every year we get a question on ataxia, NEET PG, AIMS or even PGI everywhere. Okay. The questions that are asked very commonly nowadays is on this concept. What are they associated with? What are they associated with? See, in Frederick, why don't you get a brisk reflex first? Because DRG is involved in them first, not the corticospinal. Okay. Now, what are they associated with? Especially this one. Your patients of Frederick ataxia are associated with cardiomyopathy, optic atrophy, and diabetes mellitus. Most common associated problem with patients of Friedreich ataxia is a cardiomyopathy disorder. Just remember this, that the cardiomyopathy that you find in these patients is of the type hypertrophic cardiomyopathy. This has been a question asked somewhere in cardiology. What kind of cardiomyopathy that you see in these patients? More often a hypertrophic type. Okay. Another quick fact which was recently asked in these patients, that Friedreich ataxia is associated with vitamin E deficiency. Again, I'm not going into details about it, but just note it down. There is a vitamin E deficiency found very consistently in patients with Friedreich ataxia. Now, it is a disorder which you find occurring due to this trinucleotide repeat sequence defect. Okay, can you tell me a disorder that we have covered yesterday, which we mentioned about this disease, and it caused a dementia with chorea? Yes, Huntington chorea. The sequence there yesterday was CAG repeat, more than 40. Here today the sequence is GAA. And the repeat sequence to cause this problem is even higher, more than 200 repeats. If it is a genetically influenced problem, yes, we are going to have it in the chromosome 9. Make this point very clear. I've seen this in many of the books, not textbook, guidebooks and apps and all. They mention chromosome 13. No, it's chromosome number 9. And of course, it is an autosomal recessive disease, not the dominant which you found. Okay. So these are quick facts about each one of them. Tabes. Can you tell me which disease the tabes comes with? You know the answer. Tabes dorsalis is a sequelae of which infective disorder? It's a sexually transmitted disease. Any guess? Yes, the neurosyphilis, don't forget it. It's a very important topic somewhere else. Yeah, syphilis. Okay, that's the hint for you. That's a priming word for you. It's a part of neurosyphilis. Now, can you tell me, if you read neurosyphilis in opthal, what kind of a pupillary change will you expect to happen? Pupillary change in the pupillary size or something. Please tell me. It's a pupil which is ARP, Argyll-Robertson pupil. Accommodation reflex is present and the light reflex is absent, ARP. Also in these patients, don't forget there is a lot of autonomic troubles happening, that is bladder disturbances are seen in them, bladder disturbances. Okay. In SSCD, what do you find is a low vitamin B12 very often. And a low vitamin B12 will often result in an anemic problem. Don't forget, the name is the megaloblastic anemia. Right? Okay. So let's get wiser on these topics by solving some MCQs, of course. A 12-year-old boy presents in OPD with history of progressively increasing difficulty in walking and frequent falls. Physical examination reveals an ataxic gait with nystagmus. The deep tendon reflexes in the patient is found to be absent. So the DTR is absent. An ataxia is present. Okay, with a nystagmus finding. Okay, the plantar is extensor, which I can write as a word Bembinski sign positive. What is the likely diagnosis? Good, correct answer, Frederick. But again, in exam, after a cardiology question before a rheumat question, this is going to be tough for you. So have an eye on these topics like SSCD, if at all it happened. Areflexia was not seen so well, even reflexes were found to be normal initially. Plantar, although it was extensor, I agree. Okay. Duchenne muscular dystrophy, DMD, is a different story, and in TABES, if you remember, The DTR were absent, but every time I wrote the plantar is flexor because the corticospinal tract is not involved in these patients, if you remember. Okay, so best answer is going to be the Fredericks anytime. All of the following regarding Friedreich ataxia is true except, correct except. It's the most common hereditary ataxia. Okay, with the autosomal recessive pattern, yes. Increased GAA repeats on chromosome number 9, that's also correct. First pathological change is seen in the posterior column. No, my dear friend. The first pathological change was seen in DRG. And the option D is missing, you can write none of the above. Okay. Don't mark this as an answer anytime. So the answer is C, is a simple question. 34. All of the following are true about SADC except it is due to deficiency of vitamin B12. Yes, it can happen. Posterior column is involved. Corticospinal tract is involved. And this I want to highlight. Absent DTR. No. DTR are quite often absent in the later stage of the disease. Okay. Not all the time absent. Now this is something you can tell me applying your basic knowledge. All of the following can lead to trophic ulcers in fingers except. You know, I've seen most of the answer guides and books everywhere they mention trophic ulcer and they give you 10 DDs and you might mug up by making an MCQ, but it is not going to help you. Apply your mind on this. Syringomyelia had a trophic ulcer. We have discussed this, painless burning. Leprosy, if you read somewhere else, you will always find a leonine or a painless trophic ulcer in them. Diabetic neuropathy, yes, the diabetic foot starts because of this. What are we left with? SACD. I again clarify this point. In SACD, if at all peripheral nerves are involved, yes, the involvement is quite late and quite mild in the disease, right? So the trophic ulcer could happen in any of the situation, in all the options except for SACD, right? So try to solve this question in this pattern. It's easy to recall actually. Okay. Mark it now for me. This is a sections of spinal cord I've tried to make. Tell me which is syringomyelia. If I want to locate, this is A, this is B, this is C, and this is D, right? Syringomyelia, tell me. Which one of the sections transfers looks like syringomyelia? Syringomyelia goes with the section C. It's very simple. This one, syrinx cavity in the anterior part, right? SACD, subacute combined degeneration. What were the things involved in these patients? Posterior column, yes. With what? The corticospinal tract, right? So where do we see that involvement? You can see this one as a corticospinal and this one as a posterior column because you have got fasciculus gracilis and fasciculus cuneatus. So we have this D as SACD. Anterior spinal artery occlusion, right? That's very clear, is a Tabes dorsalis, isolated posterior column. That's B. So this one is a tabes dorsalis. This is anterior spinal artery occlusion. This wala was a syringomyelia, and this is the SACD. Okay. Nothing new. The same thing again in a different way. An image-based question. Tell me, in a patient with ALS, if I want to mark this as a case of ALS, what is the thing that I should mark? Which of the following diagram represents ALS best? A, B or C? Tell me. In this transfer section, the red marking goes for the disease. Okay. Which of the following is the best one to call it as a case of ALS? In ALS, what was involved? Anterior horn cell and the corticospinal. You know it or not? Yes. Mogambo बहुत खुश हुआ. Yes. See. Okay. Anterior cell is gone and the corticospinal is gone. Right? What is this? What is A? Can you guys tell me what is A? Only the anterior horn cell is gone. This is a disease of motor neuron disease, that is spinal muscular atrophy. Yes. Another disease where the anterior horn cell is affected is polio. Polio. Polio is also one of the disease. Okay. Which of the following is true about the Claude syndrome? Claude syndrome, which of the following is true? Acha, what is B showing? I don't know. I don't know, because just to complete the quorum I made this image from Google somewhere, copied it. Okay. Which of the following is true about Claude syndrome? Tell me. A, B, C, D. Claude was red nucleus with corticospinal. Is it involving the tectum part? No, no, no. It was involving the tegmentum part. Yes. Corticospinal tract. Oh, sorry, I wrote it wrong. Third. Okay. Corticospinal was involved? No. Fourth was involved? No. Third was involved. Contralateral ataxia with tremors? Yes. Good, you know it. Mogambo. Khushwa. This is a cut section of pons. This one is the 6th nerve. This one is the 7th nerve. Okay. And I've tried to make like this, What is this? Anyway, what was Miller-Gubler? If I want to mark option A, where can I mark option A? 6th, 7th with this. That is option A. What is Fovley's? Fovley's is even behind this, Everything goes together. Medially is a Fovley syndrome, B. What was Mary Fox? Mary Fox was on this side, D. What are we left with? Raymond-Keston. Now what is Raymond-Keston? I did not tell you then. Okay, now look at the diagram carefully. The examiner is not asking what I have marked like this. He is asking you this. What is this syndrome? This is the 7th nerve. This one is the 6th nerve. And this is the corticospinal. If the 7th would have gone with it, that means 6th, 7th with corticospinal, then I could have told that this is a Miller-Gubler syndrome. Fovley's was 6th, 7th with corticospinal, yes, with medial longitudinal fascicle with medial lemniscus. Mary Fox was the spinal lemniscus with middle cerebellar peduncle. And what we are left with, odd one out, is a Raymond-Keston. Raymond-Keston, look at carefully. The examiner is not asked you about 7th, he is asking you 6th abnormality. 6th nerve with corticospinal. This is known as a Raymond-Keston syndrome. Okay. Many of the people are marking A. No, 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 no. Look at this carefully. Match the following brainstem syndrome and their clinical features. Wallenberg, okay, I forgot to name this. Wallenberg. Wallenberg is a lateral medullary syndrome, LMS. Lateral medullary syndrome is Wallenberg syndrome. Okay. What is going away in Wallenberg? Yes, this one. Wallenberg syndrome is this. If you can match it. One will go with B. Yes. Ipsilateral 5th, 9th, 10th with no hemiplegia, no weakness. Now what is Weber? Weber is a midbrain syndrome. Third nerve palsy with contralateral hemiparesis. Good. A. Fovley syndrome. 3, C. 6, 7 with contralateral hemiplegia. Your examiner might ask you these kind of questions. Be careful. See, this question has one syndrome from every section. One from the midbrain, Weber's, Fovley, Pons, and this from medulla. Okay? Right? They are simple one. They're simple syndrome. Nothing much hi-fi in them. This year in NEET PG AIMS, everywhere we got a question on a brainstem syndrome. So be careful with them. 60-year-old male presents with meiosis, ptosis, anhydrosis on the left side. What is this? Horner syndrome. Difficulty in walking, maybe ataxia is talking about. Not very clear, is he falling or not? He also complains of dysphagia and dysarthria. Okay, not a very correct statement to write as dysarthria, but dysphagia goes with the 10th. On examination is found that the pain and temperature is lost on the right side of the body and the left side of the face. Tell me the answer for this. Okay, I'll make it as the patient goes. It is lost on the right side of the body and the left side of the face. Is it left lateral medullary or is it right lateral medullary? Clear my concept? हाँ, very good. क्या बात, क्या बात. Mogambo बहुत खुश हुआ. Okay, people from Tukde Tukde were also there. Okay, sorry yaar. They must be wondering what is this A, B, C and what are they writing in this. Okay. Left lateral medullary. There should not be any confusion in this diagram. Okay. Good. Which of the following is not involved in a Wallenberg syndrome? Answer me. Sympathetic trunk is involved, nucleus ambiguous is involved, spinal lemniscus is involved, trigeminal lemniscus. Na baba. Trigeminal lemniscus is not formed in medulla, it is formed in pons. Okay? Right? Acha. This I will teach you. Okay? But after a short tea break, I'll come back and will teach you. Class is till 9 p.m. Okay? Endocrine will start anytime after 6 p.m. Don't ask me this question again. Okay? Without asking, I'm giving you breaks today. My wife also came and checked as what am I doing inside, playing some music. What are you teaching to these students today? क्या चल रहा है? कुछ तो गड़बड़ है. Okay. This is a right lower motor neuron lesion. Bell's palsy. I just forgot to show you this image. Okay, facial palsy, madam, as you can see, has got loss of wrinkle on the forehead region, and she's got a typical Bell's phenomena. When she smiles, her face goes towards the normal side, right? So this is something which is a right lower motor neuron type of a facial palsy that you find. Correct? Chalo, ladki aankh mare. If the girl is blinking like this to you, please check her once. She might be having facial palsy. Be careful. Now, let's go into another disease syndrome that is a very important syndrome known as the Guillain-Barré syndrome. Guillain-Barré syndrome, that is a disorder associated with the peripheral nerve secondary to demyelination. GBS. This is another Suryavansham that you find typically. Okay, this is another Suryavansham that you find typically, because uh, I call it as Suryavansham because in NEET, AIMS, any exam that you go in, you always find a question related to this one. Okay, GBS, and like you read Brown-Sick cord, you read all the brainstem syndrome, but you should never forget to read GBS. It's a must-know topic, but it's a very simple one. For this, we'll start with a very basic concept. Why does it happen? Okay, there is an organism which is known as Campylobacter jejuni, which happens to cause gastroenteritis as a disorder in any one of us. And we often fight any organism which is not a normal commensal by forming antibodies. Okay, so antibodies are going to act against this organism when the infection comes in form of a gastroenteritis episode secondary to this organism Campylobacter. Okay, now there is a peripheral nerve with us which is conducting an impulse at a very low speed, approximately 1 meter per second. That is a nerve which doesn't have any myelin on top of it. That is an unmyelinated nerve. Now we find somewhere that on the nerve we suddenly get a myelin as a insulation or maybe a jelly kind of thing which is going to surround it circumferentially. Now the importance of having myelin on it is this. The myelination of any nerve is going to increase the speed of conduction. From a continuous, it is going to become a saltatory conduction. So the speed of conduction is going to become 70 times, 70 meter per second. Okay. So 1 meter per second is something as a speed of conduction in an unmyelinated nerve, while in a myelinated nerve, it is going to become 70 times. So that's good news for it. But the unfortunate part is this, that this Campylobacter somewhere antigenically mimics a cell which is forming the myelin on the peripheral nerve, and the name of that cell is the Schwann cell. Like the oligodendrocyte in the central nervous system, we have got Schwann cells in the peripheral nervous system. So unfortunately what happens, maybe 10 or 14 days after the infection of this organism, the antibodies against the organism might go and cross react with the Schwann cells. Okay. Now when the Schwann cells are gone, what will happen? The myelin will be lost. Once the myelin is lost, obviously the speed of conduction is going to go down. So a nerve becomes unmyelinated because of an attack by the antibody on the Schwann cell. Starting after an episode of infection by this famous organism Campylobacter. So I can write this together in one word like this. It's a post-infectious, okay, demyelinating polyneuropathy. It is a post-infectious demyelinating polyneuropathy that we find. Okay, that is known as a Guillain-Barré syndrome. Now the most common organism associated with GBS as a disorder is Campylobacter. Remember this. But that's not the only one. There are other organisms listed in books which have been found to initiate this kind of a thing. Okay, that is your human herpes virus, the Epstein-Barr virus, the cytomegalovirus. Why should HIV remain behind HIV virus? And then another virus, that is hepatitis, specifically being in all the literature being mentioned as hepatitis E virus. Zika virus also. Wait for another 1 year, you will also have COVID-19 in the list. Okay, father of all the viruses. They say somewhere 70 to 75%, approximately I can take as 70% of patients with Guillain-Barré syndrome always have got a history of antecedent infection. Antecedent infection. So that means infection prior to the onset of this demyelinating polyneuropathy is found in almost majority 70% of these patients. Okay. Apart from this, don't forget there are certain vaccines also being listed which have been known as a trigger of this disease, Guillain-Barré. That means they can also form antibodies, and those antibody can cross react with the Schwann cell. Now, what are those triggering antibody vaccines? One is your influenza vaccine, the commonly used swine flu vaccine. And another one is more commonly used, that is a dog bite or a rabies vaccine. Now, one student got quite emotional on this and he asked me, sir, if I go and have a dog bite, and dog bite is 100% fatal without vaccination. So, if I go and take a rabies vaccine, I'll develop GBS. If I don't take a rabies vaccine, I'll die of rabies. Sir, what should I do? How should I die? I said, come here, I'll kill you. That's a simple way. Don't get emotional on this. Remember this. Influenza, the swine flu that you use nowadays, and the rabies, the old variety of it, not the new ones that you have. So the old variety of all these vaccines, the influenza and the rabies vaccine, okay, were known as a trigger for this kind of a problem. Okay. Not so common, but still they have been documented in the previous literatures. Now we'll go to the clinical symptoms of this disease, the clinical features of this problem. In the clinical features of GBS, don't forget, one symptom that stands out with it very often is ascending paralysis. Ascending paralysis, okay? Now, ascending paralysis is something that we find as a disease in which the weakness initially starts in the distal part of the limb and then it goes to the proximal part. So initially in this patient, the weakness is found to be distal and then it ascends up into the proximal muscles, right? So what we find is that the pattern of weakness is ascending in most of them. Along with this, remember this concept that the weakness which is ascending from onset to the maximum weakness will be within 0 to 4 weeks time. I can explain this in a very simple graph like this. If I take this as a timeline, and that is a pattern of the deficit or the weakness that we find here, the weakness will progress, reach the maximum, stay on a plateau and get normal. Now the time to reach the maximum weakness in these patients from the onset is taken to be always less than 4 weeks. 4 weeks, which I can take as around 28 days. So there is no progression of weakness beyond 28 days in patients of Guillain-Barré, right? Apart from this, we find that there is areflexia seen in these patients very consistently. Because it's a disease on the nerve, the peripheral nerve has lost the myelin, and any neuropathy will always present to me with a very important clinical sign, that is areflexia. Along with this, remember this, that the sensory involvement in these patients is found to be minor. So we find in these patients the motor involvement is more predominant than the sensory. So there is a minor sensory loss seen. That means the nerve which have lost the myelin are predominantly the motor nerve, not the sensory one. Apart from this, don't forget the most common cranial nerve involved in these patients. The most common cranial nerve involved in these patients is the seventh cranial nerve or the facial nerve. Some fugax is there, don't worry, it will get alright. It's bilateral element facial nerve palsy that you find. In almost 50% of these patients, we find it. Okay? Not in everyone, but almost 50% of them we find it. In patients of Guillain-Barré. Okay? Now, there is another concept here, don't forget this, that the urinary bladder most of the time is spared in these patients. So urinary bladder is something which is found to be intact and spared in them. But if at all the involvement of urinary bladder has occurred in these patients, if at all it is involved, then remember this, the involvement first of all is not permanent, it will recover, it is transient, and it usually happens in a very severe form of Guillain-Barré. So in a very severe form of GBS we find it. Okay. Now everything which I have told above comes into one roof, as a named disease, as acute inflammatory, don't worry, demyelinating polyneuropathy. Acute inflammatory demyelinating polyneuropathy, being abbreviated to us as a term AIDP. Okay, why did I name this like this? Because it's a disease on many nerves that we come across, polyneuropathy. It happens due to loss of myelin on those nerves. It is demyelinating. Antibodies are fighting with the antigen, that is a Schwann cell this time, inflammatory, and the disease doesn't progress beyond 4 weeks time. So we keep the term as acute for it. Okay. Now GBS, Guillain-Barré syndrome, is a big name actually. It has got various types. Okay. Now the types of GBS that we have are: 1. AIDP. About AIDP I have already explained to you. In these patients of AIDP, remember the nerve involvement is more often motor than sensory. Correct? Right? With the facial nerve palsy and all this areflexia ascending, but the nerve involvement is often motor than sensory. Just note this down, the antibodies which are fighting with the Schwann cell in these patients of AIDP are of a type GM1. So GM1 antibody positivity is seen in these patients of AIDP. Remember this also as a very common question asked. Most common type of Guillain-Barré syndrome is GBS. Of GBS is AIDP. Now I want to highlight this confusion. Most of the authors, I don't know, have tried to mention that in children some other type is found. Don't worry, it will get alright. Some fugax is there. Don't worry, all is well. And adults. So make it clear, I'll repeat, in children as well as in adults, the most common type of Guillain-Barré syndrome that we find is the type of AIDP. Right? In children also I stress upon this. Second that you find here is a type that is known as acute motor axonal neuropathy. Acute motor axonal neuropathy, that is abbreviated as a word AMAN. Now what is the term motor applied for them? In these patients, the nerve involved is more often motor. So write it down, in these patients only the motor nerve is involved, not the sensory anywhere. Like in AIDP it was at least mild sensory, but here there is no sensory involvement. So I can write it here, there is no sensory involvement at all, not even mild. Now why does it hold importance here? Because in these patients we find antibodies. Now antibodies found in them are GM1, yes, the same as AIDP, and the other one is GD1A. So these are the two antibodies which are found in patients of AMAN, acute motor axonal neuropathy, with the nerve involvement predominantly motor with no sensory involvement. Okay. See, the clinical features which I have mentioned fall into the category of AIDP. See, most of the MCQs, I'll discuss them also in GBS, which you must have seen. The examiner never puts the word as GBS. They always puts a term as EIDP. Okay, so all the symptom, everything which has gone parallel is with reference to EIDP. Third type is acute motor sensory axonal neuropathy, the third type, that is being abbreviated as a term AMSAN. Now, what is the meaning of this term motor sensory? In these patients, motor nerve as well as sensory nerve are almost equally involved. So it is not only a motor and not only a sensory, it's motor and sensory both together. Okay, don't worry, it will get all right. Some fugax is there. Now, antibodies in these patients, don't worry, all is well. Antibodies in these patients is of the type GM1 and GD1A, again the same as AMAN. But most important thing, remember this, the most important thing is this: one GBS which happens to not come out of the disease, one GBS which is having the worst prognosis among them is this type AMSAN. Okay, so AMSAN type, acute motor sensory axonal neuropathy, yes, will have the worst prognosis. Okay, number 4, very important, has come this year as well, Miller Fisher syndrome. Okay, MFS. Keep on writing, don't look at the screen too much, like it's going blank. It's a very important topic. Even my internet is blinking at me sometimes. Miller Fisher syndrome. Okay, Miller Fisher syndrome is a syndrome which is found in around 5% of GBS patient, so it's not very common. It requires a clinical description because of the triad it comes to me with. One thing which we have in these patients is ataxia. Second thing that we have in these patients is areflexia. And the third thing that we have is ophthalmoplegia. So these are 3 things that we have. Many of the authors have tried to write this as Miller-Fisher variant also. Many of the authors have tried to write it as a Miller-Fisher variant also. Just a second, I'll just do the internet speed check. How fast are we? What about it? Just a second. Oh, क्या बात है. Airtel is giving me such good speed today. मोयम्बो बहुत खुश हुआ. Leave it. All is well. It's all a transient phenomena. We have checked the prognostication of it. It will get all right. Don't worry. Ataxia, areflexia with ophthalmoplegia, right? Something we find in these patients is a particular antibody that we find. Now the antibody that we find positive in these patients is GQ1B antibody positive. Don't forget, GQ1B antibody positive. And don't forget this, that these patients are coming into a category of a variant because of no weakness. So one thing which we find in these patients, typically in Miller-Fisher syndrome or variant, is this. Okay. So something which we find is that the weakness in these patients is not that severe, or it's not found at all, and that's why they put the word variant over there, rather they present with these kind of symptoms. Okay. Now apart from this, I'll make a small diagram again. Where is the immunological attack occurring in them? Like if I want to cover the myelin onto any peripheral tissues like this, so this end to this end we cover it with myelin, this end to this end, okay, and maybe this end. Now what do you have is the Schwann cell sheet, which is there below the particular myelin forming a unit, like here. Okay, so with a green marking I can show you the Schwann cell, right? And this one is a point where the impulse will arrive and it will jump to the next point. If you know this term as what? Node of Ranvier. Node of Ranvier. Now why I'm drawing this diagram? Because something we should know, that antibodies attack Schwann cell? No. They can also attack or initiate the immunological attack at this point, node of Ranvier. Now write it down. Antibodies attack immunologically Schwann cells in two categories of GBS. One is AIDP and second is Miller-Fisher syndrome. So the Schwann cell have got an attack directly by the antibody in two types of GBS. One is rare Miller-Fisher and one is the most common AIDP. While in patients of the other two types, yes, the Aman and the Amsan, you find this, the antibody attack happens on what? The node of Ranvier, the node of Ranvier. So the site of immunological attack in Amman and Amsan is found to be node of Ranvier, while the site of immunological attack to begin with in patients of EIDP and Miller-Fisher is the Schwann cell. Okay. So because this has been a recent question on this topic, that Aman and Amsan will have antibodies immunological attack to start at what point? Node of Ranvier. Now let's move into the investigation part. In the investigation part, what we want to do in these patients is nerve conduction study. Right? In the nerve conduction study, we find two things. One, decrease in the nerve conduction velocity, and second wala is a decrease in the action potential. Okay, two things will happen, because once you lose the myelin, okay, you lose the nerve conduction velocity, okay, and action potential of the nerve will also drop. Just a word to write, need not go into details of why, just write it down. There is a loss of a wave in nerve conduction study that we find in them, that is known as a F wave. So don't forget, there's a term F wave that is lost in patients of GBS or the AIDP. What is F wave? How does it happen? Leave that story. Okay. Second is the CSF. One thing very important, why this topic comes into highlight every time, because the CSF will show increase in the protein, albumin in these cases, but there is not going to be any pleocytosis found with them. That means the protein increases and the cell count doesn't increase at all. There is no pleocytosis found in them. In CNS infections, what did we found? We found that the protein rise cell went up, the glucose and chloride went down. But this time the protein went up and the cell did not go up. It's known as cytological dissociation. So both the things move away from each other, being abbreviated as a term ACD. Now this is found in the CSF, correct? Remember this concept that the onset, or rather I can write the word as appear. This thing appears in the CSF almost 48 hours after the onset of weakness. Almost 48 hours after the onset of the weakness. So when the weakness has actually started, 2 days later on we will find in the CSF this problem known as the albuminocytological dissociation. Apart from this, we know that this is going to peak or can be seen at the maximum amount, or the best, at the peaking will be seen at around 7 days after the onset of weakness. So maybe in the second week, if I want to see, okay, I'll find it best the albuminocytological dissociation, but it will not appear so early. It will appear 48 hours after the onset of weakness. ACD, or the albuminocytological dissociation, right? What is FA? Why does it happen? Leave that story. I'm telling you because this is something too hi-fi at your level to understand. Treatment. Treatment is something that is important in these patients because timely treatment is going to prevent morbidity as well as mortality. That is IV immunoglobulin, or the IVIG that we use. Now IVIG is something that is given in these patients at the dose of 2 gram per kg over a duration of 5 days. So if it is a 50 kg patient, you give 100 gram to that patient, not in a single day ever, you divide it over 5 days. So maybe on a length of 5 days per day, the dose will be 20 grams somewhere. Okay. The second treatment is something that you must be knowing. We can take out the antibodies which are causing the immunological attack and filter the blood and give a blood which doesn't contain them at all. Don't worry, all is well, it will get all right. Plasmapheresis. Okay, just keep on writing. Plasmapheresis, IVIG are the two treatment. Now there are 2 points here to be written that's important for answering any question in exam. First of all, IVIG and plasmapheresis both are equally effective. Both are equally effective. It has come back, it is not hanging anymore. Okay. Write emeresis, fugax or fugax. That looks better, Someone read hang, or whom are you hanging, your teacher or what? Mob lynching is happening. Both are equally effective. They found in a study being done at multiple centers that both are equally effective. Okay. And they are best in 14 days of weakness. So the weakness that you have in the patient in the first 2 weeks, if I want to give it, the benefit will be excellent in these patients. They are found best in 14 days of weakness. Plasmapheresis and IVIG. Both are equally effective. That's again very important step. Now something we should all know, steroids. Steroids are something which are not recommended in these patients at all. Steroids are not recommended in these patients at all. Okay. They found in a lot of multi-center trials that they are not recommended, in a sense they don't do any benefit. So steroids are obviously no in these patients. Prognosis. In patients of GBS, something good is there, that the recovery happens in majority of them. Yeah, the treatment wise, if I want to see even Miller Fisher or any type, is the same treatment. Okay, same treatment for every type of GBS. See, the recovery occurs in 85% of the cases. The disability or the sequelae is seen in around 10% of these patients. But the most unfortunate of all, death, that happens in 5 or less than 5% of these patients. Okay, right. Okay. Now, this is something we should know, that these patients might require a ventilatory support also. Now, the ventilatory support is required in nearly 30% of the cases. Not so common, but 30% patients might require ventilatory support. Okay, what is the cause of death? See, there is no one cause of death which has been labeled. There have been multiple, like patient is on the hospital bed on a intubated ventilatory support. He might develop a DVT, die of pulmonary embolism or secondary infection in the lung, anything. Okay, but the 30% of these cases will require a ventilatory support. We should know this. Okay. So you're counting number of minutes also. Every 8 minutes it is occurring. The role of IVIG goes in this way that we find that antibodies are going to fight against the antibody. So one role of IVIG is in this sense that the antibodies are going to fight against the antibody which are causing the damage. Okay. Now there is a elder brother also in their family which is known as chronic inflammatory demyelinating polyneuropathy. Acute inflammatory demyelinating polyneuropathy, CIDP. Right. Now remember this, CIDP is an elder brother of AIDP for the reason, first is the definition part. We try to define it well. First of all, remember the definition, this is very important. There is in these patients deterioration or maybe progression of weakness beyond 9 weeks. Now make it very clear. The first part of the definition in AIDP which we tried to mention was this. We find somewhere that the weakness increase reached the peak in a duration of less than 4 weeks. But in patients of CIDP, the weakness progresses beyond 9 weeks time. Right? So the progression here is beyond 9 weeks time in patients of CIDP. Less than 4 weeks goes with AIDP, more than 9 weeks goes with the CIDP. So it's acute, maybe there is someone in between they don't mention is subacute, and then finally we get a chronic one. Second definition, very important, in patients of CIDP you might find 3 or more than 3 relapses of the weakness. See, I'll again show it in a comparative way, like AIDP was found to be monophasic. Monophasic, that means only in one phase it happened only once. Correct? So AIDP happens to be a monophasic kind of a thing. While here in CIDP, 3 or more than 3 could be found. So if the relapses of the weakness which are settled is 3 or more than 3, okay, is known as CIDP. Right? So 3 or more than 3 relapse in the weakness is CIDP. Only once if it is happening monophasic is EIDP. Now clinical features, remember this, in these patients the weakness that we find, don't worry, it will get alright. The weakness that we find could be symmetrical, right, or can be asymmetrical also. Asymmetrical also. Now asymmetrical type of a variant of CIDP that we found is known as the multifocal acquired demyelinating sensory motor neuropathy. Is also known, abbreviated as a name, MATSM. Okay, MATSM. Also known to me by another name which as a question came in one of the exam this time, is known as the Levi-Sumner syndrome. Levi-Sumner syndrome, MATSM, is an asymmetrical involvement which is sensory and motor of patients with GBS. Okay. Now, apart from this, remember this, the nerve involvement in them. Nerve involvement is not only motor, it can be sensory also. Like in AIDP, if I want to see, it was more motor than sensory, while here it is both. Okay. Sensory symptoms are present, that means. Investigation wise, when I check the CSF of this patient, ACD, albumino cytological dissociation, is also present in them. Okay. In CIDP also ACD is seen. Another thing which came in the question this time was the nerve biopsy. The nerve biopsy done in these patients showed an onion bulb appearance. Write it down. This in a systemic path they had asked recently, the onion bulb appearance in a peripheral nerve is seen in which disease? It is seen in CIDP. Treatment. MATSM, this multifocal acquired demyelinating asymmetrical involvement of nerves, is MATSM, is Levi-Sumner syndrome. Okay. Treatment. IVIG can be used, or plasmapheresis could be done. Okay. Or even something which was not recommended in EIDP, that is known as steroids, can be given. Very important thing. Steroids can be used in treatment of patients with CIDP. Okay. The other name for MATSM is Levi-Sumner syndrome. Okay. Thank you. Giving me tea. Sure. Thank you. Dhanyavad. Right. Now let's see another type of neuropathy disorder. Okay. Let's see another type of a neuropathy disorder. See, the MATSM, as you know, is a type of neuropathy which is a multifocal acquired demyelinating axonal sensory motor. It is a type of CIDP which we also know by the name Levi-Sumner syndrome. Okay. Yeah, CIDP is also post-infectious. Now this one, Charcot-Marie-Tooth disease. People do ask me, sir, you teach GBS, you teach CIDP, but you don't tell anything about CMT. Okay, it's a neuropathy. You want to write, it's fine, because there are types of neuropathy seen in them. Various types of CMT are seen. And this year, two questions came on one of the exam, back to back on this topic. Okay. I'll do with CMT1 type 1. It's a neuropathy. Okay. Remember this, it is an autosomal dominant disease. It's an autosomal dominant inheritance of the disease in Charcot-Marie-Tooth. The onset of the disease is somewhere seen in the first till third decade of life, right? You know, one of the common presentation in these patients is a foot drop. Foot drop is considered to be a very common presentation in patients of Charcot-Marie-Tooth disease. Foot drop we found due to peroneal nerve injury, and if a patient of foot drop comes to us, we think about this disease very commonly. Is it a Charcot-Marie-Tooth or not? Remember this, paresthesia as a complaint in these patients is usually absent. That is, tingling and numbness will not be seen. But the deep tendon reflexes are decreased and sensations are often lost in this patient. So it's a neuropathy which can cause sensory loss also with dull reflexes. Now, what was the question that came in this exam regarding this? Was that in these patients we find typically atrophy below the knee joint. Below the knee joint in the patient we find a lot of atrophy, especially in the anterior compartment. And I'm 100% sure somewhere in orthopedics, Bahubali must have told you about this. The lower limb anterior leg muscles are totally wasted, while the muscles which are there on the rest part is fine. Look at this. The anterior compartment, the leg muscles are totally wasted. Okay. Above it, they happen to be like this. Nothing but this. A champagne bottle which is inverted. So this is something known as a inverted champagne bottle leg. Okay. It's a very common thing which is asked nowadays. That's why I'm taking out this topic from the grave, of course, because all these topics were I always found to be very dead topics. For the last 4 or 5 years, no one was asking anything. Then suddenly the examiner pulled the things out of the grave. Okay, inverted champagne bottle legs. Okay, people are asking who is Bahubali. You can go and watch Bahubali for this. You will know, and come and attend classes. Then you will know. Now, a few facts to write here. Okay, nerve biopsy that we do here. The nerve biopsy that we do here. Okay, is something not always required. It is not always required, but because clinically we can easily know the disease. But if at all I do a nerve biopsy in these patients, we will find the same appearance as CIDP, the onion bulb appearance. Okay, so this onion bulb, in pathology they say like the patho do piazza. There are many things which are related to piaz or onions, especially in neuropathy, like CIDP had an onion bulb appearance, same as a Charcot-Marie-Tooth type 1. Okay. In these patients, we find the motor nerve conduction velocity. NCV stands for nerve conduction velocity is in the range of 20 to 25 meter per second. That means there is a slowed conduction in these patients. Right? The other types of Charcot-Marie-Tooth, don't go into details of it. Okay, just remember there are total 4 types. There are total 4 types of Charcot-Marie-Tooth, right? 1, 2, 3 and 4, that's the number given to them. Out of them, type 1 is the most important to be read, and the inverted champagne bottle and onion bulb appearance, don't forget it. Okay. Now, one thing which I had somewhere left in between should have been discussed, regarding the brainstem herniations. It's a very simple concept. Let's try to figure it out. If this is the brain, okay, we have got herniation of the brain. The brain doesn't burst out of the skull. It has to herniate downwards or laterally something. So how does it happen? There are very simple ways to remember this brainstem herniation. Now, so pay attention, leave everything and pay attention to this. Okay, and mother has again come. Kya hua? Mummy returns. Yeah, this one. This one is a part of dural invagination which is known as falx cerebri. Falx cerebri. Falx cerebri. Okay. Yeah, done in surgery. Very good. You will answer me then. Arey wah, kya baat hai. Gambo khush hua. I will not leave this topic. Arey Baba, if I don't do in medicine, you will always remember me only. Sorry, you are not done. I know done in surgery. Padh lo. Now, this is a herniation of a cingulate gyrus which happens below the falx cerebri. Okay. This is known as a term. Number one, I can number this as subfalcine herniation. Subfalcine herniation. Okay. Right. Another herniation which you can imagine this is this. For example, there is an extradural bleed and the brain tries to shift across the midline. How can it shift? There is something here, the uncus part, number 2. Yes. Number 2 herniation of the brain can be like this. It can go medially and it can go downward also, right? So this is known as the uncus herniation. Now, there is another herniation which is straight downwards like this across the foramen magnum. The brain is displaced downwards like this. Number 3. This is across the tent, It's known as a transtentorial herniation. Transtentorial herniation. And something you already know from syringomyelia concept that we have read is this. The cerebellar tonsils. Okay, uncle. That's why I never write uncle, People will write UNCLE, uncle. It's not uncle, it's uncle. Okay. Number 4. Number 4 is your tonsillar herniation that happens through the cerebellar tonsil. Right. Now, someone asked me, sir, tonsils in the neck. No, my dear friend, no. It is a cerebellar tonsillar herniation. Okay. Now, why this topic became important, I want to discuss this uncle. Let us discuss this uncle herniation. Why brainstem herniations are important? Because of this uncle only. Okay. Uncle herniation. Now, if an uncle herniation happens, what happens? Immediately medial to this uncus part of the temporal lobe, there is a structure sitting there known as a midbrain. So when the uncle herniation happens towards the midline, it compresses the midbrain, right? Now, why is it important? Because immediately surrounding the brain is always a skull, and the skull is not going to break easily because it's a bony prominence, it's a bony thing. So when there is a displacement done by the uncus part of the midbrain, initially what will happen? Initially, the crus cerebri part of the midbrain of the opposite side will press itself against the skull and get crushed, Look at this cross now. Yeah, when the uncus herniates towards the midbrain, the opposite crus cerebri will get compressed against the skull. Now, what is something important here? Something which is important is this. The corticospinal which has come from the crus cerebri is going to supply the body of the opposite side. That means the uncal herniation has happened on this side, right? Uncal herniation has happened on this side. Can you tell me the weakness in the patient initially, if I'm talking about, will be seen on which side? Same side of the herniation, ipsilateral, or opposite side of the herniation, contralateral? Any idea about this? Of course, on the same side of herniation, because initially the corticospinals of the opposite side across the skull has been crushed, so it is going to cause ipsilateral weakness. Ipsilateral with a reference to herniation. So if you have a herniation on the right side of the uncus, the weakness is going to initially come on the right side, right? What is this known as? Carnohan-Waltman sign. Some people, I don't know, keep the word notch over here, that's fine, but in Harrison it's known as Carnohan-Waltman sign. That means on the site of the uncal herniation, you will find initially weakness, okay? Carnohan-Waltman sign, and it occurs in uncal herniation most of the time, right? Now someone is asking me what is central. The transtentorial is also known as the central herniation because it is in the central midline, okay? Now what part herniates below the falx cerebri? The part which herniates here is a cingulate gyrus, remember this, right? Okay, I'll repeat. Are you told me you already know this? Uncal herniation, if at all the temporal lobe herniates from the uncus part, it will go towards the midline. It will compress the structure of the brainstem in the upper part, midbrain. Whenever there is displacement of the midbrain by the uncal herniation, initially the corticospinal of the opposite end will be involved, because when the midbrain displaces like this, it is going to press against the skull and the corticospinal of the opposite side will be crushed. That will cause weakness on this side. On which side? Same side of herniation. Uncal herniation happens in the patient on the right side. Weakness will initially happen on the right side. Okay. Right, let's get wiser on these topics by solving MCQs. Cingulate gyrus is likely to be involved in which of the following herniations? Any ideas on this? I just now told you about it. Okay. That is subfalcine or transfalcial herniation. Okay. Answer is C. Carnohan-Waltman sign is related to which type of cerebral herniation? C goes with the subfalcine, the B was the transtentorial, the central, A is the uncal herniation, and D is the tonsillar herniation. Carnohan-Waltman sign is related to which type of cerebral herniation? It is related to this one, A. A means what? The uncal herniation. Uncal herniation. Right? True about Guillain-Barré syndrome is all except. Tell me please. It's inflammatory, that's correct. It's demyelinating is also correct. Plasmapheresis can be done is also correct. Is it descending in any form? No, no, no. It is always found to be ascending. Now remember this, if they ask you any time, what are the causes and differential diagnosis of a descending paralysis or weakness? What are you going to mark? It is B, P and D. The B stands for botulism, polio and diphtheria. This is a very age-old question that you will find everywhere. What are the DDs of a descending paralysis? Okay, it is botulism, polio and diphtheria. There are three differentials for it. Okay. A young man had suddenly developed paraplegia following a short febrile illness, and the patient reveals a lower motor neuron type of paralysis with no sensory disturbance. Which of the following will be found in the CSF of the patient? ACD. Correct. But think about the question, please. How should you approach this one? The patient had paraplegia, that is lower limb weakness, and that was after an infection because the fever was something as a systemic symptom found initially. But look at this. This paraplegia can occur to myelopathy also. Yes. But if it was a case of myelopathy, I agree there can be lower limb weakness, but there is going to be a sensory loss and above all bladder involvement in the patient. Nothing like this happened. So GBS is the most fitting reply for this patient. It cannot be myelopathy. It is more likely to be a post-infectious neuropathy found in patients of GBS in the CSF ACD. All are true regarding GBS except high dose IVIG can be initiated true, plasmapheresis can be done true, high dose IVIG and plasmapheresis are equally effective, that's also true. Corticosteroids are used for early recovery and preventing long stay. No, they are not recommended at all in the patient. In GBS, all of the following are seen except. Tell me, what is not seen in patients of GBS? Areflexia, motor loss, ascending paralysis. No pleocytosis. Only rise of protein occurs, that is albumin in them. Right? GBS will come. This is a topic, Suryavansham. In GBS, all of the following are true except predominant motor involvement, yes. Absence of pleocytosis in CSF, yes. Sparing of the bladder function, yes. Something you can write down in your notes also. Residual disability if the treatment is delayed. Somewhere in books they write sequelae is unaffected by treatment. That means someone of GBS was going to have a problem like a disability lifelong. In spite of a timely treatment, it would be there with the patient. Okay. So the treatment doesn't affect the sequelae part. It will be unaffected by the treatment sequelae. It is bound to, it will has to happen, will happen. Features are not typical of GBS. It's an acute onset, yes. Autoimmune, yes. Many nerves are involved with radicals, yes. Males and females are equally risk. No, no, no. Just a epidemiological fact to add into your notes. This has come recently as a question that it's more frequent in males than females. Okay. Right. There's a criteria, remember this, there's a criteria which is a criteria to diagnose a patient of GBS. Write it down in your notes. The name of the criteria is the Brighton criteria. There's a Brighton criteria to diagnose a patient of Guillain-Barré. Okay. And it includes everything. Everything under the clinical roof and the investigation that I've told you comes under one roof of a Brighton criteria for diagnosis of GBS. Why I'm instilling this name in your mind, because there was an old criteria, Ashbury also. Yes. But nowadays we don't use that one. In fact, I found that one to be very simple. But nowadays we are using a new criteria which includes even the investigative part like albuminocytological dissociation, even the nerve conduction study. That is known as a name Brighton criteria. Immunological attack is initiated in node of Ranvier in which of the following subtype of GBS? Tell me fast. Node of Ranvier, Amsan and Aman type. They were more commonly having this problem, right? Right. Okay. Which of the following statements about GBS is false? Bladder involvement occurs in severe cases. Yes. GD1A antibody are found in patients with Aman type. I've already told you yes. Facial diaparesis. Look at the term facial diaparesis. It means facial weakness. Bilateral element facial nerve palsy is seen. Glucocorticoids are effective in GBS. No, no, no. Totally ineffective. Right? Simple question. See, intentionally I'm discussing a lot of questions on GBS because this is a must know topic and you should be prepared with anything. It can be clinical or theoretical thing. 25-year-old patient with GBS is having a bilateral lower limb weakness with no recovery for the last 4 weeks, even with IV, IgA plasmapheresis. Patient also requires an assisted ventilation. Now look at this. CNS examination shows motor and sensory loss with an axonal damage on the nerve conduction study. Patient is likely to be suffering with which type of GBS? Please tell me. Patient with bilateral lower limb weakness with no recovery for the last 4 weeks. Don't tell me it is CIDP. That will come when the recovery or the progression is there beyond 9 weeks. And look at the question. The nerve conduction study shows motor and sensory loss both. That means I am seeing it as a case of GBS which is not recovering, having worse prognosis. What is that type? Amsan type. Good. Mugambo Khushwa, you know the answer. I'm happy. Very good. So I'll teach more. See, there is no harm in discussing a topic which is very frequently asked in exam. So you should know the mind of the examiner. Okay, can ask you anything. All of the following is true about CIDP. Should be considered in a case of GBS when the weakness deteriorates beyond 4 weeks of onset. None. Beyond 9 weeks. Only motor nerves are involved. No. Nerve biopsy is normal. Onion bulb. Okay. Steroids are recommended in therapy. Yes. Is recommended in patients of CIDP. Levi-Sumner syndrome is Matsom. Option A. Okay. All of the following are true about Charcot-Marie-Tooth disease except. Tell me the answer. It is autosomal dominant, presence with a distal leg weakness, inverted champagne bottle, foot drop. You can write it down also. It is a most common type of hereditary neuropathy. That's a true statement. Nerve biopsy is required. No, it's not always required. Be careful. It's not always required in Charcot-Marie-Tooth. This has come recently. This topic was a dead. They pulled it out from the grave, especially the inverted champagne bottle and the onion ball appearance. Don't forget it. Okay. Now we'll go into the last over. The last over of neurology, not the class. That is something about myopathies. I agree a lot have been done in peds maybe, but a bit of it should be understood in neuromedicine as well. Okay, right. The very first one to read from pediatrics maybe is the Duchenne muscular dystrophy. or the DMD? I don't know. Some people are constantly sitting with a clock in with them. Yeah, Gadi. This is a Pavlov, doggy. They will stop studying when the time comes. I will not study. DMD. Now remember point about DMD, very important, that it is an X-linked. It is an X-linked recessive disease. Now, my dear pathologists and the genetic experts, can you tell me if it is an X-linked recessive, who is affected? Males or females? Tell me please. Good. Males only, right? Someone was writing in the chat box multiple sclerosis. Oh my god, I've already discussed that topic earlier in season 1. Right? Males only. Now it happens due to deficiency of a subsarcolimal protein. Okay, it happens due to a deficiency of a protein, that is a subsarcolimal protein, whose name is dystrophin. Just a bit of understanding what is this dystrophin doing there. Now if I want to see a membrane of the muscle, okay, there are certain proteins which are somewhere in the sarcolimal membrane. The two major ones are, one is the sarcoglycan complex. Yes, so there's a sarcoglycan complex like this. 3 of them I've tried to make. In between the two, like this, there's another complex in the muscle group. This one, okay, all of them between the sarcoglycan are known as the dextroglycan complex. Now what happens below them? Below the sarcoglycan complex, this protein is present, whose name is the dystrophin protein. Now the main aim of such a protein is somewhere to hold the muscle intact. That means it should not break on any muscle tear that we face. Okay. Now remember this. There is a dystrophin gene with us. There is a dystrophin gene with us, with every one of us, to code for this protein. And this gene is located on the X chromosome. The X chromosome, the short arm of the X chromosome. Now in patients of DMD, we find a definite mutation on the short arm of the X chromosome in these patients. Now when there is a mutation on the short arm of the X chromosome, this mutation leads on to deletion at the 5' end of this gene. Now look at this. The short arm of the X chromosome has got a mutation on the dystrophin gene, and that particular mutation is the deletion of the 5' end, the most common deletion here. Now when this gene is mutated, that means it is not going to form the dystrophin protein. So there is a dystrophin protein deficiency in the muscle that is found in them. Now this dystrophin protein is somewhere protecting the above protein. See, if I look at the muscle sarcoglycan and dextroglycan, they have been protected by the dystrophin protein below the sarcolemmal layer. So if this is lost, suddenly any protein which is present above in the above part, the sarcolemmal layer, will also be lost. So there is deficiency of dystrophin protein causing secondary loss of the dystroglycan and the sarcoglycan complex. Now finally what will happen? The muscle will slowly and gradually undergo breakdown, that is necrosis, followed by atrophy. Right? I'll repeat. There is a dystrophin protein which is present below the sarcolemmal layer of the muscle. The sarcolemmal layer of the muscle is made up of two major complexes, the sarcoglycan and the dystroglycan. Now the dystrophin gene which is coding for this protein is located on the short arm of chromosomes X, and the mutation happens on this gene. The 5' end of the gene has got deleted. That means this gene will not develop in this patient, and now suddenly the secondary loss of the dystroglycan as well as sarcoglycan will occur. Okay. Oh, spelling mistakes. Dystroglycan and sarcoglycan will occur, which will cause muscle necrosis and finally atrophy. Why I'm telling this story? Because we can inhibit breakdown and necrosis by giving certain immunosuppressants also, like commonly use your steroids. Okay, that can be a part of therapy in them. Now, when I look at the clinical features in patients of Duchenne muscular dystrophy, remember this disease is present from birth, no doubt, but the usual onset of the disorder in these patients happen in the bracket of 3 to 5 years of age. The usual onset of the disease, usually clinically when I see them, happens in the bracket of 3 to 5 years of age. Why there is a secondary loss? Because when this protein is not there below, it's totally missing. The protein just above it will be commonly exposed to the wear and tear of the muscle, and this protein will also start breaking. Okay. Now onset happens usually in the bracket of 3 to 5 years of age, right? Most of these patients we found had a problem with them as heel cord thickening. I'll show it in an image what does a heel cord thickening actually mean. With a lordotic posture, somewhere at around 6 years of age. Okay, the heel cord, if you know, the tendo Achilles has got shortened in them, so they just keep on walking on their toes most of the time. I'll show you an image later. Just keep on writing. Now, along with this, remember, they start using prosthesis for walking that is known as braces. They use prosthesis like braces for walking somewhere at the age of 8 years. Now, very important thing, most of these patients are found to be wheelchair bound. It's a very commonly asked question by the age of 12 years. Apart from this, first pulmonary infection that they might catch. There's a problem in the ventilatory muscles also, and they catch the pulmonary infection, the first one, in the bracket of 16 to 18 years of age. Right? So this is the timeline, and most of these patients die or the death happens somewhere by 25 years of age. Don't forget, most of these patients, the cause of death that we find is the respiratory failure. The respiratory failure is considered to be a cause of death in these patients. Additional points. Additional points. In these patients, we find there is pseudo hypertrophy that is seen. Pseudo hypertrophy that is seen. Now look at the term. It's not true. It's written as pseudo. Why? Now what happens is there is increase of collagen deposit in some group of muscles in the patient, right? And this will give a muscle a typical bulky appearance. Now follow this line. It's not true hypertrophy, it's a pseudo hypertrophy found in them, because the collagen sits, the muscle is totally necrosed inside and collagen deposits, not the muscle cell that increases. That's why they look bulky. See, any patient who has come to me with a very bulky muscle, I'll think that the muscle has grown inside. No, the muscle has got necrosed inside, but just the collagen got deposited in between the muscle group. Now, where do we find this pseudohypertrophy phenomena? It is found very common in the deltoid muscle group, the calf, the gastrocnemius muscle group, and over the back region, the infraspinatus part, right? So gastrocnemius, deltoid, and infraspinatus are the three group of muscle. Okay, why collagen deposit? No clearly given anywhere. Why it happens? Okay, why pulmonary infection? Because they have got a poor respiratory reserve. Secondly, when the disease progresses, the cuff reflex also, due to poor respiratory muscle function, is very poor in them, so they're very prone to catch infections of the lung. Now people are asking me this, why does the secondary loss of the proteins which are in the sarcolemmal layer being happening? See what happens when there is a dystrophin protein, there is no protection to the muscle proteins which are above it. So it may be due to increased tear or maybe stress of the muscle, which leads on to a secondary loss of this problem. Okay. I'll show you an image, don't worry. This is another very commonly asked question. DMD. I think so this image will explain everything very well. Now look at this child, he's having a lot of problems. First of all, look at his shoulders area, shoulder. They are found to be having a deltoid muscle which is bulky, that is pseudo hypertrophy. Even the calf muscles have been found to be bulky. But on the other end, the lower limb thigh muscles are weak because there is a lot of atrophy which has occurred there. Okay. And there is a heel cord thickening occurring here. Because of this, the patient's heel is going up. They're all the time walking on the toes. And even the lower abdominal muscles are weak. Yes, giving a typical swing back or maybe a lordotic posture. Now look at this child when he's walking, when he's keeping his left leg ahead, his left hip might be falling down, but the right hip might go up. Okay. This kind of a gait, can you describe me? Like I'm walking and I take the right leg ahead and the right hip falls down. In order to prevent the fall, I try to move the trunk in the opposite direction. Can you tell me the gait which I am trying to talk about? That is known as a waddling gait. Okay. Gover sign, the child tries to get up from a squatting position. That is known as a Gover sign. I'll show you the image later on. What is a Gover sign? You'll understand in the image better. the investigation part of this disease. The investigation part in these patients, excuse me if I'm eating something in between, but sometimes my family members are feeling very sympathetic for me that he's taking class since morning. Let us feed him something. Otherwise, he'll not wash our utensils today. Okay. So creatine kinase is increased in these patients. It is almost increased to 20 to 100 times of the normal value. Okay, so the normal value, it jumps up very high, 20 to 100 times. And the muscle biopsy could be a better tool to diagnose this very problem. And in the muscle biopsy, what do we find is deficiency of the dystrophin protein. Maybe if I can check upon this protein by a Western blot technique, I can easily tell the protein is there or not, okay, in muscle biopsy. Apart from this, in muscle biopsy you find necrosis and atrophy, and the parts where you find bulkiness, if you do, you can find collagen deposit or pseudo hypertrophy also. As far as the treatment is concerned for these patients, the treatment is nothing. There is no definitive treatment. So what do we go and do in these patients? We can give them steroids. So steroids can be a treatment for these patients for therapy. Goer sign, I'll show you the image. Actually, it got deleted from my laptop. Okay, I'll show you an image. What do you mean by a Goer sign? You'll understand better then. Where are you going anyway? You are here with me till 9 p.m. A lot of time. Another one is myotonic dystrophy. Myotonic dystrophy. Okay. Before that, I'll do one thing. I just forgot this topic. I should not miss it. This year, something we found in the exam, that they had asked a disease which is known as Becker muscular dystrophy. Right? What is the difference between the two? Is there a difference or they are the same thing? X-linked disease. Just write it down, few points. X-linked disease. Both of them are X-linked. Yes. And they are happening because of the same gene. Yes, the mutation of the dystrophin protein gene can be seen even in Becker's muscular dystrophy. Okay. But who is more common? 10 times more common. DMD. DMD is almost 10 times more common, right? Remember this, the weakness and the wasting in Becker is more seen in the lower limb than the upper limb, okay? The pseudo hypertrophy in these patients, remember this, pseudo hypertrophy in these patients is often found to be early and commonly prominent. Like pseudo hypertrophy in DMD might happen later, but in these patients found to be early and prominent. Now the onset of Becker, remember this, the Becker muscular dystrophy happens because of the same gene like DMD, but the onset in these patients happens in the third and the fourth decade. Although I agree it can happen earlier also, but it usually happens in the third and the fourth decade also. Okay. Mental retardation, MR. Okay, mental retardation is seen in DMD more frequent than Becker. So in DMD, apart from muscle wasting and everything, we find mental retardation also. Cardiac abnormality like cardiomyopathy and problems related to the heart, yes. It is plus minus in DMD, but it is a big plus in Becker's. right? So there is a Becker muscular dystrophy, which is a brother of DMD because of the same gene. Maybe pseudohypertrophy happens in them early, but the onset is comparatively late in them. Okay. Another one which is in the adult population found is myotonic dystrophy. So this year we got a question on Becker's, and that's why I have to teach about DMD, and we got a question on myotonic also. That's why I'm telling examiner has changed his mood. He's digging out the topics from the grave. All these are theoretical ones. Okay. Yeah, same gene as dystrophin. Okay. Myotonic dystrophy. The myotonic dystrophy is the most common adult muscular dystrophy that we find. It's the most common adult muscular dystrophy that we see. Remember this. MR stands for mental retardation, not mitral regurgitation. Okay. Apart from this, it's a disease which is coming down in the family tree in the autosomal dominant trait, autosomal dominant inheritance. It is again a disease which happens due to trinucleotide repeat sequence defect. Correct? Trinucleotide repeat sequence defect. Now the sequence this time is what? CTG. If you remember, Huntington was CAG, the Frederick was GAA, and now the myotonic is CTG. The problem here is on the chromosome number 90, right? This is the last ball of neurology. Don't worry. How much neuro is left? How much we want to read? Clinical features. Clinical features of myotonic dystrophy, very important. Remember this. See, inflammatory myopathy is another topic which has gone into Rumat, and I've asked Srinath. He has told me specifically that I've told that topic, I've taught that topic. Okay, it's more of autoimmune disorder. I don't take it anymore. Weakness in patients with myotonic dystrophy is often more distal than proximal. Remember this. Like in patients of Duchenne muscular dystrophy, we find the weakness is more proximal, while in myotonic dystrophy, it is found to be more distal. Okay. Along with this, these patients have got a very typical symptom, that is myotonia. Myotonia is a symptom in which there is delayed relaxation of the hand grip that we find. Yes. So for example, I tell anyone to shake hand with me, he will catch my hand like this, shake it. But this patient catches my hand, shakes it, and leaves his hand very, very slowly like this. Okay. So if I tell him to hold anything, the moment I remove that object, he is going to leave it. But this patient has got a very slow relaxation of the hand grip seen in them, myotonia. This thing can also be elicited on percussion, like I take a knee hammer and I percuss on this eminence on the hand, and suddenly there can be a percussion myotonia also. That means I tap it and the hand remains there and then it slowly relaxes. Okay. Now in these patients also we find this palatal, pharyngeal and the tongue muscle weakness. Right? Then that problem of tongue muscle, palatal, pharyngeal will often cause what? Dysarthria as a complaint in the patient, as well as it will cause dysphagia in the patient. So these are the two complaints additional in these patients. Also in these patients we find this frontal alopecia, loss of hair in the frontal region is seen in them. Okay. There is a lot of atrophy seen on the temporalis muscle in these patients. Write it down. This has been a question recently. Temporalis muscle has got atrophied in these patients. There's a lot of atrophy on temporalis muscle. You know, I'll show you the photograph of these patients. You'll never forget them. Where have they gone? I Small photos actually. Enlarge this one. Maybe a slightly blurred one, but fine. This is what is given in all our textbooks also. That actually resembles a photograph of all the boys when they join the first MBBS. Take out your license or the I card or the first prof, you'll always look like this only. You know, Bhayaji smile, right? So this is a hatchet face appearance. You know, they've got a very prominent sharp features. Somewhere hidden behind the here is a atrophy of the temporalis muscle. Okay, there is atrophy of the temporalis muscle seen typically in them. That is a hatchet face appearance. Hatchet basically. Oh my God, battery also got low. Hatchet face appearance. So all the boys in the first prof, when they had actually joined the college, yes, they look like this only. They look so innocent, Babre. No one thought of ranking them even. People gave them money also. Garib aadmi. Right. Hatchet face appearance. You join the college as Nawazuddin Siddiqui, you know, and come out as Kabir Singh. So there is a trophy of the temporalis muscle found in them, which gives a very sharp appearance to the facial characteristic. That is known as a hatchet face appearance. Right. In these patients, you also find mental retardation. Girls are laughing at my joke, you know. Sab haso. As well as in these patients, you find testicular atrophy. Testicular atrophy. And I'm very sure half of you would have taken out a license and would have been looking at the photo and it looked like this only. Testicular atrophy, mental retardation is also a symptom in these patients. Okay, just a word on treatment in them. We give them a drug which is known as mixilitine. Mixilitine is advised in these patients for treatment. Okay. That was a drug which was used elsewhere, but they found that it can inhibit the process of myotonia. Okay. Oh, she's coming back again and again. Okay, a patient with DMD starts using braces at what age? If you know this, they start using braces at what age? 3 to 5, 12, 5 to 7 or 8 to 10? Please tell me. Please tell me. Braces that they use is between the age of 8 to 10 years. Okay, good. 18-year-old male with a family history of myopathy has got a distal muscle weakness and a frontal baldness with a hatchet face appearance and myotonia. So this is typical myotonic dystrophy case. It is due to a trinucleotide repeat sequence of the GAA sequence. Yes, true statement. Yeah, I just forgot to tell you this. Is it a GAA sequence? No, it is a CTG sequence. I marked it wrong. Is prone to develop diabetes. I just forgot to tell you. Can be developing but not so common in them. Okay. Okay, sorry, diabetes happens in them. I just forgot to tell you, diabetes happens in these patients. They can have dysphagia and dysarthria. Yes. Mixilitine is used in therapy. Yes. Now he's asking me what is false about the condition. The false is this. It's a trinucleotide repeat sequence due to CTG. Just add into your notes, they got diabetes also. Okay. But picture abhi baki hai. Because since morning everyone is eating my head. Sir, endocrine कब शुरू होगा? When will it start? Okay, we'll do one thing. We'll take a short break. We'll take the last break for the day today. We'll take a short break of 10 minutes. Okay. And then after coming, we'll start the endocrine. Okay. Okay. Cannot imagine? No, endocrine won't complete tomorrow because it's again a very big and a very lengthy kind of a thing in which I have to discuss it. Diabetes already Arvind sir has taught. So diabetes is out of syllabus. Not tomorrow, today. Take a small break, 10 minutes and come back. Okay, I'll teach you only interesting things. Nothing to bore you guys. Okay. Start with something new to read and understand, that is endocrine. Okay. So there is a lot of life left in all of us, and something important in life is always a hormone for us, right? So we have got a hormone as a substance which basically means to set into motion. That is the literal meaning of the word hormone. So in life or the zindagi, if you want to live, you require a hormone to set it into a complete motion. Okay. Now there are various hormones being produced by the glands, which is the endocrine glands in our body. A lot of them. I'll start with the pituitary first. Okay. In the pituitary, we have got the anterior pituitary that has got a very important hormone in females that is required for lactation, that is the prolactin hormone, PRL. Don't ask me again for the abbreviated terms. PRL will use it standard for prolactin hormone. Now if you know, this hormone prolactin is produced by the anterior pituitary gland, and the group of cells which are going to produce it in the anterior pituitary are the lactotroph cells. The lactotroph cells are there in the pituitary gland which are going to produce this hormone prolactin. Okay. Now we need to look at the function. We need to look at the function of this hormone prolactin. As the name suggests, it's always prolactation. So first foremost thing it tried to do is to induce and maintain the process of milk production in the breast tissue that we know as the lactation, right? Audio is there or not? No audio? Okay, audio is there. Second thing, remember this, the prolactin hormone behaves like a weak gonadotrophin kind of an action. It has got a weak gonadotrophin kind of an action. That means if it starts behaving like a gonadotroph hormone, that means it will try to suppress something above. What is that? A hormone that is required for the production of the gonadotrophs. Yes, the name is GnRH. Remember this. Prolactin behaves like a weak gonadotroph, and if the prolactin increases, it can inhibit the production of the hormone GnRH. Now, if the GnRH production has come down, yes, one thing which will fall down very often is the LH surge. Okay, I'll come to that later on. But one thing is clear, if the gonadotrophin production is not at all good in these patients, later on the bleeding phase of the menstrual cycle will not happen. So it is going to inhibit the process of the bleeding phase of the menstrual cycle known as the menstruation. Now that's the connecting link between the two. When a female is lactating postpartum, okay, and she's producing a good amount of milk in the breast, at the same time you'll find the patient not to be having any menses. We often name this as the word lactational amenorrhea. Okay, there are a lot of things, will come to them individually, what can be the other problems related to it. So one thing is very clear from this kind of a discussion, that prolactin hormone is required in females when they are supposed to breastfeed the child. Not all the time. Got it? So God is great. God has given me a big boss of all the endocrine glands. You must be knowing this as hypothalamus. Now this hypothalamus is connected to the gland pituitary through a narrow thing which is known as the pituitary stalk. Now if you know this, prolactin is being produced by the lactotroph cells of the anterior pituitary, but these lactotroph cells all the time are under the inhibitory control of a molecule that is known as DA. DA stands for dopamine. Okay. Now understand this, hypothalamus controls the anterior pituitary gland lactotroph cells in a way inhibitory. So dopamine is coming down from hypothalamus, reaching there to inhibit the prolactin production, to keep it all the time under check. Now there is a name of this pathway. I might have told you in the previous classes also that this pathway which governs the inhibition of the prolactin release and formation from the anterior pituitary has got a name, tubulo-infundibular pathway, right? Because we got a lot of things. If you remember, we have discussed this also in Parkinsonism chapter, that the dopamine formation happened in the midbrain, in the substantia nigra part that is connected to the striatum above. So we know this as what? Nigrostriatal pathway. Nigrostriatal pathway. And if I block this pathway, or if I degenerate this pathway, we end up having what? Parkinsonism or bradykinetic disorder. Well, this time it is a tubulo-infundibular pathway. Okay. Now we'll go into the disease directly, and then we'll understand the basics and pharmacology, or not pharmacology, but maybe more physiology of a prolactin then. Now, if I come across a patient who has got a high prolactin level, or known as a hyperprolactinemia, what can be the basic cause or etiology for this disease? The very first that we find is something quite normal in life, known as the physiological cause. Now, it's not a pathological, it's something quite normal in life, known as a word physiological. Okay. Now, when I look at the physiological cause, just a second, we find in the patient there are some things which are quite normal in the patient all the time. Okay. Physiological. One thing which is known as a cause of increased prolactin, that is lactation. So when a female is lacting, her prolactin is rising up. Second important thing we should never forget, pregnancy again increases the prolactin. But why? Because in females there's a hormone being produced which is known as the estrogen. Estrogen happen to stimulate the lactotroph cells in the anterior pituitary. So if I know this, the estrogen rises, the prolactin will also push up. Okay, so that can be one reason. Maybe in pregnancy the rise of prolactin happens due to lactotroph cell growth, which is being monitored by the estrogen effect. Now there is a lactotroph hyperplasia which is seen in these patients. So there is a lactotroph hyperplasia under the effect of estrogen in these patients in whom the prolactin is going to rise, right? Now, something about pregnancy, you should know this fact that prolactin will rise in pregnancy. But what happens post pregnancy now? Post pregnancy in 14 days time, postpartum 14 days, the serum prolactin, yes, will go back to the normal amount or the normal level. It will not be high anymore. Now that's a problem. Female postpartum has to lactate for a very long time, correct? Now this time postpartum, her prolactin has gone down to normal. Now what is a stimulus for more and more milk production? What is a stimulus for more and more milk production? Okay. See, pregnancy progesterone is more than estrogen. I agree with your thought. But actually, there is some estrogenic stimulation all the time, especially in pregnancy. They found the amount is less, but the stimulation of the cells inside the pituitary anterior increases in pregnancy. That is one reason they said for rise of prolactin. Good. The next thing which we can understand is this: nipple stimulation. Yes. Why? Because when the child is feeding from the breast, the child knows how to do breastfeeding because they've got an innate sucking reflex with them. Now you place the breast on the lateral margin of the lip of the child, is going to catch it orally. That is a primitive reflex, sucking reflex. Now that sucking reflex is going to increase the prolactin further through nipple stimulation. But remember this, the prolactin will rise for next half an hour to 45 minutes only. That means after this 45 minutes time, the serum prolactin will again back to normal. So there can be a surge in prolactin half an hour to 45 minutes after a nipple stimulation. Now I'll talk a clinical aspect on this. A very common experience in your gynac posting you will get maybe in follow-up, that the mother after delivering the child has gone home and due to some social reason she could not breastfeed the child, and now after a month she comes and tells you that she is no more producing any milk. Yes, that we label as a word lactational failure. Okay, but why has it really happened? It has happened because of this, because more and more nipple stimulation is going to increase the prolactin, because if the nipple stimulation won't happen, the prolactin will bounce back to normal, because this time round the clock dopamine is trying to suppress the formation and release of prolactin from the lactotroph cells, right? So now important thing here is that another thing which can increase the prolactin is sleep. During sleep the prolactin increases. Now the controversy comes in, which type or which pattern of sleep. In Harrison they write REM, but in higher endocrine books and physio books they often mention the NREM sleep. All these are, I found, as a mammal studies. It might be different by a different author, but the most of the authorities do believe in the NREM sleep. The prolactin often rises. This is one cause which I understand as a word physiological cause. Okay. Yeah, people are asking me, sir, I attended your previous class before lockdown. Oh my God. Before COVID and after COVID. Should I attend? Yeah, we should attend, because people who have attended my neuro class also last year or before lockdown, ask them in neurology how much add-on things I have given them. Okay. Because I always label this as season 2, not season 1. So there's always going to be something additional coming out of me. Now, another cause that we understand could be a systemic disorder. And 2 minutes of silence for people who are sitting with the photocopy notes with them. They must be wondering in neurology, in photocopy notes, they have been cheated by the publisher maybe. Nothing is given what I am teaching there. झूठ बोल रहा था, right? Because a student mailed me this, sir. What you teach in the class is not given in photocopy notes, sir. What is this, sir? I don't have a copyright on them. Systemic disorders. Systemic disorders which can cause increase in prolactin. Okay. One of the systemic disorder, should not forget anytime. Hypothyroidism. Okay, hypothyroidism is one disorder which is a systemic disorder often associated with hyperprolactinemia. But how is it affected? This is a cycle that you need to remember and understand. You'll never forget it. It's very simple. Hypothyroid T3 and T4, the primary hormones of the thyroid gland being produced, are in a lesser amount. Correct? We know this fact. Now, as a part of a positive feedback cycle, what would increase in them? The TSH would go up in them. Okay. But to improve the TSH, what is a stimulant now? That is something from the hypothalamus, that is the TRH. Okay. So this is what we see, that TRH is always supporting the production of TSH, which is rising because the T3 and T4 is going down. It's all a cycle of a positive feedback that we know, right? Okay. Now TRH doesn't stimulate only the cells which are there inside the pituitary for producing TSH, that is known as a thyrotrophs. The TRH often happens to stimulate two more cells in the interior pituitary. I call them two brothers from the same mother, the Karan and Arjun, lactotrophs and the somatotrophs. Now, why does it happen is a very simple thing. You might cover here and there about this genetics part also, that the lactotroph and the somatotroph, both of them are having a same precursor gene to be formed. So the precursor gene for formation of lactotroph and somatotroph is the same. PIT1 and the prop1 gene is a same precursor gene for both the cell, lacto and somato. Somewhere in pituitary embryology you read it like this, the anterior pituitary adenohypophysis, the posterior pituitary neurohypophysis. Anterior pituitary is developing from the rat case pouch and the posterior pituitary is developing from the neuroectoderm. But whenever the development happens, there has to be a coding for every cell, and the coding for the lacto and somatotroph is the same precursor gene. Now, since they are from the same genetic makeup, they might be looking to each other same genetically. Now, what happens? The TRH when goes and stimulates, okay, thyrotroph also, write it down. Lactose, somato and thyro. All three of them are derived from the same precursor gene. So now when the TRH goes there, tries to stimulate thyrotroph, on the way meets lacto and somato. They also look the same. They have the same genotype. So the TRH mistakenly stimulates the lactotroph and somatotroph in the patient. Okay. Now what will happen next? If the lactotroph has got stimulated, what will rise? Prolactin. If the somatotroph will be activated, what will rise? Growth hormone, correct? Now understand this way. In a patient, the prolactin is high, okay, and that patient is a hypothyroid patient. What should I treat in this patient? Answer my question. It's a very simple guess. I came across a female especially with a high prolactin, and she has got an untreated hypothyroid disorder also with her. What should I treat in her? Should I treat her high prolactin or should I treat her hypothyroid status? Tell me. We treat her hypothyroid status first, because if I correct her hypothyroid status, her prolactin status will automatically improve. It's all interconnected to each other. Right? Clear concepts. That's why a question came on this topic. If a patient has come to you with a high prolactin, What other hormone estimation should I get done? I should look upon the TSH of the patient. Is it high? Is a hypothyroid status there or not untreated? That may be a cause for this problem. Okay. Now, apart from this, there's one more systemic disease. I'm going to the systemic endocrine, not endocrine, but a systemic disorder proper, that is chronic kidney disease. Chronic kidney disease, also known to me as a term CKD. Right. Now, why will the CKD disorder result in this problem? Because of this. The prolactin is being excreted out or washed out from the body via the renal tissue. Okay. Now, what would happen is this: the kidneys are not working well in CKD patient. So maybe in this patient there is decreased excretion of prolactin happening. The prolactin is not being excreted out in them. So there is going to be a lot of backlog of prolactin created in them. Okay, that is a clear. Some few backs is there. Oh, it's gone blank. Oh, I'm back. I'm back. Don't worry. Oh, again gone. What's happening? Okay, I'm back. I'm back. I'm back. Don't worry. I'm back. I'm back. I'm there. जिंदा हूं मैं. Tiger जिंदा है. Teacher जिंदा है. Don't worry. Tiger is back. Okay. Now, CKD disorder is very important. I'll repeat it again. Chronic kidney disease, CKD, is a disease in the kidney. Now, the prolactin finds its way out from the body from the renal tissue. Now, what happens if the kidneys are not working well? The excretion of prolactin will come down. Because of that, the backlog of prolactin will be very high in the patient. Okay. So, what came as a question like this, in a patient whose serum prolactin is high, correct, we need to assess the kidney function also. So one test you can get done in them very often is a kidney function test, that is urea and creatinine is enough to diagnose any patient with a CKD disorder. Okay. Seizure. Another disease you should never forget is a seizure disease, seizure disorder. They found in a lot of studies that post-ictal, after seizure, the serum prolactin in the patient is going to go up. And this post-ictal timing, when it really goes up, is for at least 30 minutes or half an hour. So for half an hour time post-ictal, we find in a seizure patient, they found to have a high prolactin, correct? Now remember this, I want to mention this term as true seizure disorder, because I have discussed this thing in seizure disorder chapter as well, to differ between pseudo seizure and the true seizure. One hormone which can help me out is serum prolactin, and we need to assess it half an hour post-ictal to find it there. Okay. Now let's look into another category of things which can increase prolactin, that is iatrogenic. Iatrogenic, as the name suggests, is going to be drug induced. Yes, there can be two categories of drugs which can do this. One is a dopaminergic antagonist and the second wala is a dopamine depleter. So if I block the dopamine receptor on the lactotroph cell, so this dopaminergic antagonist is going to block which pathway? It is going to block which pathway? Yes, tubulo-infundibular pathway. Remember this. So tubulo-infundibular pathway is blocked in patients who are taking drugs like dopaminergic antagonist, right? Now, okay, why does prolactin rise post-ictal? In psychiatry books they write like this, seizure disorder actually inhibits the tubulo-infundibular pathway. The tubulo-infundibular pathway again which is traveling down with the dopamine molecule, is blocked by the seizure episode. So seizure is already very short in duration, not more than 5 minutes, otherwise we'll keep it as status. So post-ictal for half an hour, because of the blockage of this pathway, dopamine is not reaching there, the prolactin in the patient will shoot up. Now the dopamine will come back again and stop the prolactin production. Okay. Now dopaminergic antagonist. Yes, we have got our drugs, that is the typical antipsychotics. We know them. Butorphanol group like haloperidol. Yes. But there's one drug which I know as a atypical antipsychotic. Although the atypical walas were not going to block the central dopamine receptor, but we found there is an atypical antipsychotic with us, which can have an effect in females, especially for a high prolactin. Can you name that drug? Can you name me the drug which is a drug which is important? Yes. The name of the drug starts with the alphabet R. Yes, risperidone. Good. Yes. Actually, I forgot the spelling of risperidone. It is RIS. Thank you for reminding. That's why I asked you guys. Is it RIS or RES? You're confusing me now. It's RES. Most of you are writing RES, right? Risperidone. Forgot the spelling. Okay. Now, apart from this, we find another drug which we use to control emesis. That's antiemetic metoclopramide that is used in the patient. Okay. So metoclopramide is a drug which is a dopaminergic antagonist, blocks the central dopamine receptor, prevents nausea and treats emesis very well. Okay. Dopamine depleters, many of them, if you remember, we've discussed them, like your methyl dopa, one of it. Another one is your tetrabenzene that we discussed in Huntington chapter yesterday. Reserpine is a catecholamine reuptake inhibitor. Yes, reserpine. And just to remember, a calcium channel blocker this time, which is a again dopamine depleter that we find is verapamil. Verapamil, a calcium channel blocker. Okay, which is a dopamine depleter effect. It has got a dopamine depleter effect with it. So these are the drugs that we find to cause Parkinsonism very often, the iatrogenic type. Number 4 is another very important cause to know, that is a tumor inside the gland pituitary known as the pituitary adenoma, right? Now pituitary adenoma is just like an intern. He can go to any department and work. If he goes to the department of thyrotrophs, it can produce TSH, can result in hyperthyroidism. He can go to the department of somatotroph, produce growth hormone acromegaly. He can go to the department of corticotrophs, can produce ACTH and Cushing's. But today, this in turn pituitary adenoma is only in the gynae and pediatric department. So it is only in the lactotroph cell prolactinoma. So it only affects the prolactin cells producing, that is lactotroph prolactinoma. Okay. Now the pituitary adenoma prolactinoma is considered to be the most common type of pituitary adenoma. So when I look at the pituitary adenoma, the most common type which happens to be working or functional, like all the interns keep on working in only one department, gynec. So this tumor also works in the prolactin producing tumors. Yes. So most common functional pituitary adenoma is always known to me as a prolactinoma. Okay. Now, be it a pituitary adenoma or be it a prolactinoma, there is a difference between the two. Less than equal to 10 mm in size if you get them, or more than 10 mm in size if you find them. Less than 10 mm in size, we find this as microadenoma. More than 10 mm in size, you find as macroadenoma. My wife just came and asked me, "You're cracking jokes or what?" Micro and macro. Okay. 90% of the pituitary adenomas you find radiologically even or histologically is a microadenoma, and 10% of them are macroadenomas. Okay. Now, remember this also, female to male ratio in a microadenoma is 20 is to 1, while a macroadenoma, yes, the male to female ratio is 1 is to 1. So macroadenoma is equally common in males and females. Okay, while microadenoma is 20 times more common in females than males. Okay, 90% are microadenoma. So please tell me, this is a very easy guess. Prolactinoma as a tumor which is a functional pituitary adenoma will be more frequent in males or females as a disease you expect it to be. It is more frequent in females than males. So prolactinoma is a tumor which is more frequent in females because most of the time they are micro. Micro is 20 times more common in females. So it is more frequent as a disease in females than males. Okay. Now to discuss this disease of hyperprolactinemia, we'll go into the prototype, that is a prolactinoma. Okay. Prolactinoma. Now, prolactinoma as a disease, if I consider the clinical features of it, it could be like this: a simple triad that we find in the patient. In the patient of prolactinoma, when there is excess of prolactin production, there is going to be excess of milk production also. That is known as the term galactorrhea. Galactorrhea is found in nearly 80% of the patients, and it is spontaneous. That means the patient doesn't have to press the breast to excrete out the milk. It is on its own, spontaneous, and it is found in both the breast equally. So milk production is increased in both the breast equally. Okay, and it is spontaneous without manual compression. It will come out on its own, and it is found in 80% of the females with prolactinoma, galactorrhea as a complaint. Along with this, we understand there was something which a prolactin could inhibit, GnRH, and then we find what? Amenorrhea. Amenorrhea. Now, why does amenorrhea happen in them? If at all the prolactin rises, correct, it is going to inhibit the GnRH production because it functions as a weak gonadotroph, one thing. It is going to bring down the LH surge, okay, which can inhibit the menstrual process. And second thing it can also do is to bring down what? Ovulation. So not only the female is having amenorrhea, she is having an ovulatory cycle. That means ovulation is also not occurring at the patient. So please tell me, can you complete the triad for me? If there was galactorrhea, there is amenorrhea, and the cycles are anovulatory, and there is no menses at all, what is the third thing the patient could come to me? Third thing is obviously infertility. Infertility. Right. So this is a triad that we find complete in these patients. Okay. Especially in females when I'm talking about. Obviously the males are not going to have amenorrhea as a complaint. They're out of syllabus for this thing. Galactorrhea as a symptom is not seen in them at all. Infertility, yes, can happen in them. But remember this, the most common presentation of prolactinoma as a disease in females especially is not galactorrhea. Okay, it is always infertility. Okay, Now, in males, what could be the disorder? As I said, that amenorrhea, obviously they're out of syllabus for it, they will not have it. Galactoria, no, the breast mammary glands are not so much developed that it will start secreting milk overnight, even in spite of prolactin. But one thing is clear in these patients, that if the GnRH production is not there in them, they are going to have decrease in the testosterone production. The testosterone production is going to come down, right? Now, the decrease in the testosterone production is going to cause a decrease in spermatogenesis, one thing. Second thing that they might have is a decrease in the sexual drive, which we know as loss of libido. Okay. And obviously, after all this thing, they are going to have what? Infertility. So males also have got a symptom in this triad. They have got infertility with them. Okay. Now, these are all symptoms which we relate to the excess of hormone production. Okay. So the clinical features that I would try to explain here are under the heading of endocrine symptoms due to excess of hormone production. One more thing that I just want to tell you extra here is, if at all the GnRH production is not occurring, the estrogen is also going to fall down. Now, estrogen is very important to hold the calcium onto the bone tissue. Now, if the estrogen in females is low, what are they going to have? A very common bony disease that's known as osteoporosis. Correct? Osteoporosis. Apart from this, which I could learn from the pharmacology books also, they find that high prolactin can cause insulin resistance. Now, once the insulin resistance happens, what are we going to have? Hyperglycemic disorder known as what? Diabetes mellitus. So diabetes is also being documented as an endocrine disorder in these patients, okay, due to insulin resistance which is caused by high prolactin in these patients. Right. So all these are symptoms that we understand through the excess of hormone production in the patient. Now, there is one symptom which could happen due to the growing tumor, right? Now, if I look at this pituitary gland, it is sitting comfortably in a thick bony cage in the skull. That's known as sella turcica, if you remember it. And the common thing that we find when the pituitary has to come out of the cave, the common dimension of the direction it takes is not anterior, posterior, inferior. It's more commonly seen to be as the superior one. Superior extension of the pituitary will compress someone sitting just above it. Who is that someone? That someone is nothing but a person who is collecting the signal from each optic nerve and sending it out into an optic radiation like this. That is optic chiasma. Now, in the optic chiasma, as I see, if at all there is a optic field effect, okay, what kind of an optic field effect are we going to see in the patient? Tell me fast. If there is an optic chiasma compression from below, yes, what kind of optic visual field effect are we going to see? Write this also down fast. I've cross-checked it from your opthal faculty also. Okay. Someone was asking me in between, sir, please tell us about the parietal lobe ocular defect. You did not tell us about that. Okay. Now this one. Bitemporal heminopia. Yes, it's bitemporal heminopia. Just jot it down here. You can go back and write into your neuro notes. If there is a right temporal injury, there is a hymenopia in this dimension, okay, in right and the left eye field. If it is a right parietal injury, it is going to be like this on the same side, homonymous, okay. But if it is a optic chiasma injury, then it is a bitemporal hymenopia. Okay, pie in the sky, pie on the floor. Okay. Parietal is on the floor and the temporal is on the sky, and it is homonymous on the same side. But optic chiasma is bitemporal. That's very clear. Initially, you might have a different kind of a presentation. I agree, but most of them end up with this problem: bitemporal hymenopia. Okay. Yeah, of course, the pituitary stalk is going to get compressed first, but I'm just talking about a visual symptom. Now, this symptom, as you understand, is a compressive symptom because of the tumor growing up. Now, please guide me on this. Please guide me in this. A compressive symptom due to your pituitary adenoma or prolactinoma will be more frequent. I'm asking you, more frequent for a macroadenoma or a microadenoma. Please guide me on this. A compressive symptom of the gland pituitary will be more frequent for a macro or a microadenoma. Obviously, it is on the size, so it is more frequent with a macroadenoma than a microadenoma. Correct. So these are the list of symptoms that you commonly see a prolactinoma patients with. Okay. Now, before we move into how to manage them, let's try to see the prolactin molecule. And when I look at a patient with a serum prolactin, the normal range of it is somewhere 5 to 25 microgram per liter. That is a normal serum prolactin range that we find in females, especially if you want to see them. Now, prolactin in this range is considered to be normal, and there are causes in which the prolactin in the patient rises. So one cause that you find is physiological. Other cause that we find is iatrogenic. Third cause that you find is a prolactinoma. Correct? Now when I look at the physiological cause, it is most of the time the value of prolactin is between 25 to 40. Okay. Iatrogenic is the value of prolactin most of the time between 25 to 100. And most of the prolactinoma, most of them, majority, the prolactin value is above 200. Okay. Now, something that you need to understand this, if a female comes maybe with symptom but her prolactin is between 25 to 40, think it to be due to stress or some other physiological stimulus. Okay. And if she is on a drug that is a dopamine depleter or maybe a dopamine antagonist, her prolactin is more likely to be not exceeding 100. It commonly occurs between 25 to 100. Now there is a guideline to manage these patients. I'm telling you the guideline on this. First of all, in a patient with a high prolactin iatrogenic type, they say to stop the drug for minimum 3 days time and then reassess serum prolactin, okay, after 3 days. In these patients who are having iatrogenic cause, the serum prolactin will always return back to normal on stopping the drug for 72 hours or 3 days time. Correct? Why I'm telling this, because it may be between 25 to 100 and she might be harboring a pituitary adenoma also. We don't know. If in spite of stopping the drug her prolactin is still high, then you go in for investigating it as a case of prolactinoma is there or not. Otherwise, you take it as a case of iatrogenic. Okay. Another question that has been asked is if the tumor is more than 10 mm in size, we label this as macroprolactinoma. In them, the serum prolactin has to be above 250. Okay. Systemic problems are how much prolactin, it's variable. This disease severity will guide it. If it's a very bad hypothyroid, if it's a very bad CKD, the prolactin can go in thousands also. So there is no fixed value for them. Okay, it all depends on the severity of the systemic disorder associated with it. Okay. Now a question came in a great exam that you appear most of the time, that is JIPMER. Be careful when you go there, because they're going to find a line in Harrison in a corner and going to make a big messy MCQ around it. Now, a question that came in JIPMER was this: macroprolactinemia. Okay. And to my surprise, they also repeat the topic, not the question, hook effect. So these are two things which happen in a contrast, macroprolactinemia and the hook effect. Right. Now, what is this story? Oh, few gags, don't worry. Oh, again few gags. Again few gags. Don't worry, I'll come back. I'm there. Now, macroprolactinemia and hook effect. Okay. Now, what do you understand through this? Remember this. In macroprolactinemia, in the patient, there is an antibody excess that is found. First thing. Okay, I'm back. While in hook effect, there is an antigen excess that is found. Just the first difference between them, why does it happen? This happens due to antibody excess and this happens due to an antigen excess. Now, where is this antibody excess? Is it in the titer plate that you're checking the titer with? No. This is in the patient's serum. Sometimes it happens in the serum, the antibody excess. How does it affect? Let me understand this. Prolactin molecule, is a single molecule like this. If you know, the prolactin molecule is a peptide molecule. It is made up of around 198 amino acids. And it is available to me in a single molecule format, that is monomeric. Around 85% of the prolactin molecules are available in the blood as a single molecule, monomeric, not many together. Now what happens, in my serum there is an antibody against the prolactin molecule. It is a harmless antibody, not going to harm us. But the problem is, this antibody will not only attract one antigen, it is going to attract a lot of antigens now. So look at the configuration now. Normally I should have it as a single molecule monomeric, but clustering occurs across the antibody, and now what molecule am I having? A bigger molecule, polymeric. Now what is the fallacy here? When I go and check the patient's serum prolactin level, it is found to be very, very high. Why it is very, very high? Because when you check the serum prolactin, you put it in a titer plate. So there are antibodies somewhere sitting there to catch it. Now what happened this time? Suddenly the antibody sitting there to catch it found many molecules of prolactin together at this point and this point. So the whole body, whatever prolactin was there got clustered in clumps like this. And now the titer plates which are going to read it as 1, instead of reading it as 1, it reads as 100. Why? Because at one point they catch 100 molecules. another point they catch 100 molecules, another point they catch 100 molecules. So the total count of the prolactin will keep on rising. Serum prolactin in the assay that you do is found to be high. Now the query comes in your mind, sir, if the prolactin is so high, it should cause symptoms also. No, remember this. Polymeric prolactin that you find in the patient is found to be bioinactive. Look at the name, bioinactive, in the sense physiologically inactive. It cannot go and act on the breast, neither it can act on the gonads now. It is physiologically inactive hormone which is there present in clumps, and when I check it in the serum assay, the prolactin is found to be very high because instead of one molecule we try to catch 100 together. Now can you tell me, if I am trying to tell you the story, this serum prolactin increase is true or false? True or false? Tell me please. Is this serum prolactin high, true or false? This antibody formation is not clearly given in any of the literature. Okay, that why it is forming, it's some idiopathic reason. Yes, false high prolactin, false high prolactin. Okay, pseudo high or false high. So that means, look at the name, macroprolactinemia. See, that's why. Why did we get it done? I'll tell you the story. Patient was not having any symptoms of high prolactin. On top of it, in imaging like MRI, we did not find any prolactinoma in the patient. But when we checked the serum prolactin as a routine investigation, we found in the patient the serum prolactin was very, very high. Got it? It is just a routine investigation in the patient. We found the prolactin was very, very high. Now, why do we name this as macroprolactinemia? Look at this, please. Prolactinemia means increase in prolactin level. Yes. Macro. Why did the word macro come here? Because the size of the prolactin molecule increased. Okay. So this is very simple. There is no tumor, there is no symptom, but the patient presents to me with a high serum prolactin, false high macroprolactinemia. See, the antibodies are not going to destroy every antigen. It tries to carry with itself. And now when we try to catch it in a assay plate, it catches all them together. Okay. It doesn't decrease prolactin. Okay. It tries to catch all of them together, and then in an assay titer plate, we find it to be high. Okay. Now, how do you try to find them? You know, if at all you have this thing in mind, yeah, it's an incidental finding, that's why. Now, how do you find them? There is a special technique that we do is PEG, polyethylene glycol, okay, chromatography. That is a chromatography technique, PEG chromatography, in which you can find these molecules of macroprolactin. So you need a special type of a chromatography to precipitate them. Okay. No, the antibodies are not going to destroy the antigen so well. It keeps on carrying it in the blood. And now suddenly when I check it in the blood, I find it high. Okay. On the other end, hook effect is just the opposite of it. You know what happened this time? There were antibodies in the titer plate. Okay. Which were there to assess the hormone level. Correct? And I got antigens. That is a prolactin molecule. Correct? Like this. So what do you understand? The patient's serum prolactin or the prolactin level in the patient is excess. In excess it is very, very high. But there are not sufficient antibodies in the titer plate to catch them. That means the titer plate to catch these antigens has already got saturated. Look at this please. There is an antigen excess now. There is a prolactin which is in a larger amount with me. When I check it in the serum assay, the prolactin has to precipitate somewhere. It will precipitate on an antibody this time. Now what will happen this time? If the titer plate is being saturated by one molecule, see, this will catch one, this will catch one, and this will catch one. What about the rest of the people? They won't be caught. So tell me, the prolactin level in the patient actually in the blood is very, very high. But when I check it in the serum assay, due to high antigen and a lesser antibody in the titer plate which have got saturated, tell me, what should be the serum prolactin like? Please tell me. It's a very simple thing. We try to have an antigen which is in excess now, and we don't have that many antibodies in the titer plate to catch it. What should be the final serum reading? Should it be as high it is that is there actually in the blood, or it is normal? Yes, normal. What should I tell this as? True normal, false normal? False normal. Hook effect. Not high. False low, okay, you can write false low also. False low in the sense that it is normal, false normal means the same actually. So this is known as a hook effect. When there is a lot of serum prolactin in the patient, that means, look at this now, I'll write it again. Patient has got symptoms of hyperprolactinemia, one thing. She's got amenorrhea, galactorrhea, infertility, everything. On top of it, the patient has got a tumor to produce so much of prolactin. Prolactinoma is already there. Okay? But the serum prolactin is found to be normal. False normal. Because the titer that plate that is going to catch the molecule is already saturated. Okay, now what should I do? Can you guide me on this? If you read in path, if such a situation comes to you, what should I do? I should repeat the test. By what? Can you guide me? You guys know it from path. If a patient comes to me with symptoms of prolactinoma, with prolactinoma tumor, and I find in the serum assay the report comes out to be normal. Yes, good. Serial dilution. Why serial dilution? If I dilute, not a PCR. PCR. It's not a virology study. Dilution. If you dilute it, you will take out a lot of antigens. Okay, unnecessarily saturation of the titer plate won't happen. Hook effect. False normal or a false low prolactin in a patient who is symptomatic for a tumor and has got everything. And a false high in an asymptomatic patient is macroprolactinemia. See, normal in the sense that it is supposed to catch 5 or 25 molecules. It will catch only that much, saturate. It will not go and catch everyone. That may be a kind of a lab error that we have done. Okay, not taken a good titer plate. I'll just quickly repeat, I'll just quickly recap this. Macroprolactinemia and hook effect are the two spectrums. In macroprolactinemia, there is an antibody excess. We try to catch a lot of antigens together in a clump, and now suddenly what will happen? The serum assay will go up, because instead of one molecule, we catch 100 molecules all together. But the good news is that this 100 molecules together are not physiologically active, they are bioinactive. So they don't create any symptom. There is no source like prolactinoma for them, but the serum assay is very high. In such a case, you should always go and order for a PEG chromatography. In a PEG chromatography, you can easily precipitate these large molecules and confirm the diagnosis. Apart from this, just the opposite is antigen excess. When my serum prolactin is very high and I send it for a serum assay, the titer plates which are there are not going to catch every molecule. Only few of them it will catch. The rest of the molecule will go undetected, right? So there is an antigen excess in the format of prolactin high. Patient is symptom, yes. Symptomatic, yes, and there is a source for this much of prolactin. But if the prolactin goes normal in this patient, we should repeat it by dilution, wash them away. Okay. Yeah, hook effect you can think it as a lab error also. Okay. It usually happens very common. I've seen these patients, if the prolactin is extremely high in 1000, 2000, it would happen like this. Now, how do you manage these patients? How do you manage? Take one full page for this. Take one full page for this. Okay, take one full page for this. For this, we will write a page, like we'll try to make it as a flowchart in a simple manner. Serum prolactin, is the first thing to assess in a patient with a prolactinoma or a symptomatic patient, What was the question in JIPMER? What is macroprolactinemia? And everyone marked that macroprolactinemia is a high prolactin due to a tumor more than 10 mm in size. I told everyone, beta, read it carefully. These are JIPMER people. They are Vinod ke daddy also, so they know it. They will miss it. It's not macroprolactinoma, it's macroprolactinemia. Okay. Now, if the serum prolactin in the patient is found to be above 200, we are going to suspect, yes, a tumor. Tumor suspicion is fine, but the confirmation has to happen through an MRI. MRI of the gland pituitary is going to find me a prolactinoma. But apart from this, we are going to differ it on the size. Less than equal to 10 mm micro and more than 10 mm is a macro. Correct. Now, how to manage these patients is a very simple technique. Hypothalamus is under the control, or not, is trying to control the prolactin release and formation through an inhibitory signal that is known as dopamine, through the tubular-infundibular pathway that we know. Correct. Now, what do we do here is we utilize this funda. Like, we will give my patient with a small size tumor a drug which is a dopaminergic agonist. Right? Now, if you know the dopaminergic agonist, there are two. One is a short-acting congener, bromocriptine. Other one is a long-acting congener, that is your cabergoline. Right? Now, we start the treatment maybe after a span of 1 or 2 months. In the patient, we repeat the serum prolactin. They say if the serum prolactin has gone below 50, all is well. Why all is well? You are able to achieve a hormone level that is okay, is not going to cause too much symptoms. You have to continue the therapy, continue same treatment. Continue same treatment. A quick abbreviated name for that in the OPD prescription paper is CST, Tariq pe Tariq. But kab tak Tariq is important? For at least 2 years time. Now, after 2 years, we find that the serum prolactin has come into a normal range. Okay. And of course, there is no tumor residual inside. We can stop the dopaminergic agonist. Okay. And then reassess serum prolactin. The reassessment can be done not monthly, 6 monthly, yearly, or depending on the symptom if they reoccur. So what do you find here? We don't give a lifelong treatment in a microprolactinoma which is well treated by a dopaminergic agonist. They found in a lot of studies, what happened was that a prolactinoma which was small in size, and you started giving a dopaminergic agonist, it did not only put down the prolactin level, it made the tumor disappear also from the site. So when there is no tumor, there is no rise of prolactin, there is no point giving the drug any further. So this is something as evidence-based medicine we could understand. Okay. So 2 years therapy is more than sufficient for this patient. If the serum prolactin is found to be above 50, then what? Problem is that if the problem is not solved with a medical line of therapy, what are we going to do? We're going to operate and take out the pituitary by doing what? Surgery. Now, what kind of surgery can be done? Think about it. You can cut open the skull, lift up the cap, take out the brain, and pull out the pituitary, which is hiding in a cave. Possibly, you will break down every structure in the brain. Don't do this. The surgery that you already know is, yes, you cross the sphenoidal sinus through an endoscopic gun, and then you locate the pituitary and take it out. Yes, the name is transsphenoidal resection. Transsphenoidal resection, or the TSR. Correct. You know this? Very good. Bogambo Kushwa. Now, macroprolactinoma. Okay. Macroprolactinoma, what should I do? Tell me please. What is your guess on this? If it's a tumor more than 10 mm in size and it is a symptomatic patient, should I operate on them, take out the tumor, or should I give them bromocriptine or cabergoline? Tell me please. No, my dear friend, you don't operate on them. First of all, remember this. You are not only removing a prolactinoma tumor, you are removing the pituitary gland as such. In such a situation, if you remove pituitary, you're removing the lifeline, you're removing the ACTH, cortisol, maybe FSH, LH, and a lot of gonadotropes hormone. So remember this, remember this. This has been found, whatever size of the tumor, especially prolactinomas, they are well responding to the medical line of therapy. So macroadenoma, yes, you give them dopaminergic agonist. Correct. And now MRI has to be done at 4 months time. And then you look upon the size of the gland pituitary. If the size has reduced, then we continue the same therapy, CST, maybe lifelong. Why lifelong? Because we found that these tumors might relapse, they may not get back to a normal level of hormone also and size. Okay. If the size of the tumor is found to be unchanged, then in that case you operate upon it by doing what? Transsphenoidal resection. Moral of the story. The moral of the story is micro or macroadenoma, whatever. The treatment of choice is always going to be medical. Correct? Now, if I want to start a medical therapy, can you guys guide me on this? What should I give it to the patient? Bromocriptine or cabergoline? Please tell me. Bromocriptine or a cabergoline? If you have any idea on the dopamine agonist therapy in pharmac and gynec, also you read it. Which is a better one? It's a long-acting congener, more convenient for the patient and less toxic in the reference to dopaminergic side effects. Yes, cabergoline. Someone is asking me long-term therapy will cause hallucinations and all. No. Especially with cabergoline, the side effect profile is very low. Okay. Now, can you guide me? If the vision is poor, that means there is a tumor whose prolactin is high and there is a bitemporal hemianopia in the patient C. Can you guys guide me on this? That what should I do? Should I go for a medical therapy or should I go for a surgery? People do tell me, sir, I'm going to operate and take out the tumor. if the vision is compromised because it's compressing the optic chiasma. Okay, good. People are doing surgery. Very good. You know what happened? You took out the pituitary. Not only the pituitary, the optic chiasma also came out. So, pre-operative it was bitemporal, and post-operative, where is my doctor? Andhadhun, he will come and kill you then. Okay, so don't worry, all is well here also. Even with a visual defect, the first line of therapy is seen as always a medical line of management. And if they don't respond, then you go in for a surgery. I remember this case, can never forget it. A female came into my OPD. She complained of amenorrhea and some amount of galactoria as a complaint. Don't write it, I'm just telling you as a reference. And her serum prolactin, was found to be somewhere in the range of 200. And then we went ahead and did an MRI on her. MRI showed pituitary hyperplasia. And the radiologist on the other end very politely wrote please correlate clinically, the line. Yes. So we were great in that work. We were born for this only. So we started her on a dopamine agonist. Correct, don't write it, I'm just telling you as a reference. Now, to my surprise, I thought it's a prolactinoma most likely. To my surprise, after 1 month of therapy with a dopamine agonist, her serum prolactin increased to 250. Then I told her that we are not able to successfully treat you, so we should go in for a surgery, the transsphenoidal dissection. Right? Now, what happened was I told her that surgical risk and everything. She told me, I'll do one thing. I said, what? I'll take second opinion. I said, fine. Go and take second opinion. That's your choice. After a month time, I found the same patient standing outside the gynec OPD. I went and asked the patient, how are you? She said, I'm having the symptoms there. Then I asked her, did you get the surgery done? She said, it is not required. Then I told her that please come to our OPD and show us. Then she very bluntly replied, you are also not required. I said, what happened? She said, one day I was having a lot of vomiting and retching. And she got an ultrasound done from outside, which has written a line like this, live intrauterine 2 to 3 months pregnancy. Please correlate clinically. First day, first show, when she came into our OPD, she was having pregnancy. Amenorrhea and some galactoria can happen in pregnancy. But some of our resident doctors sitting there might have read this chapter in morning and got the serum prolactin done. Common sense, you could have done a urine pregnancy test to diagnose pregnancy at that point. Or in Hindi movies or Telugu blockbusters that you watch, you check the pulse of the patient and tell her that she is pregnant. Ab maa banne wali hai. Pulsus gravidarum. So please write a thesis on this. Something which I could now understand. What the mind does not know, the eyes will never find it. Correct? Something that we missed in the patient was pregnancy. That could be a cause for high prolactin in her. And of course the symptom that she was coming to us. Correct? Now the clinical problem is this. See, try to learn pulsus gravidarum. We'll give you Nobel Prize for that one day. Okay. Now, how to manage a patient of prolactinoma during pregnancy? This is a very important thing and a small topic, but a very important thing. How to manage a patient of prolactinoma during pregnancy? First of all, a female, who has come to you with prolactinoma. and this female is on a dopamine agonist, correct? So the female is on a dopamine agonist and she is a known case of prolactinoma. What should I tell her? She has come to you with infertility as a complaint and she wants to conceive now because the cycles are normal. First of all, they say allow her to have 3 normal cycles. And after 3 normal cycles, stop the dopamine agonist. Why? One reason they say teratogenic can affect the fetus during pregnancy. Dopaminergic agonist. So why to take a risk? Stop it. After stopping the drug, which is can be teratogenic but is required for managing this patient, what should I do? Stopping the drug, we can allow her to conceive pregnancy. Now the biggest challenge is to assess such a patient. That during pregnancy, how do I assess her? First thing, kindly tell me, should I assess her by getting her serum prolactin done? Please tell me. A big no. Just not from my clinical experience that you learned that the serum prolactin rises exponentially in pregnancy. Okay, so serum prolactin is not at all a good guide to assess the females in pregnancy because it's a physiological rise that you come across with. Yeah, it can go till 1000 also. It can go till 1000 also, right? So what do I assess? I will assess her clinically. Clinical assessment. How? Is she complaining of increased in size of the pituitary? She's complaining of headache, one, or she's complaining of a visual problem. Like the tumor, maybe after stopping the treatment, would have gone from a size of 2 mm to 20 mm, which is a macro. It will go and compress the neighboring structure, causing headache as well as a bitemporal heminopia. Now what do I do? If she's having this complaint, don't panic. Start her on a dopamine agonist. This time we're going to use a shorter acting version, that is your bromocriptine, right? Now once we give a bromocriptine drug to her, she might respond. She will respond most of the time. See, why bromocriptine this time? Because the studies which we have with us, collected studies, most of them are based on bromocriptine use in pregnancy, and they found that bromocriptine has been a very old drug which has been not very teratogenic, but it's always better to stop it before conceiving. Okay, now the problem is if she doesn't respond. Most important, if the female pregnant not on treatment started on treatment of bromocriptine and she doesn't respond, then what should I do? Then I go for my surgery to remove the gland pituitary. What is that? Transsphenoidal resection, TSR. Okay, but don't worry, all is well. Why? Because all these problems like headache and visual problems in pregnancy, even off treatment, have been documented very rarely. So I'll write it down like this: prolactinoma in pregnancy is asymptomatic. Get my line clear? Prolactinoma during pregnancy is asymptomatic. Why the word asymptomatic? Because it won't increase in size. It will not cause any compressive symptom. Secondly, it might cause amenorrhea that's already there in the pregnancy. I'll come to you the things like what should be used in a fertile female. I'll come to that. Okay. Now I'll just write down in a very simple way. Drug of choice. Drug of choice. If they ask you drug of choice for prolactinoma, remember this. It is nothing but your cabergoline. Cabergoline. Always cabergoline. Why cabergoline? Cabergoline is this, is a drug which is considered to be a long-acting congener. It is having lesser side effects. Any of the effect of dopamine agonist can cause nausea, vomiting, even psychiatric symptoms. The lesser side effects are seen with them. And the third most important, they found out it was having a better effect to control the disease. So lesser side effect, better effect, more convenient for the patient to take in. There's always a cabergoline. If you prescribe cabergoline in pregnancy, yeah, I'll come to that also. But cabergoline as such, if you prescribe in OPD, is going just a tablet or two in a week. It's a long-acting drug. Okay. Drug of choice for prolactinoma in pregnancy. Please tell me. If this question comes to you, what is drug of choice of prolactinoma in pregnancy? How to differentiate headache? Are there pre-eclampsia? You will have high BP now. क्या करते हो? Pre-eclampsia, you will have high BP. Headache is because of that. In pregnancy, what should be a drug of choice for managing a female with this problem? Bromocriptine. Just a reason given in the book is that the safety data which we have of this drug is much better compared to cabergoline. Now this is a concept that you need to understand through this. If they ask for you that high prolactin in a fertile female, okay, don't write in, otherwise you will make her infertile. Already my grammar is so bad. In a fertile female who can conceive in any cycle, and she has not come to you with infertility, and she has got no amenorrhea as such as a complaint, she just come to you with a galactoria complaint maybe, and her prolactin is high. What is a drug that you can give to her? Should I give her bromocriptine or cabergoline? Tell me. It is bromocriptine, because if she conceives in the next cycle and she's on a cabergoline therapy, then in that case you can be in a problem. If she takes the medicine and conceives, it can cause teratogenicity. Why to put her into so much of stress? That will cause a lot of stress for you also. Put her on a safer drug now, bromocriptine, things will settle. But a student came and asked me another doubt. Sir, what is a drug of choice for high prolactin in a male? He asked me like this only, sir, fertile male, sir. Just imagine this. Answer me. High prolactin or maybe a prolactinoma also. Okay. In a fertile male. Thank God, cabergoline, very good. Because one student told me, sir, bromocriptine. I said, why? Sir, it is less teratogenic. No, you only told me. Arey yaar. First we should read biology, then we should come to medicine. Okay. कहते हैं ना, बेटा तुमसे नहीं हो पाएगा. Another interesting and a funny hormone, the last ball of the match today, is the growth hormone. Right? Growth hormone. Now, the growth hormone is being produced by the gland pituitary, the anterior pituitary gland, yes. And the group of cells in the anterior pituitary which happen to produce it is somatotroph cells. Just a question from physiology that we find, okay, is this: the most abundant cells in the anterior pituitary gland are known as the somatotroph cell. They are the most abundant, right? Now, when I look at the cell lineage inside the pituitary, especially the anterior one, somatotrophs happen to be the most abundant, followed in the list by the lactotrophs, followed in the list by the gonadotrophs. So roughly, if I can just write it, around 50% of the cells are somatotrophs. Lactotroph is somewhere 20 to 30%, and the gonadovala is somewhere 10 to 20%. Right? So if they don't ask you somato and give you an option like somato, you can mark it as lacto. 5 minutes break, don't worry, I'll leave you 5 minutes early if you don't take a break. Now, growth hormone. Why 3 cycles in menstrual cycle? See, she has been a female of infertility, and that was anovulatory cycles with amenorrhea, of course. So if she has a 3 normal cycles, at least she will have a healthy endometrium to implant the embryo well, and she will always have a good ovulation for fertilization also. Okay. Growth hormone. Growth hormone is one thing which is under the effect of various other things. But remember this, the growth hormone is being produced by the somatotroph cells, and there are a lot of things which supports the production of growth hormone. The growth hormone is stimulated by the hypothalamus by an hormone known as growth hormone releasing hormone, GHRH. So that is produced by the big boss hypothalamus, growth hormone releasing hormone from the hypothalamus. Another thing which happens to have an effect on growth hormone is the somatostatin. Remember this. Somatostatin is stopping the somatotroph cells, right? Now, where are these somatostatin produced? One, hypothalamus. This was a physiology question last year, that hypothalamus produces stimulatory as well as inhibitory hormone for growth hormone. Stimulatory in the form of GHRH and inhibitory in the form of somatostatin. Another cell that is in the GI tract is the delta cell of pancreas, which produces somatostatin. Okay. Now, there is another stimulatory factor for the growth hormone production. Okay. That could be a hormone being produced in the gastric mucosa lining known as a ghrelin. Okay. Ghrelin is a hormone which is a gastric derived peptide. Remember this, it's a gastric derived peptide. It is derived from the gastric mucosa. Okay. And the main action of ghrelin as a hormone on us is two. One, it increases the appetite. One. Second, it also increases the gastric motility. So when you feel hungry, your motility of the intestine is good, you will keep on eating a lot of food. So the sleeve gastrostomy and all these operations which are a part of bariatric is to just remove a ghrelin production in our body so that we don't eat more and we have a satiety also, because motility is less and we keep on losing weight out of it. Okay. Now, apart from ghrelin, GHRH, another stimulatory effect for the growth hormone comes from fasting. In physiology book, they write that fasting happens to be the most potent stimulatory thing for the growth hormone production, right? Another stimulatory thing that we find is sleep. Somewhere we find at the onset of sleep, the growth hormone picks up. Yes. Another stimulatory thing is exercise. Now, I believe you are in a big trouble right now in the classroom. I know. You are fasting. Correct. Most potent growth hormone stimulator. and on top of it, intermittently, you are at home, you are sleeping also, and under compulsion, you are writing notes also. Exercise. So what is increasing in my class? Your knowledge or your growth hormone? Your growth hormone is rising. That means when the class ends and you come out of your room, you'll be 1 feet taller and your family members will look at you. Acha, you are studying today. Very good. Keep it up. But this won't happen that easily because something is there with me which is going to try to suppress the whole drama. How? If you know this from basic physiology, the growth hormone is going to stimulate some cells in the liver, and in the liver there is going to be production of a substance known as IGF-1, insulin like growth factor 1. Correct? Now when the IGF-1 has an action on the bone and the soft tissue, the final effect will come. So look at this. The growth hormone acts on the target cell, that is the bone and the soft tissue, right? And the IGF-1 also acts on the same tissue, right? But the good news is this: when the IGF-1 rises, it goes and inhibits the growth hormone production in a sort of what? Negative feedback. So in fasting, exercising, and maybe sleep onset, your growth hormone is rising, but at the same time IGF-1 is also rising, and it will go back and push the button on the somatotroph cell to stop the growth hormone production. So all is well. In the classroom, you're not going to gain height. Only one thing you can gain is your knowledge. But there is a good difference, something important. The growth hormone and IGF-1 are acting on the same target cell, but they happen to have a slight difference of action on the final tissue. Okay, let's compare it. First on the carbohydrate, second wala is on the protein, and the third one is on the fat. Carbohydrate, diabetogenic, right? Remember this, the growth hormone increases the blood glucose all the time. Okay, IGF-1 is got the word insulin with it, so it is having an insulin like action. That means it is going to stand as what? Anti-diabetic. Now the protein comes in, anabolic, both of them anabolic. And now the fat comes in. Fat, it is going to break the fat, lipolysis. And IGF-1 on the other spectrum is going to be anti-lipolytic. But why does it happen? I'll explain it in a very simple format. You know, the growth hormone is going to all the time stimulate an enzyme which is sensitive to hormone known as lipase. Lipase, as the name suggests, it is going to break the lipids. Lipolysis. Correct? When lipolysis occurs by the action of lipase enzyme, there is increase of what? The free fatty acid. Whenever there is increase in free fatty acid, that means there is a store of energy created in me. My cell has got free fatty acid. By the beta oxidation, it will generate ketone bodies and give me ATP. Correct? So tell me, if the free fatty acid happens to increase in me, which can convert itself into an energy store, what should happen to the insulin secretion? Apply your mind, it's a very basic biochemistry. Should it increase or decrease? What is insulin doing on the target cell? It is shifting the glucose into the cell. Yes, it is shifting it inside to generate ATP from their energy. But today the cell already has got energy products inside it through free fatty acid. What should happen to the insulin now? If the cell already has got a lot of energy stored through free fatty acid inside it, what should happen to the insulin secretion? Yes, good guess. Insulin secretion should decrease. If the insulin secretion decreases, ultimately my blood glucose level will increase. If the blood glucose increase, you have what? Hyperglycemia or diabetes. It's a diabetogenic hormone, that's why. I'll put everything of growth hormone into a very simple diagram. For example, I'll make a better diagram. Okay, you need not make it actually. Uh, uh, this is me. Okay, this is me in the lockdown. Yeah. So these are my body curves. I've got a family pack, and now my wife keeps on telling me go and do something. She tells me reduce your beer belly over here and do yoga. I said yoga nahi yoga. Then she said okay, gyms are going to open. You join some gym. Okay, I join a gym, and the gym is 2 kilometers away from my residence. So I book a Ola Uber, go there. In the gym, I am so tired that I'll go and sleep. Sleep will increase my growth hormone. I'll come back again home. Again, I'll sleep in a fasting stage. Again, it will increase my growth hormone. And whenever I feel hungry, I'll drink the great legendary green tea. And by the effort of Ola, Uber, and the green tea that I had, maybe in a month span of my efforts of just going to the gym, not doing any training there, I might have a muscular body almost like this, right? So the chingam became a singham like this, right? So this is the effect of growth hormone. Why I'm showing this diagram? Because one thing the growth hormone can easily do is to break down the fat, lipolysis, put up a good amount of protein, anabolic. But the problem is if the growth hormone rises in excess, it is going to give me a sweet gift. What? Diabetes. Remember this protein anabolic effect is not restricted only to the muscle skeletal. It can happen in the heart and everywhere. Okay. Now, remember this, the rise of growth hormone is always seen as a disorder for us. Okay. We see the disorder as per the epiphyseal fusion. As per the epiphyseal fusion. Right? Before the epiphyseal fusion and after the epiphyseal fusion. Before the epiphyseal fusion, yes, we find in the patient gigantism because the epiphyses have infused, the bone length can increase in the patient. We're going to have a very tall personality, gigantism. But after the epiphyseal fusion, the bone length cannot increase, only the digit side increases. That's known as the acromegaly. Okay. Now, when I look at a disease like a gigantism or acromegaly, it's a very easy way to remember the cause for it or the etiology. Remember this way, growth hormone rises, one, or growth hormone releasing hormone rises, two. There can be two kinds of disorders which can cause this very problem, right? Growth hormone rises. The growth hormone production is in the gland pituitary and there is a tumor there in the pituitary. It is known as the pituitary adenoma. It is a tumor inside the somatotroph cell. Okay. Now remember this, the most common cause of acromegaly as such is always a pituitary adenoma. You might ask me in this way, sir, if the growth hormone rises in this patient, the IGF-1 will also pick up? Yes. Now the IGF-1 should stop the growth hormone production through what? The negative feedback. Remember, in pituitary adenoma is a vicious cycle. There is loss of negative feedback seen in them. That means the IGF rises and the growth hormone also rises. So 1 and 1 is not 2, it's 11 now. Okay. So the IGF-1 fails to stop the growth hormone production. There is a loss of negative feedback seen in these patients. Right. Apart from this, there can be a cause for growth hormone production which we see as the word ectopic. Not from the natural pituitary, somewhere else. Whenever you read the word ectopic, remember this. It is always related to a malignancy. This time, remember only one is more than enough. Islet cell carcinoma of pancreas. So islet cell CO of pancreas has been known as an ectopic source for the growth hormone production. Okay. GHRH rises now. GHRH is something that is being produced by the hypothalamus. So there is something wrong in the hypothalamus which we see. Okay, with something wrong in the hypothalamus that we find is known as hypothalamic hematoma, a tumor inside the hypothalamus which will in excess produce GHRH and cause a problem. Another cause like this is of course the ectopic. Now the ectopic cause, as we understand, is through a malignancy again, and that's a bronchial carcinoid as a cause for it. Right. Remember this, when we look at a cause for excess of GHRH production or an ectopic cause for a GHRH production, most of the time the most common cause of GHRH production seen is the bronchial carcinoid, most of the time. Okay. But the most important thing, most common cause of acromegaly as such, whenever you have around 98%, most of them are due to a pituitary adenoma. Okay. Yeah. Gelastic seizure, you read in peds about it separately. Laughing epilepsy. Right. Now let's look into a clinical features of this problem. Clinical features of this problem. Right. Clinical features could be divided systemically depending on the system, like cardiovascular system first. In these patients, don't forget, the cardiovascular system is badly involved because of the soft tissue proliferation. Now, because of this, there is a left ventricular hypertrophy, LVH. That's a very commonly used abbreviation. Along with this, there is also in these patients diastolic dysfunction. As well as in these patients, we find hypertension. Hypertension could also be seen. LVH is seen, diastolic dysfunction is seen. Also in these patients, we have a higher incidence of CAD. Again abbreviation, but a very well known, that is coronary artery disease. Remember this, most common cause of death in acromegalic patient which has been documented is acute myocardial infarction or acute MI. Right? GHRH production from bronchial carcinoid is due to ectopic production of your GHRH there. Respiratory system. In respiratory system, we find in the patient, maybe in the nose, they develop a lot of nasal polyps, one thing. Or they can also develop a problem which has a long-term sequelae that you read in respi very often, obstructive sleep apnea, being abbreviated as a term what? OSA. Why obstructive sleep apnea? If you read in respi, you read it like this. If the pharyngeal diameter, or rather not the diameter, but the pharyngeal muscle mass increases, it is going to compress the neck tissue. And during sleep, the uvula will go back and touch it very often. So while sleeping, the patient will start snoring. Along with snoring, the respiration will stop due to obstruction, okay, for more than 10 seconds, causing hypoxia and all lot of problem in the patient. known as obstructive sleep apnea. GI tract, again important thing. In patients with acromegaly, GI tract is affected, in which we find in the patient increase in the liver and the spleen size, hepatosplenomegaly, right? Apart from this, in these patients, we find colonic polyps and carcinoma. CA stands for carcinoma now. Colonic polyps anytime are frequent, more frequent than CA colon. Polyps are there, but don't worry, it's a benign polyp most of the time. They are not a malignant polyps which are going to transform into carcinoma. They are found to be a benign polyp most of the time. Okay. And most important and the striking feature here is the skeletal. In skeletal features, write it down very carefully, very important. In these patients, we find large digits. The word acromegaly came because of this. That we find this suddenly that the digits are very big in size. Okay, large digits that we know. Along with this, in the patient, on the front region of the head, the frontal region, there is a lot of prominence seen known as frontal bossing. As well as in this patient, the jaw is going to protrude out, known as what? Prognathism, the protrusion of the jaw. How will it affect the patient? Just imagine this is a normal jawline. Okay. In an acromegalic patient, it happens like this. The jaw comes out and it transversely stretches also. Because of this, the dentition will be affected. The lower jaw, that is a mandible, the teeth are crowded like this for everyone. But in this patient, there is a gap which is created between the teeth because you cannot grow the number of teeth. You're going to have 32 only. So because of the increase in the jaw size, the distance between the lower incisors will increase. This is all put together into one term as jaw malocclusion. In jaw malocclusion, what do you find? There is increase of space seen between the lower incisors. Correct? Jaw malocclusion. I'll show you some images related to it. You'll understand them better there. Now first, this is a copy paste I've taken out from Harrison. What in Harrison they have written about these two similar looking brothers, they are twins. That means genotypically they are similar, but phenotypically they are different. And this Swala looks to be normal and this one looks to be very tall. So possibly he has gained a lot of height before the epiphyseal fusion, that is known as a term gigantism. On the other end, the comparison is also in the size of the hand and the feet. So this is a normal brother, hand and the feet, and this is the abnormal brother. Now in the abnormal brother, we find this. Not only a slight increase in the length is seen, but most important, the increase in the breadth of the digit is seen. So in these patients, we find typically large digits. Okay, something in radiology you often write about this topic. That when I look at the digits in a normal person, the terminal phalanx has got a contour like this. Okay, normal contour. But in an acromegalic patient, especially the terminal phalanx looks like this. Can some of you tell me? Yes, in acromegalic patient, the terminal phalanx looks like this. May not be a very good diagram, but tell me, what is this known as? What is this known as? A spade-like digits. Spade-like digit is seen in the patient. The terminal phalanx looks like a spade. Okay. So spade-like digit is seen in the patient. Look at the feet. Look at the feet. The length might have increased, and most important, yes, the breadth has also increased. Something in radio, again, you read these topics. You're going to have increase in the heel pad thickness that you can see on an X-ray, right? This everyone was so excited to see. Dear Khali, you all know him, but phenotypically he's a case clear cut of gigantism because he had a jawline like this coming out, prognathism. Okay, although on his face the frontal bone is not that prominent, but fine, but prognathism is very well visible. And look at his hand, most important. It's not 2.5 किलो का, it's 250 किलो का this time. ये आदमी उठेगा नहीं, उठा लिया जाएगा today, you know. And Khali is a living legend with a serious disease of pituitary adenoma inside his brain. And now what happened was, since his childhood he had the problem, and his height increased, he lost a lot of fat and gained a good amount of protein. But for the last almost few years he stopped playing, you know, because of the metabolic problems that he is having, like diabetes, hypertension and CAD, right? So Khali is a living legend with a serious problem. But someone asked me later on, sir, do you think that Khali is having this mental retardation? Sir, is Khali having mental retardation? I asked why? Why are you asking me this? He said, sir, I saw that Ambuja cement ad. Oh, the way he was walking in the ad and breaking the wall, he looked to be a moron also. And in the end of the ad, he was talking like this. मेरे मौसी ने बताया घर बनवाओ Ambuja cement से ही बनवाना. No, my dear friend, he's not having any mental retardation. Because of the increase in the tongue mass, that is macroglossia in him, he had a difficulty in articulation while speaking. He had a typical hollow voice, right? And also, in these patients, we found in a study, they had a glaucoma in the eye, and when the digit size increases, the wrist size also increases. That causes a lot of problem and traps the nerves, especially in the wrist joint, causing a typical carpal tunnel syndrome, right? So in these patients we find macroglossia, hollow voice, glaucoma and a carpal tunnel syndrome typically, right? So these are some additional points that you find in these patients. Now how do we investigate these patients? A very simple way to investigate them. Investigation. First foremost thing in investigating them is to get the growth hormone assay done. Remember this, you know, a patient of acromegaly-like disorder walks into my OPD, or maybe a person who is extremely tall genetically also walks into my OPD. I get him done this test, growth hormone assay. First of all, he will come to the lab fasting. Secondly, he will go out in the lab, start sleeping, and come to the hospital almost walking. So all the three stimulus are enough to increase the growth hormone physiologically. So the problem with him is going to be like, you know, physiological stress will increase the growth hormone. Yes. So you catch him here. Yes, a very high growth hormone level. You think he is a Khali. Or maybe you catch him here. He looks like a Rajpal Yadav maybe. Okay. So remember this. So getting a growth hormone assay is not a very correct idea in any acromegalic or a gigantism suspected patient. We don't get it done so routinely, right? Second thing is that what is always pulling down the growth hormone to normal? If it kept on going up and up due to physiological stress, we could have resulted in a lot of problems. Something which is an inhibitor all the time, that is somatostatin. Remember this. To maintain the normal basal growth hormone level in anyone, yes, is always a somatostatin. So what should I get done in the patient? IGF-1 assay. If that's high, we come to know about the disease better, because it only increases when there is a disease as such. Okay, so we understand this from our studies that the best screening test that we have got for an acromegalic or a gigantism patient is always an IGF-1 assay. That is considered to be the best screening test. But there's another test. This is known as a growth hormone suppression test. Remember this test. Growth hormone suppression test. What do we do in this test? Listen to me very carefully. The growth hormone is said to be inversely proportional to glucose. Correct? Fasting, what happened? Hypoglycemia occurred. The glucose went down. And now what went up? Growth hormone. Simple. Right? So that's a very typical formula to understand this. Like in your life, I've told you earlier also, there is a formula that you follow. Tension, don't write it down please. Tension is inversely proportional to number of days left for exam. Yes, foundation batch students have this problem. So my exam is 2 years late. I have got more days, so where I'll have less tension. Tomorrow I'll start study. Tomorrow I'll start studying is always constant. Okay, so if you have less days, you have more tension every time. Now remember this. How do you exploit this growth hormone and a glucose formula? We give our patient 75 gram glucose. See, the problem with a foundation batch student is that any foundation student starts studying in a medical college. Everyone will go around him, do parikrama inside the library and ask him, "Bhai, kya kar raha hai? Padhai?" And people will make fun of him and start studying. But the irony is that if you don't study now, you have to study more later on in a very uncomfortable environment, right? 75 gram glucose is given to the patient. Remember this. In a normal subject, what is going to happen? Please tell me. If you give glucose to anyone, inverse relationship, the growth hormone will obviously come down, right? Correct. But in an acromegalic patient who has lost the negative feedback of IGF-1, right? What should happen in them? The growth hormone level is going to remain unchanged. So you give the 75 gram glucose to a patient, the glucose rises and the growth hormone should come down, but in this case the growth hormone remains unchanged, right? So this is a test in which we try to suppress growth hormone, but we are unable to do so. It is known as a confirmatory test. The confirmatory test for diagnosis of this disease is growth hormone suppression test. Number 4. Number 4 is imaging, MRI of the brain. Why? We do MRI of the brain to find or to rule out what? A pituitary adenoma. So to find out the cause for it, you need to do an MRI of the brain, the pituitary adenoma. Yeah, I know your doubt will come now that, sir, if you apply this formula, growth hormone is diabetogenic. That means the growth hormone rises in me, the glucose could come down. See, remember this. It's not the same story in this case. If the growth hormone rises in excess, it is going to cause decrease in the insulin secretion, and that will result in hyperglycemia indirectly. So growth hormone in excess is always giving me a sweet gift, that is diabetes. Remember this. Now, the last part here, the treatment, a small concept. How do you go and treat such patients? Treatment part. First important thing, in these patients, remove the pituitary because they are most of them are having a lot of other problems related to this hormone excess. And the surgery that we advise in them is transsphenoidal resection, being abbreviated to me as a word TSR again. So remember this, treatment of choice TOC, and even the initial therapy in any patient with acromegaly, if I find it, is always a transsphenoidal resection being done, right? But what about the other drugs? The medical line of therapy. The medical therapy could be done with the help of this two kinds of drugs. One is a somatostatin analog, and second drug is a direct growth hormone antagonist. Okay. Now when I have this somatostatin analog as a drug, there are two drugs here. One drug, if you remember, is your octreotide, and the second wala is your lanreotide. Now remember this, octreotide is a drug which is given through the route, subcutaneous route. This has been recently asked in pharmacology, while the lanreotide is given through the route intramuscular. Need not go into side effects of too much and dose and all, just remember this one. Octreotide is given through the subcut route most of the time in these patients, while lanreotide is given through the intramuscular route. How do they work? They are somatostatin analogs. That means they work like somatostatin and suppress the growth hormone production. Okay. The growth hormone antagonist that we have is pegvisomant. Some fugax happen, don't worry, all is well. All is well, all is well, all is well, don't worry. That is pegvisomant. Okay. So this is how we manage these patients of acromegaly. But remember this medical therapy is always written in all the literature as an adjuvant therapy, Okay. Yes, for every patient with a disease, acromegaly, and a documented tumor, yes, is always a surgery being advised for them. Okay, so you have to save the life of the patient. That's the most important thing in acromegalic patient. Okay, right now, questions. I've got questions for every situation. All of the following are known to cause hyperprolactinemia except. थैंक यू नहीं, इधर है, किधर, रुको, मेरी क्लास जो तुम छोड़ के जल्दी जाओगे, बड़ा पछताओगे, बड़ा पछताओगे. पढ़ो ना, पढ़ो ना, पढ़ लो ना, थोड़ा सा और थोड़ा सा पढ़ लो ना. Okay. All of the following are known to cause hyperprolactinemia except, okay, bromocriptine, okay, there's some spelling mistake, methyl dopa, dopamine depleter, phenothiazine, and metoclopramide. All of them are dopaminergic antagonists. One is this bromocriptine, which is a dopamine agonist, is used to treat them. 30-year-old woman presents with secondary amenorrhea for the last 3 years with galactorrhea. The most likely symptoms would be due to what? Remember this. A 30-year-old woman with secondary amenorrhea for the last 3 years and galactorrhea. Remember, this is nothing but a galactoria amenorrhea syndrome, but nothing but prolactinoma. There is a brain tumor that you read in peds also, craniopharyngioma. Could have been that, but remember this, in craniopharyngioma patients, there is more of compressive symptoms. There are more compressive symptoms seen in these patients, right? Okay. 20-year-old woman with on risperidone therapy, that is, it is I, not E, okay? For some disorder psychiatric has come to you with amenorrhea and galactoria and is found to have an elevated prolactin level of 80. What is the next best step in managing this patient? Tell me, please. Please tell me. Prolactin is 80 and she is on a drug which can cause this problem. I've seen most of the students tell me this, sir. They behave like a consultant. They say just change the drug and get rid of the problem. No, my dear friend. The first protocol is to stop the drug and measure the prolactin after 3 days. If it has returned to normal, then you can brand the patient to be having a problem due to this. Otherwise, you over investigate her, find a prolactinoma, that's always better. There is no harm in over investigating such patients. Macroprolactinemia refers to, now this is the name, tumor, macroprolactinemia, not OMA. Refers to what? A large polymeric prolactin molecule. Remember this, it's a very large prolactin polymeric molecule. Okay. Pituitary macroadenoma refers to size of the tumor. What? 1 centimeter is equal to 10 millimeter. That is a priming method for you. The answer is more than 1 centimeter. Simple. Okay. Young woman with amenorrhea, galactoria and bitemporal hemianopia and our MRI shows a tumor of 25 mm in size in the pituitary fossa. The treatment is what? Bromocriptine. Simple, straightforward answer. Even with a visual defect, the answer is always a bromocriptine. Now this one. A 30-year-old female presents with amenorrhea, galactoria and infertility. She has a triad of a prolactinoma tumor. Her pituitary adenoma is 25 mm in size. She is having a tumor which is of a larger size, but to my surprise, her serum prolactin is found to be just 30. What is this? Tell me, please. Slightly high, false normal, or maybe false low, you can call it. What is this now? Hook effect. For finding it out, what do? Dilute the antigen, dilute the blood, okay, take out the excess of antigen and then reassess the patient. Polyethylene glycol chromatography was to be done for a macroprolactin, not for them. Okay. This came quite recently, that's why I'm asking hook effect. 45-year-old female with a microprolactinoma started on a cabergoline therapy. Which of the following is true about her treatment? Microprolactinoma started on a cabergoline therapy. Tell me. Lifelong treatment is required in a microprolactinoma? No. 2 years is sufficient. Monitoring done by MRI in microprolactinoma? No, that is done in macroprolactinoma, not in micro. Single dose can suppress prolactin for 7 days. No, it can suppress prolactin for more than 14 days. Remember this. Echocardiography is performed before starting cabergoline therapy. Can you tell me why? This is from pharmacology. Can you tell me one side effect of dopamine agonist which you might be scared of? They found that the patient was taking a very high dose of cabergoline therapy for Parkinsonism study and they found increased incidence of what? Can you tell me from Pharmac? Fibrosis? Mediastinal fibrosis? Arre babre. Yes, not fibrosis, valvular heart disease. valvular heart disease, the incidence was found to be very high in these patients, especially on a cabergoline therapy in a higher dose. So they found that it's always better to get an echocardiography done before we go in for a therapy with this drug, because if at all, just imagine this, she had a mild mitral regurgitation. You put her on this drug, she will develop what? Severe mitral regurgitation. Correct? So mild MR will go into a stage of severe MR if you give her a dopamine agonist for a very long time. So always rule out any valvular heart lesion in her before starting or instituting this therapy. Simple. True about prolactinoma in pregnancy or all except. Most common tumors in pregnancy and are usually asymptomatic. Am I correct or no? I'm correct. I'm not sure about this line, most common tumors in pregnancy, but yes, in pregnancy they are found to be asymptomatic. That's obviously correct. Increased prolactin level indicate bad prognosis and requires monitoring. Look at this. During pregnancy, they're asking me. No, that's wrong. Rise in prolactin is something which is considered to be a normal physiological thing in pregnancy. Size of the tumor increase in pregnancy. Yes. It's a right statement. It slightly increases, not drastically increases. Remember this. Macroadenoma of 1 centimeter can lead to optic chiasma compression. Yes. This is something which can happen even without pregnancy. It's a correct statement. But remember this. Increased prolactin level of prolactinoma in pregnancy doesn't mean bad prognosis. It might be due to a physiological effect. Size of the tumor, yes, it increases in pregnancy. Yes, but it will not cause much of a symptom in the patient because the increase of the size is found to be very mild. C is the correct answer. 29-year-old woman with pituitary microadenoma on cabergoline 1 mg per week presents with 12 weeks of gestation. Tell me, what are we going to tell her? She is already in the first trimester and she's on a cabergoline therapy. What should I tell her? Advice for termination of pregnancy as a cabergoline was continued during the first trimester. Follow up with her prolactin assay monthly. MRI of the cellar to look at the enlargement of the tumor, or reassure her, evaluate further only if the symptoms like headache and visual disturbances are present. Tell me. Think about it. If she is already on cabergoline, you can stop it, no problem. But don't tell her to terminate pregnancy. It is teratogenic, just follow her up in view of her ultrasound, that is fetal, and then look at if there is some problem, then go ahead with it. Otherwise you can also continue. There is no harm in it. Okay, don't assess her with a prolactin monthly level because this is something that will rise physiologically. It doesn't hold any good. Eight months pregnant female with past history of prolactinoma presents with headache and no visual impairment. Tell me, now she is not on treatment, she is in the last trimester and she came to you with headache with no visual impairment. What should you tell her to manage with? What should you tell her? Induce her and deliver the child because she is nearing term? No. Even with headache? Yes. What do? Start her on a bromocriptine therapy, that is a dopaminergic agonist. Simple. Don't go in for a neurosurgical intervention like transvenous dissection because it will only come into the picture if there is no response on this therapy, but most of them respond very well. Which of the following is not an action of IGF-1? Tell me. Is it lipolytic? I've told you this. No, it is always anti-lipolytic. Insulin-like activity? Yes. Protein anabolic? Yes. Can induce the epiphyseal growth? Yes. Is it lipolytic? No, it's anti-lipolytic. Which of the following sets the basal secretory growth hormone tone? The amount of growth hormone is always under check. Yes, by which one? Somatostatin. Somatostatin. Okay. This is from physiology. I don't know you read that much or not, but you should know this fact. Growth hormone receptor. How will it work? How will it work? By dimerization. Just write this name. JAK-STAT pathway. This was a recent physiology question. There is a JAK-STAT pathway through which it works. In this JAK-STAT pathway, you know what will happen on the membrane when you get growth hormone there on the cell membrane, right? Two receptors will join each other, that is known as dimerization. That means two receptors will join each other and exert their effect through the JAK-STAT pathway. Okay, this is important. You can go back in physiology, read it once. JAK-STAT pathway. It requires dimerization to exert its effect. Which of the following is not a clinical feature of acromegaly? Tell me please. Glaucoma, I told you. Jaw malocclusion, I told you. Goiter. You know, growth hormone stimulates the thyroid follicles. It has got a stimulatory action on thyroid follicles. The thyroid follicles, whenever are stimulated, it can result in goiter formation. Simple. Goiter can happen. Does the brain size increase in them? No. Remember this. Acromegaly increases size of everything except the brain. The brain remains the same. It doesn't increase up in size. Right. All are seen in gigantism except, tell me please. Increase in the organ size like the liver and the spleen. Large foot, yes. Cardiovascular damage, yes. Mental retardation, no. Mental retardation is not seen in them. Confirmatory investigation for acromegaly, clear cut answer, growth hormone suppression test. Okay, which of the following is regarding acromegaly is false? You can just put down one thing into your notes. Most of the patients of acromegaly are not diagnosed for 10 years or more. That means for 10 years time they remain asymptomatic. Yes. If you don't treat them on time, their survival is reduced by 10 years. That's also correct statement. So rule of 10 is not only for pheochromocytoma. It is also seen in acromegalic patient. That means they are asymptomatic for 10 years, and if you don't treat them, they will die 10 years early. Okay. Most common cause of GHRH mediated acromegaly is what? Bronchial carcinoid. I've written that down earlier. Now, soft tissue changes in acromegaly are irreversible. No. Remember this, if you do a transsphenoidal dissection, the soft tissue changes, especially on the hand and the face, they become pretty normal. They are found to be reversible most of the time. Okay, so that's a fact that you need to remember about this. This is false. In a patient with the following facial and the skeletal feature, typical acromegalic face, his IGF-1 is found to be elevated. Growth hormone suppression test shows an elevated growth hormone. MRI reveals a pituitary macroadenoma. The following of the drug in this patient could be given through the intramuscular route. Tell me, which drug medical management in medical management of acromegaly can be used through the intramuscular route? Tell me please. Lanreotide, long acting lanreotide, somatostatin analog. Mugambo खुश हुआ. So Mugambo says takliya. Go back. Nadeba, 3 students kal aana. Morning 9 a.m. sharp. We'll start again. Okay, and don't be a crybaby. Again, I'm going to have a longer session because endocrine is also equally important. Okay, thank you, good night, and my apologies for holding you back so long. If you're not gained knowledge, you have gained a growth hormone.